speakers. The first speaker is Dr. Ayush. He's a junior resident in RP Center. He has received many awards. And next speaker is not present next is Dr. Anand. He's a senior resident in glaucoma services. He has many index publications and awards. Next is Dr. Abhijit Beniwal. He's a senior resident in cornea refractive and ocular oncology. He has also received many awards and is had many international presentations. Next is Dr. Neha Bajpai. She's a Vitreoretina fellow at Karnataka, Bengaluru. Next is Dr. Priyadarshini. She's a senior resident in RP Center in the unit of cornea refractive surgery and ocular oncology. Next, I would like to welcome our judges. Dr. Digvijay Singh is the immediate past president. He is a director of Noble Eye Care, Gurugram. He is a head of the department in Narayana Super Specialty Hospital, Gurugram. He has a special interest in pediatric ophthalmology, strabismus, and neuro-ophthalmology and glaucoma. He holds credits of 20 awards and 75 publications and 20 book chapters. He has delivered over 100 lectures and 8 international and 16 national lectures. He is immediate past president of YOSI, treasurer, and Indian Neuro-Ophthalmologic Society. Next is Dr. Aditi Ghosh. Next judges, we welcome Dr. Aditi Ghosh. she has completed her MBBS from Safdarjung, and she completed a long-term fellowship in cornea services from SN. Presently working as a cornea and ocular surface consultant at Synergy Eye Care, New Delhi. I will welcome our next judge, Dr. Ruchir Tiwari. He is a Vitreoretina and Evia consultant at Tiwari Eye Care Center, Ghaziabad. Okay. He completed a senior residency in subspecialty service of Vitreoretina, Evia, and ROP at Dr. RP Center. His area of interest include vitreoretinal surgery, retinal vascular disorders, ARMD, uveitis, and ROP. Okay, now let's start with the first speaker, Dr. Ayush.
Timing your scientific content, how you respond to the Q&A, answers the clarity and the aesthetics of your slides. All right.
Okay. A very good morning to all present. Today I am here to present our work on the topic Progression to Bilaterality in Unilateral PCG, done at Dr. Rajendra Prasad Center for Ophthalmic Sciences under the guidance of Dr. Shikha Gupta, Professor Vinay Gupta, and Professor Tanuj Dada. So, as we know, the incidence of unilaterality in PCG in the published literature varies from 15 to 35% according to various studies. And these unaffected fellow eyes of these patients are believed to harbor form of frustrae of the same disease. However, this cohort remains poorly characterized in the literature, and there had been no long-term incidence studies to highlight how many of these fellow eyes eventually develop disease in the future. On reviewing published literature, we could find only 2 studies. One done by Dr. Bayomi in 2017, which was a retrospective review of 56 unilateral PCG patients, in which they found that these normal fellow eyes differed significantly when compared to healthy controls in terms of IOP and cup disc ratio. And in another one done by Dr. Zia, which was another retrospective study of 7 unilateral PCG patients over 17.8 years, they found that none of these 7 patients eventually developed disease in the fellow eye. So, to address this lacuna in literature, we aim to identify the incidence of rise in IOP in the fellow eyes of these unilateral PCG patients, and as secondary objectives, we aim to identify any possible risk factors for the development of disease and to correlate these with the ASOCT findings. Unilateral PCG patients with a minimum follow-up duration of 5 years in our glaucoma clinic and who met the predefined inclusion and exclusion criteria were called for follow-up examination in which the clinical parameters were assessed. And in this study, we defined the progression to bilateral disease as increase in the IOP to more than 21 millimeters of mercury, either without an associated increased cup disc ratio, which was termed ocular hypertension, or with an increase to cup disc ratio by more than 0.4:1 associated with signs of glaucomatous optic neuropathy, which was termed as frank glaucoma. High resolution ASOCT images were also obtained to visualize the angle structures of these patients, and we looked for the markers of angle dysgenesis, which were namely, first, the absence of a Schlemm's canal as seen in this image, the absence of a clearly discernible trabecular meshwork, or the presence of a hyperreflective membrane which covered the angle recess, the putative Barkhan's membrane. We also looked for the presence of a patent supraciliary channel in these angles, which has been hypothesized in some studies to act as an alternate route for aqueous drainage in these eyes. Coming to our results, we were able to recruit a total of 54 eligible patients with a median age at presentation of 12 months, median age at last follow-up 9 years, and over a median duration of follow-up of 8.2 years. We found that a striking 31% of these patients eventually developed disease in the fellow eyes as well, with 15% of these patients developing ocular hypertension and 17% developing frank glaucoma in the fellow eye. Of the total patients who progressed to bilateral disease, most of them were found to do so in the age group of 5 to 10 years. Of these 17 progressors, the 8 patients who developed ocular hypertension in the fellow eye, all of them could be successfully managed medically with a mean of 1.13 plus minus 0.64 topical medication. And of the 9 patients who developed frank glaucoma, 7 could be managed medically, while 2 required surgical intervention, with 1 undergoing goniotomy and 1 requiring trabeculectomy for IOP control. On comparing the ASOCT dysgenesis parameters, as I just showed, between the affected and fellow eyes, we found that there was no significant difference in the absence of Schlemm's canal, the absence of trabecular meshwork, or the presence of hyperreflective membrane when comparing the affected versus the fellow eyes, which could signify that these unaffected fellow eyes also harbored the similar level of dysgenesis as compared to the affected eyes. However, when we looked for the presence of the patent supraciliary channel, we found that there was a significant difference when comparing this unaffected to the affected eye, which could signify that the hypothesis which I mentioned earlier, that this patent supraciliary channel could be protective against development of glaucoma in the fellow eyes. And when we compared this, we found that with the presence of this patent channel, the odds ratio of not progressing to bilateral disease was found to be 1.48. Coming to the risk factors that we assessed, we found that the affected and fellow eyes differed significantly when comparing the mean axial length, mean CCT, mean corneal diameter, and the mean BCVA. Out of these factors, only one, that is the corneal diameter, was found to differ significantly in the fellow eyes of the progressors versus the non-progressors. And with fellow eye corneal diameter of more than 12 mm, the odds ratio of progression to bilateral disease was found to be 9.5, which was statistically significant. When we compared the dysgenesis parameters between the progressor and the non-progressor's fellow eyes, we found that there was no significant difference in the absence of Schlemm's canal, the absence of trabecular meshwork, the presence of hyperreflective membrane, or the patent supraciliary channel. Thus, these ASOCT features cannot be used to differentiate that which fellow eye will develop bilateral disease or not. So, to conclude, the unilateral PCG patient cohort, 31.5% patients were found to progress to bilateral disease, with around 15% developing ocular hypertension and around 17% developing frank glaucoma. A corneal diameter of more than 12 mm emerged as the strongest predictor of progression amongst the fellow eyes, and the presence of a patent supraciliary channel in these angles could be protective for the fellow eyes from development of glaucoma despite the presence of a similar dysgenesis level. Clinical implication is that since a significant proportion of unilateral PCG patients were found to develop disease in the fellow eyes, they require a close follow-up along with close evaluation of this fellow eyes so that the detection can be early and we can intervene early. And the eyes with more than 12 mm diameters could be especially watched for signs of progression. And we would like to recommend genetic analysis of this cohort in the future, as in a recent study it has been proposed that these unilateral PCG patient might actually represent a genetically distinct entity. Thank you.
So I think well presented there. Generally, what proportion of these congenital glaucomas are bilateral to begin with?
So in published literature, the ratio is 80% to 20%. 80% are supposed to be bilateral, while 20% is supposed to be unilateral. According to various published literature, it varies from 15 to 35%, the incidence of unilaterality.
Right. So roughly about, as you said, about 20%
Yeah.
are. So between the ones who progressed in the other eye to bilaterality and who did not progress, you didn't find any parameters that were different between the two. So what is your hypothesis? Why did one
No,
group
so
of
we found two significant factors which differed in the progressors was the non-progressors. The two factors were, one was easily clinically accessible, which was the increase in corneal diameters. So in the fellow eye, if the corneal diameter on follow-up is found to be more than 12 mm, that is a very strong predictor that this fellow eye might develop disease in the future. And the other factor which is not clinically easily accessible is the presence of a patent supraciliary channel. As I showed in the AIOS YOSI images, in those fellow eyes which had the patent channel present, the incidence of progression to bilateral disease was lower as compared to those fellow eyes which did not have this channel. So it has been hypothesized in previous studies that this could act as an alternate route for aqueous drainage. Despite the presence of angle dysgenesis, the normal route for aqueous drainage is lost, but this is an alternate route which can protect it from developing glaucoma in the future.
Right. And was there an axial length difference?
Axial length was measured, sir, but we
But-
couldn't find no significant difference. It was not a predictive factor for which will undergo a progression to bilaterality.
Because that would make more logical sense along with the corneal diameter.
Yes, sir.
too,
Yes,
but
sir.
there was no difference.
Actually, axial length is one of the most important features which we look for in follow-up to look for the progression in the affected eye. So we thought that maybe in the fellow eyes as well, the axial length could be predictive. But in our study, we did not find so.
And how easy was it to do the ASOCT for the children? I mean,
Sir, in our inclusion and exclusion criteria, we had kept this that at least that age who could cooperate. So we needed the patient to be sitting stationary for around 30 to 40 seconds for it to capture good images. So we included only those patients in which we could get clear ASOCT images. The rest were excluded.
that's a difficult one to image actually, but great.
Great job.
Thank you.
How was the corneal diameter measured?
Ma'am, corneal diameter was measured for those who could cooperate and sit on the slit lamp. I measured it myself using the slit lamp.
Okay.
And in very small kids, we could use a ruler.
Right. And like you did a horizontal and vertical?
Horizontal and vertical, ma'am, mostly the horizontal diameter was more, and we took the maximum dimension only. Most of the patients, it was the horizontal diameter.
Okay. So you took the horizontal or whichever is
The maximum
larger,
dimension.
maximum one.
Yes, ma'am.
Thank you so much.
Yeah, I just have one question. Yeah. Yeah, hi.
Yes.
As presented, I just had one question. You said that the corneal diameters were, that was one factor which you found. But tell me one thing, you think it will proceed the intraocular hypertension?
Sorry,
Or
sir?
The increase in corneal diameter, would that precede increase in intraocular tension? Is that what you found, or was it an after effect of the increase in the intraocular
Sir,
pressure?
this was a follow-up study actually. So
Yeah.
patients were called for follow-up. At that particular point of time, they were found to have increased corneal diameter as well as increase in IOP,
Yeah.
which could either have ocular hypertension or glaucoma. So we are hypothesizing that when we are calling these patients for regular follow-up, what we have given in a clinical implication is that all these unilateral PCC patients should be regularly followed up, especially in the age group of 5 to 10 years, and there should be serial evaluation of the corneal diameter to see if it is increasing, because that could signify that this fellow eye is progressing. It has
So you think that it is possible that there will be an increase in corneal diameter without an increase in the intraocular
not
pressure?
without mostly it is because of the increased IOP that the corneal diameter is increasing. Although in our patient, one of the patients was found to have increased corneal diameter without an increase in IOP. There was one such patient.
Just one.
We have excluded it from our analysis, but we are following up this patient to find out the pathogenesis of whether he will develop disease in the future. There has been one such patient, but the significance of this factor is just to help us identify of which patient we should be especially watching out for to look for disease, and we should not lose him to follow up.
But even for kids, measuring the intraocular pressure is easier than measuring the corneal diameter.
Yes, sir. But we usually tend to miss the fellow eyes whenever there's a unilateral
Talking about
PCG.
both eyes.
Whenever there's a unilateral PC patient, we are mostly focused on the affected eye, and in the EUAs as well, we tend to overlook the unaffected
Do
fellow
that?
eyes. Yes, sir.
You actually do that?
No,
You
no,
don't check
we
the
measure
fellow-
it, but we are not really focused on that. So that is what we are saying. We should be focusing more on these patients who are found to have more increased corneal diameters, because they should be especially watched for. In patients who were having less corneal diameters, around 10, 11 mm, they were not found to progress as much. So if we have this factor of more than 12 mm, we should be a little suspicious of these patients.
Fair enough.
Thank you.
Nice presentation, Dr. Ayush. I would call upon the next presenter, Dr. Anand.
Very good morning, one and all. So I am here to present the study which has taken place in last 1 year of time, that outcomes of bent ab interno needle goniectomy in moderate to severe primary open angle glaucoma patients of Indian eyes. So the study taken place under the guidance of Professor Tanuj Dada, Dr. Devang Angmo and Karthikeyan Mahalingam. So the study taken place at Rajendra Prasad Center for Ophthalmic Sciences, AIMS. So no financial interests and no conflicts of interest. So here the study taken place to assess the safety and efficacy of ab interno needle goniectomy in moderate to severe open angle glaucoma patients who were undergoing visually significant cataract surgery, phacoemulsification. So coming to methods, it's a prospective interventional study at taken place at Dr. RP Center, AIMS, and ethics clearance was obtained from Institute Ethics Committee, and PVOG eyes which eyes whatever the uncontrolled IOPs with visually significant cataract was operated by single surgeon in between the time of November 2021 to December 2022. Here the surgical procedure, how the surgery is taken place in open angle glaucoma patients with the toric marker assistance. We mark 30 degrees, and under the with the usage of Swan-Jacob gonio lens, we visualize the angle structures, and we strip the trabecular meshwork for 30 degrees, and whatever the stripped trabecular meshwork remnant in the anterior chamber is cut with micro scissors, and which is confirmed later on with anterior segment OCT on post of day 1 and 6 months and 12 months. So this is the open angle in a preoperative patient with the dense meshwork of trabecular tissue, and later on in post-operative period the stripped trabecular meshwork is shown on as a cleft-like opening in the angle. The pink arrow showing that. And then coming to methods, and these patients data are documented in Excel sheet with preoperative mean IOP, mean number of anti-glaucoma medications used preoperatively and postoperatively, and gonioscopy and anterior segment OCT also documented with the guide of spectralis OCT, and intraoperative complications for each patient was documented, and these patients were followed up at 1 day, 1 week, 3 months, 6 months and 12 months postoperatively. Repeated ANOVA test was used to compare pre and post operative 6 months and 12 months data, and p value was considered significant if it is less than 0.05. So 46 eyes of 42 patients were operated for bent needle goniectomy with the mean cup dish ratio of 0.85:1. The mean IOP in preoperative patients was 22.4 mm of SG, and 46 eyes of 40 patients. And at 6 months, the out of 46 eyes, 40 eyes was followed up, and the mean IOP is reduced to 12.5 mm of SG, which is statistically significant. At 12 months follow up also, among out of 46 eyes, 24 eyes followed up, and the mean IOP is 12 mm of SG, and which is also statistically significant. And the mean number of anti-glaucoma medications also, at pre-operative time it is 3.73 medications was used. At 6 months it is reduced to 2.78, almost one medication is reduced on post-operative period up to 6 months. At 12 months it is almost around one medication is reduced, it is 2.96, both at 6 months and 12 months, which is statistically significant. And the other parameters, there is almost 76% of eyes at 6 months showed more than 20% reduction in IOP, and around 90% of eyes showed at 12 months more than 20% of reduction in IOP, and less than 12 mm of SG, which is low teen IOP, considered as target IOP at advanced glaucoma patients, which is indicated as qualified success, which is seen at 6 months is around 70%, and at 12 months around 83% of eyes showed qualified success. and there is decrease in more than one medications was 70% in at 6 months. Out of 40 eyes, 28 eyes showed 70%, uh, 70% decrease in more than one medication, and 66% at 12 months. And 3 eyes required zero medications to achieve that target IOP, and 2 eyes required filtration surgery at 6 months of period, which showed the failure rate around 2 eyes. And post-operative mild hyphema was noted in around 10 eyes at 1 week post-op. After 1 week, it was reduced. And coming to conclusions, 30 degrees goniectomy using 26 gauge needle is a safe and cost effective, economical for developing countries, which showed favorable IOP outcomes up to 1 year. Then, however, these most of these eyes required number of anti-glaucoma medications to achieve low target IOPs. And coming to limitations of the study contains small sample size and shorter duration of follow-up, needed longer duration of follow-ups to conclude at better results. So we are still following of these patients, and we come up around 18 months of follow-ups at around next 3 months. Thank you.
Right. So you've done the goniotomy with a 26 gauge needle.
Yes, sir.
Are there other techniques of doing it?
Other techniques, they used one instrument which is in Chinese eyes. They used one suction kind of aspiration needle. With that thing, they cut the trabecular meshwork, and they removed the tissue with the suction help. And another thing, one more instrument they used, that is the curved blade. I
Do
forgot.
you know
sir.
the name of that?
Sir?
Do you know the name of that instrument?
Yes, yes. The blade is suddenly.
Right, you do know about it, so that's all right.
Yeah.
Don't worry. And was there any difference in the angles of those who had a full success versus those who had a qualified success or a failure? Did you find any?
Yeah, we seen most of the follow-up patients at 6 and 12 months of AIOS OCT. We compared the goniectomy cleft with the diameters changing from 6 months to 12 months, the amount of fibrosis happening and all. So those results yet to come, but we haven't assessed fully that whatever the Schlem's canal, the opening cleft and all. So we better come up with better results on upcoming times, or around 3 months.
Yeah, because that will be important to see that if pre-operatively we can do a gonioscopy or an ASOCT and say that these are the patients who will show a success, versus.
Yeah, actually, we taken as the surgical success rate with the number of anti-glaucoma medications from pre-operative to post-operative, and the mean IOP change from pre-operative to post-operative at 6 and 12 months. And the secondary outcomes like these goniectomy cleft changes has to be assessed with the high resolution HD OCT.
Yes, and pre-operatively also. Basically, if you
Yes,
do a
sir, yes.
gonioscopy, if you're finding in these, if there is very blotchy pigmentation, or you're getting pseudo exfoliation, or you're getting something else, also whether those are going to have success or not. Because in previous studies, so gonectomy is something that has been happening even in the past. It's not a new procedure, but we found that there are certain. We'll go back and read. There are certain
In
changes
Indian,
which
in
indicate
Indian
that this is
eyes,
less likely to be successful.
in Indian eyes, still there is no published
in
data
Indian
of
eyes, correct.
goniectomy. But in Chinese eyes and Japanese eyes, they documented around 2 months back. They published 2 papers, and which showed almost 70% success rate of mean reduction in IOP. Uh, Around 42 eyes, 42 eyes. Around 6 months of 6 months, one study shown the success rate of 70%, and the Japanese eyes showed 70% success rate at 12 months of success rate.
Hi Anand. Acha. Tell me one thing. What was the area of a goniectomy that you did in the
So
study?
actually, one study we recently performing that aqueous angiography guided goniectomy. So we primarily before entering into the eye, we do aqueous angiography and we locate the aqueous channels. So wherever the dense aqueous channels, we left the area untouched, and wherever there is lack of aqueous channels, we create the goniectomy in that area. So mostly conventionally nasal area got a dense network of aqueous channels followed by superior, then inferior, then temporal. So temporal area got less number of aqueous channels. In among 46 eyes, we mostly around 26 eyes we did in temporal quadrant of goniectomy, and remaining 20 eyes we did in nasal area of goniectomy. So we haven't compared nasal versus temporal yet. So we needed, we are looking for more sample size in that study, because it little bit of interesting one and novel study. So we are coming with better results in such area.
Were there any eyes where you could repeat the surgery and you did more in any eye?
Actually, we haven't repeated goniectomy in none of these eyes. So only we did primary sitting of surgery only. But in pseudophakic eyes, we did like operated trabeculectomy where the trabeculectomy failed. In such eyes, we tried goniectomy, which showed little bit of like one medication drop from the pre-operative period.
But all the inclusion eyes had undergone cataract, right? These were pseudophakic.
Actually, whatever the pseudophakic eyes we haven't included here, because that's a separate scenario which I said. These eyes are primarily cataract, whichever the patient's going for cataract surgery, all those eyes are included in this
They
study
became
only.
pseudophakic, right?
Ah.
After the surgery, they were pseudophakic.
No,
They were undergoing cataract surgery, right?
primarily they are undergoing cataract surgery.
did it
Before
along with
cataract
cataract
surgery, we did goniectomy. Later on, we do in the
You do
same
cataract
setting
surgery.
only we
So
did
in the
cataract.
2 cases that you had to do an intervention, a separate intervention, you did not try to repeat this same procedure again.
Goniectomy
Yeah.
repetition.
So there were 2 eyes, right, which you said that
Yes, yes.
required trabeculectomy at 6 months.
Yes.
You did not try to re-intervene with the same procedure again in those eyes.
No, no.
Okay.
Only single sitting surgery, around 30-degree only at one sitting we did.
Thank you.
Any other complication apart from hyphema?
No, ma'am. No, not very significant complications we haven't noted. But yeah, hyphema only the major complication we noted, up to like dispersed hyphema in most of the eyes we noted. So initially there will be drop in vision because of the dispersed hyphema. Later at 1 week the hyphema resolves, and they gain their better than preoperative vision.
And as you already said, there was no incomplete. You didn't have to do any repeat or.
No, ma'am. No repetition of surgery.
Thanks.
Thank you.
Nice presentation. Next, we'll move on to the next speaker, Dr. Abhijit Beniwal. Going to talk about resident cataract surgeries in a tertiary care center experience.
Good morning, everyone. I'll be presenting my paper on residents cataract surgery, a tertiary center experience. So, cataract surgery is one of the most common surgery performed around the globe. It is no longer recognized as a disease. It is believed to be age-related degeneration. Over 50% blindness in India is attributed to cataract. However, cataract surgery-related complications are an important cause of visual impairment. Hence, proper training is an important aspect to tackle this double-headed problem. And in our hospital, residents need to be trained in the surgical skill lab and get certified before operating in human eye. So it was a retrospective observational study at a tertiary care center, and it was done in community ophthalmology department. Surgeries were free of cost. A total of 4,185 patients were operated. Premium vials were not used. Assessment was done at day 1 and at 6 weeks. So the mean age of patients was 59.8 years. 2/3 of the patient were between 50 to 70 years. In 90.2% cases, phacoemulsification was done, and 84.7% patient walked off with foldable IOL in bag, and a total of 98.5% patients were discharged with IOL in the eye. And 85 patients had mild visual impairment before surgery. 1,429 had moderate visual impairment, 543 had severe visual impairment, and whooping 2,126 patients were clinically blind before surgery. And after surgery, 2,661 patients had normal vision, that is vision up to 20 by 30, 6 weeks after surgery, and 1,165 patients had just mild visual impairment. And 189 patients had moderate visual impairment, 56 had severe visual impairment, and 111 blind after 6 weeks after surgery. A total of 63.6% patients had normal visual acuity after 6 weeks, and 77.3% had better than 20 by 40, 91.4% had better than 20 by 60 vision. So, out of 85 who had preoperatively mild visual impairment, only 4 had worse visual impairment than preoperatively. Similarly, out of 1,429 patients with preoperatively moderate visual impairment, only 20 had worse visual impairment postoperatively. Out of 543 patients with severe visual impairment, only 3 had poorer visual impairment after the surgery. And out of 1,026 blind patients, only 94 were blind postoperatively also. 170 patients, that is up to 4%, had best corrected visual acuity less than 20 by 200, and 97.5% patient reported improvement in visual acuity. And being a retrospective study, the data for causes of poor vision is not available fully, but for 352 patients we could elicit the cause of poor postoperative gain of vision, and surgery related causes were the reason in 187 patients out of it. So cataract surgery is a complex surgery with little margin of error, and surgery is performed by a single surgeon, although the assistant can guide the surgery, but ultimately it is in control of the resident surgeon only. And a lot of complication can result from complicated surgery, from corneal decompensation to cystoid macular edema and even retinal detachment later on. So training programs have improved a year, as has been phacoemulsification machine. So for instance, in 1976, one study reported around 20% vitreous loss in trainee surgeon. It was reduced to around 3% by 1992. So best corrected visual acuity of 20 by 40 or better was achieved in 77.3% cases only, which is inferior compared to recent studies, and according to WHO it should be better than 80%. And COVID pandemic could be a cause in it, because, and as noted by Stephen et al., who noticed a jump in PCR rate post COVID. And the 84.7% patient had foldable island bag, compared to, which is comparable to another study from our center, and 98.5% patient were discharged with IOL in the eye, which is comparable to recent studies. So internal quality improvement projects are important in resident training program, and every complicated case should be assessed. Residents should maintain logbooks, and simulators should be encouraged. Thank you.
Hi, good presentation. So any pre-operative specific investigation were added later on? Like as you said, corneal decompensation was a big post-op complication.
Yeah, so all the patients were operated in different unit, but almost everywhere specular count was done pre-operatively, and we usually use IL master, and
So any precaution taken if the specular count was low?
so usually the cases which had very low specular count were not given to junior residents, would be operated by senior resident, but these are also included, and a viscoat could be arranged for such cases.
Right. Thanks.
Hi, Abhijit. So basically what you're saying is that the study included cases operated by both trained and untrained surgeons.
Basically, all the 4,185 cases we included. So we included all the cases. Many cases the trained resident would intervene in between. So we did not exclude the cases operated by senior resident, because they were firstly less in number, around 5 to 7% only. And also in many of the junior resident cases, the senior resident would intervene in between. So we haven't excluded all of them. All the cases that were operated within 4 years, we all included all of them.
Is it possible that you can divide these groups into first year resident, second year resident, third year resident, so that you can get better data, better sense out of the data that what is actually happening, what the training program is actually doing. Because otherwise, if you club everything, then you only have a general data. Are there any other studies from across India, from other centers that have tackled the same issues?
Yeah, there is a center from South India. There are several studies. They have classified according to the year of residency. And currently in IGO, one paper was published by Dr. Akshay Nair, in which they sent a questionnaire across social media platforms and discussed the problems encountered by resident surgeons.
And what is the mean number of surgeries per resident that was there?
Sir, it was different pre-COVID and post-COVID. It also depends on the batch which was there. Like I myself did 23 in residency, and my seniors did 70. Before COVID, it was almost 50 to 60 surgeries at least per resident.
And generally in phacoemulsification or cataract surgery, what is the reported prevalence of PCR in the general surgeons across globe? There are a few studies which have looked at that.
It is around, if you are talking about trained surgeon, it is less than 0.1%, 0.1 to 0.2.
Right. So this is roughly about 300% of that
Yes,
overall.
Yes,
But
sir.
then I think we're all reaching that place over time. But thanks.
Thank you, sir.
Nice presentation. Next, we'll call upon Dr. Neha Bajpai to share her presentation.
Opportunity here to present a paper on vitrectomy for uncomplicated rheumatogenic retinal detachment with or without use of PFCL, which is a retrospective comparative study. So as we all know, with the advancement of pars plana vitrectomy techniques, it has become the first choice of surgery for the primary RRDs. Pars plana vitrectomy has taken over the scleral buckling in past decades. Use of PFCL as an intraoperative adjunct in the vitrectomy is usually for draining the SRF in the RRDs and to flatten the retina. However, few surgeons drain SRF through fluid air exchange directly without using PFCL. And use of PFCL is completely surgeon's choice and based on surgeon's discretion. So aim of this study was to compare the anatomical and visual outcomes with or without use of the PFCL during the vitrectomy for uncomplicated RRDs. So this was the retrospective study conducted in the time span of January 2021 to January 2022. Patients had the mean follow-up of 1 year. 79 or 79 patients were included who underwent pars plana vitrectomy. Exclusion criteria that were kept in mind were patients who had undergone previous vitreoretinal surgeries were excluded. PVR grade more than grade C1 were excluded. Patients having giant retinal tears, complicated retinal detachments like secondary to trauma or vasculitis were excluded, and patients who were lost to follow-up were also excluded. So patients basically were divided into two groups, where 42 eyes of 42 patients included in the PFCL group, where the PFCL was used, and 37 eyes of 37 patients were included in the non-PFCL group, where FAE was used to flatten the retina. Anatomical outcome was single operation success rate at the end of 1 year, and functional outcome was improvement in the best corrected visual acuity at the end of 1 year. Results were statistically analyzed, and p-value less than 0.05 was considered significant. Patients whom PFCL was used were underwent 25 gauge MIVS with core vitrectomy, a vitreous skirt excision, subretinal fluid drainage using the PFCL. After that, fluid air exchange was performed, endolaser to the brakes, and choice of tamponade, silicone oil or 10% C3F8 was used according to the surgeon's preference. And in cases where PFCL was not used, FAE was used to drain the SRF. So out of 42 subjects in the PFCL group, 14, that is 33% were phakic, and 66% were patients were pseudophakic. Amongst the non-PFCL group, 21 eyes were pseudophakic and 16 eyes were phakic. In the PFCL group, silicone oil was used as a tamponade in 62% patients, and 10% C3F8 was used in 38% patients. In non-PFCL group, majority of the cases had a tamponade of 10% C3F8 and 37% had a tamponade of silicone oil. So at the end of 1 year, single operation success rate with in PFCL and non-PFCL group was 83 and 85% respectively, which really did not had much difference. Coming to the post and pre and post operative visual acuity comparison in PFCL group, it definitely improved from 1.78 log MR to 0.88 with a p value of 0.006, which was statistically significant. And in the non-PFCL group, the visual acuity improved from 1.77 log MR to 1.36, which was also statistically significant. However, when we compared the post-operative visual acuity between the two groups, it was found that PFCL group, where the PFCL was used, had a better best corrected visual acuity than the non-PFCL group. But the results in this data were not statistically not significant. Also, the redetachment rates in both the groups were similar. 6 patients in both the groups underwent the revision vitrectomy. So, use of PFCL as an adjunct is believed to provide better stability during the surgery. Few studies have also said that drainage of the SRF through FAE leaves some residual SRF in the end, which could be the reason of poor visual acuity after the successful vitrectomy. However, PFCL associated complications like subretinal migration of PFCL or migration of PFCL in the anterior chamber should also be kept in mind. So I would like to quote two studies where Chen et al. Actually studied the clinical outcomes in macula of RRDs, where he drained one group complete subretinal fluid drainage and other was a partial subretinal fluid drainage. And the mean best corrected visual acuity at the end of 6 months post-operatively was not statistically different between the two groups. Also, in the similar study conducted by Orit Wende et al., he studied 162 eyes of 162 patients who underwent pars plana vitrectomy. With the use of PFCL, they drained the SRF and one was subretinal fluid drainage by FAE. Both found that in both the groups, they have achieved the excellent results in terms of retinal reattachment rates and also the visual improvement, and had a comparatively safety profile. However, they have found that slightly higher rates of additional surgeries were found in the group where PFCL was used. So in our study, anatomical success rate at the end of 1 year was found to be same in both the groups. Best corrected visual acuity in the PFCL group was better, but it was not statistically significant. Although a large sample size and additional large prospective studies on this combined intraoperative and postoperative procedures is required to validate the results. So to conclude, use of PFCL can be avoided in medium complexity RRDs intraoperatively, as there was no clinical significant difference in anatomical as well as visual acuity postoperatively at the end of 1 year. And total surgical time, cost of the surgery, extra surgical step, along with the risk of complications can be avoided by not using PFCL without compromising on the reattachment rates and postoperative best corrected visual acuity. These are my references. Thank you so much.
Nicely done study. I just have one question. Did you measure any other parameters of vision other than visual acuity?
Any other parameters?
For example, a lot of talk is going on right now about retinal displacement and metamorphopsia. So for
Yes,
a retinal surgeon,
Yes,
when you know how to attach a retina and vision improves in a patient, the last thing I guess is decreasing metamorphopsia.
Yes, sir.
So there's a very good study which has compared 3 different modalities using a retinotomy to drain the subretinal fluid using fluid air exchange and PFCL, and their results are very different.
Okay.
So maybe you could go back, and they give a very good hypothesis why retinal displacement is less when you do not use PFCL.
Yeah,
So
sir.
metamorphopsia and visual acuity is better in those groups.
Okay, we have not considered the metamorphopsia substitutes. Yeah. We can actually, study is still going on, but yeah.
It's difficult to do, but
Yeah, sir, because subjective it is very we can't,
fair enough.
Like,
So are there any specific conditions in a vitreoretinal surgery or a vitrectomy where you would recommend PFCL to be should definitely be used, or it's most useful in?
Yes, sir, in cases of GRT, if the break is large, if the break is too posterior, and if the break is too anterior also we use, because we have to see that where in PCIL patients, pseudophakic patients, when there are anterior breaks and very small breaks, we tend to miss the breaks basically. So PFCL use actually allow us to see from where the fluid is getting drained, so that we can actually identify the break properly and do the surgery.
And is there a difference in the operating time or operating?
Yes, sir. Operating time while using the PFCL increases a little, sir. But if the FAE is, but it totally depends on how surgeon is well performing the surgery. Sometimes through FAE also multiple attempts are required to drain the SRF. So it totally depends on how well surgeon is performing the surgery.
All the surgeries were done by same surgeon? Sorry, I might have missed.
No, ma'am. It's done by all the surgeons mentioned in the first slide. Dr. N.S. Muralidhar, Hemant Murthy sir, and Dr. Suman sir.
Right. Any difference in the choice of C3F8 and all you were telling for Temponan in the results? Was that noted?
Sir, actually, we have calculated examined the best corrected visual acuity in the silicone oil patients after SOR, and also the phakic patients who developed the cataract. The best corrected visual acuity was checked after the cataract surgery. So, like that.
Thank you.
Okay, thank you, ma'am. Thank you, sir.
Nice presentation. Next, we'll call upon the next speaker, Dr. Priyadarshini. She is going to talk about the ablation pattern after in hyperopic eyes with a femtosecond laser.
A very good morning to one and all. I'm presenting my study on the ablation pattern in hyperopic eyes treated with femtosecond LASIK. So the FDA approved treatment limit for hyperopia is up to 6 diopter sphere. However, the outcomes of the hyperopic LASIK can be negatively affected when the hyperopic correction goes beyond +4 diopter sphere, as found in many studies. And below 4 diopter sphere, literature has found that postoperative K values do not, beyond 48 diopters, do not affect the outcomes. Though the biomechanical strength is preserved in comparison to myopic LASIK, the initial outcomes of hyperopic LASIK were found to be relatively lesser when compared to the serial follow-ups, in which the vision gradually improves with higher hyperopic corrections. So we decided to look into what happens during the ablative procedure, and the purpose of the study is to study the ablation pattern in patients who underwent femtosecond LASIK using Zeiss Visumax femtosecond and MEL 90 excimer laser. So this was a prospective interventional study which was done in 10 eyes of 5 consecutive patients of over 18 years of age with a stable manifest refraction over 1 year. And the patients with a postoperative KM calculated to be over 50 diopters and a residual epithelial thickness on ASOCT mapping found to be calculated less than 25 microns were excluded. Patients who were involved in contact sports were also excluded from our study, and the patients who were otherwise unfit for any LASIK refractive procedure were all excluded. Informed consent were obtained, and the surgery was done using Zeiss Visumax femtosecond and MEL 90 excimer laser. The LASIK procedure was done as per the usual protocol using femtosecond laser cut first, and then flap elevation, ablation, followed by flap reposition. These were the parameters which were used. We took an optical zone of around 6.2 mm, and the ablation zone went up to 8 mm. Postoperatively, antibiotics, steroids, and preservative-free lubricants were prescribed for all patients. And the visual acuity assessment, intraocular pressures, tomographic ASOCT evaluation, and slit lamp evaluation were done on all serial follow-ups. So this is the criteria. This was the final results of all the eyes in the 5 patients, of which 2 were females and 3 were males. We can see the preoperative best corrected distant visual acuity slightly declined in the first follow-up. In the average, you can see that the logMAR is 0.5 plus minus 0.38, which gradually improved at 30-day follow-up to 0.3 plus minus 0.2. The average refractive error which was corrected was around 4.5 plus minus 1.3 diopter sphere of spherical equivalent, and the average cylindrical error we corrected was around 0.5 plus minus 0.39, and the maximum cylinder we have corrected is 1.5 diopters, in which the refractive error was plus 6.25. So the intraoperative findings, bleeding was noted from the peripheral vessels in 4 out of 10 eyes, and a step-like configuration which corresponded to a trough-like depression at the hinge area was noted in 8 out of 10 eyes, which regressed at the first follow-up month, which with corresponding improvement in visual acuity in these eyes. and a buttonholing was noted at the hinge in 1 out of 10 eyes. So this was the clinical image of the patient in which we had a refractive error, the highest refractive error that we corrected, of with a cylinder of +1 diopter in the right eye and plus 1.5 diopter cylinder in the left eye. And this was the patient. We had a buttonholing, as you can see in the ASOCT image as well in the left eye. And you can see a definitive slab-like pattern on the slit lamp image as well, corresponding to the ASOCT area in both the eyes. And this gradually regressed on postoperative day 30 in both the eyes, and the visual acuity of the patient also improved. So this was the intraoperative video of the patient, and I'm taking it to the part where we are doing the flap dissection. And so you can see that the laser is coming over the hinge area, and it just led to the buttonholing of that eye. We had applied a BCL over the eye and observed it for further assessment. Usually the hinge area was, we didn't expect that the visual acuity would be diminished because of that. These were the step configurations in the other eyes which we had operated on, and you can see a mild step-like configuration in all these eyes and a mild dip in the ASOCT here at the hinge area, which gradually regressed. This was another eye where we had a peripheral vessel bleed, and this vessel bleed is usually temporary. It might interfere with the ablation procedure, so we need a dry cornea during ablation. Here we had used a flap protector as well, and you can see over the flap protector also that the hinge area ablation is involved, and the bleed continues in the peripheral vessels, which can be a little difficult during the surgery, and the bleed spontaneously resolves once the flap is totally dehydrated. So the previous largest series on hyperopic LASIK was with Reinstein et al. Series, in which he performed hyperopic LASIK on 1370 eyes. He had also found that the uncorrected distant visual acuity of over 20/20 was seen only in 75% of the eyes, in comparison to the 93% who had a preoperative CDVA of over 20/20. And there was a loss of more than 2 lines in 17% of the eyes. In our study, we had only 3 eyes which had a corrected distant visual acuity of over 20/20, and all of them had achieved a uncorrected distant visual acuity of over 20/20 postoperatively. And there were 2 eyes which had a loss of more than 1 line of visual acuity at the last follow-up. And our study, the limitation is that the study has smaller numbers relatively. However, it is the first of its kind in the Indian population, and we would need a larger data to know better about the outcomes of hyperopic LASIK. So to conclude, hyperopic laser ablation might involve the hinge region, which might result in suboptimal visual outcomes initially. However, this regresses and scarring with time, and it can improve visual outcomes eventually. A flap protector is mandatory during the ablation of high hyperopic errors especially, and a good patient counseling can help optimize the outcomes of hyperopic refractive errors. Thank you.
So there was one buttonhole, right?
Yeah.
And one bleeding. Anything else? How long is the follow-up?
The follow-up was, till now we have a follow-up of 6 months. Some patients are going on above 6 months, but the maximum we have is up to 6 months.
Any complication you expect in the future? Especially because the limbus area, the epithelial handling and
especially in the eyes with buttonhole, we were scared that the epithelium might not heal properly.
Okay.
So
that is the initial. Anything in the future you feel when you're handling so much of the epithelium, the flap area, the hinge area, any remnant, anything in the future do we expect in such cases?
Ma'am, in high hyperopic errors, we should always be cautious that we might have any complication. Even with the slight eye movement, it might involve some other region also.
That's
and
okay.
even if
anything, what about ingrowths? Any idea regarding ingrowths? Okay.
Sorry,
So maybe we'll see in the future follow-up, right?
Yeah.
Okay, thank you.
So one of your conclusions is that flap protectors are mandatory for these high hyperopia patients. So
Yeah.
what part of your result has said that if you don't have a flap protector, this will happen. If you have a flap protector, this will happen. Or is that a general conclusion from the?
So in the eyes reached of lab protector, we could barely see the step-like pattern. So that step-like pattern probably occurs because of the ablation in that zone only. It could, I mean, the stroma is also ablated in that area. So there might be a mild depression in that area along the hinge because of the stromal ablation along with the hinge ablation. But without a flap protector, the hinge ablation is much more predominant. And in the eyes which we had high hyperopic errors with higher cylinders, this effect had it was much more predominant and it showed in the visual outcomes also. So that is why we think the flap protector might avoid. And in the eyes, in the couple of eyes which we used the flap protector towards the end, we found that the visual outcomes in the very next day was very good. Patient had barely any disturbances or complaints.
Right. Thanks.
You think changing the location of the hinge based on the cylindrical error would have some better outcome?
So that could be an option. We also considered changing the angle of the hinge, but still the ablation zone was coming over the hinge. However, we change it or shift it because it is an overall peripheral ablation, and most of them have a combined hyperopic error also, not just a cylinder. So,
Fair enough. Nice study.
thank you, sir.
Nice presentation. This is the last talk of this session. Now I'd like to call upon Dr. Aarti and Dr. Aditi. Dr. Aditi to give a moment to Dr. Digvijay sir. Now I would like to. Yes, sir. Now I would like to call Dr. Digvijay sir to give a moment to Dr. Dushir sir. Next, I would like to. I would like to call upon the participant, Dr. Ayush, to receive certificate.
नहीं नहीं, it's okay. मेरा वाला यूज करो.
Next, I would like to call upon Dr. Anand to receive the certificate. Next, I would like to call upon Dr. Abhijit to receive the. Next, I would like to call upon Dr. Neha to receive the certificate. Next, I would like to call upon Dr. Ruchit to give certificate to Dr. Priya. Next, I would like all the participants and the judges to take a group photo.
Anterior segment video competition in the next 5 minutes. I request the judges to please come and take the position. Dr. Digvijay sir, Dr. Rushad Shroff, Dr. Ramya and Dr. Prasanna. Here we've received videos from each of the 5 parts of anterior segment. So for extraocular muscles, we have Dr. Anuj hunting down the slip medial rectus. From cornea, we have Dr. Aarti Heda, dial to the twist. From the glaucoma part, we have Dr. Sandeep Chaudhary, phaco with bent angle medial goniectomy. From phaco, we have Dr. Nikunj wandering into less explored area. And from IOL acrobatics, we have Dr. Rohan Mehra rescuing the subluxated IOL back complex. So let the show begin. I welcome you all for the surgical anterior segment video competition, and my name is Dr. Zain Khatib, and Dr. Aditya here with me is going to be co-moderating this session. So just to give you a brief, basically we had 10 video submissions this year. And we had a panel of judges, 5 judges who anonymously judged the videos, and we selected the best 5 from those marks. And so the top 5 videos are going to be displayed here today. And I'm very pleased to have the judges here with us today. We have 4 judges who will be judging the videos, starting with Dr. Digvijay sir. He needs no introduction. He's a guide to all of us. Currently, he's the past president of YOSI. And then we have Dr. Prasanna, who also, needs no introduction. Dr. Prasanna is, we make 2D and 3D videos. This guy makes 4D videos. So he's, someone who's very much into video making.
We also have 2 prolific cornea surgeons. We have one from our very own Delhi, Dr. Rushad. He's the medical director of Shroff Eye Center and a very dear friend. And we also have Dr. Ramya, all the way from Chennai, who's come all the way from Chennai to judge this competition. So all participants, you're blessed having such a great jury here. And all the questions will be directed not to the participants, but to the judges. So please be ready with the answers. I hope we've all received the scoring sheet. Yes. So may the best man or woman win, please.
So we'll start with the first video, which is Dr. Anu June. Dr. Anu, you can come here.
So the videos are being judged basically on the clarity, the narration, how the animation, the presentation is done, the scientific content, as well as the question and answer. So some questions should get directed at them as well.
An 11-year-old girl presented to us with history of trauma to the right eye with a bicycle handle and history of previous surgery of the muscle. She came to us with 90 PDs of exotropia with limited adduction. On left case, there was absent convergence and medial rectus was found in the sheath on imaging. She was taken up for medial rectus exploration with advancement along with lateral rectus recession. The conjunctival dissection was very difficult and there was a lot of scarring and adhesions. leading to buttonholing of the conjunctiva. A tissue was hooked, roughly around 5.5 mm from the limbus, which was actually the pseudotendon, and it was dissected from the conjunctival surface. The pseudotendon was then secured using double-armed 6-0 micro suture for better guidance and further dissection of the muscle sheath. The sheath was then dissected posteriorly to exclude the medial rectus. After a lot of dissection and a long surgery, a few fibers were identified posteriorly, which was confirmed by the presence of oculocardiac reflex. These fibers were then secured using the 6-0 micro suture, and further surrounding tissue was dissected near these fibers. This led to the exposure of more muscle fibers on either ends, both superiorly and inferiorly, and the full muscle was then secured using double-armed 6-0 vicryl throughout. The surrounding facial attachments were then severed. And the pseudotendon was cut. The muscle was found 19 mm from the limbus. It was then secured at 5.5 mm from the limbus at the original insertion, making sure that the passes were deep enough. Bites were also taken from the central muscle fibers to enhance the attachment and to prevent further slippage, as was the case as she was already operated once previously. The conjunctival edges were freshened up and the conjunctiva was closed using 8-0 vicryl suture. The buttonholing was closed using a purse string technique. The lateral rectus was then dissected out. And recessed 8 mm from the original insertion. Conjunctiva was closed using 8-0 vicryl, and the patient was orthotropic on day 1 with full reduction in the left case. Thank you.
So while the judges give their scores, I would want everybody to give a big hand to the first nominee for the Oscar today. Anuj, please. Anu, if you have questions.
Judges, your comments.
Yes. So, why is the medial rectus the most kind of difficult muscle to manage if it is slipping or if it's it's not in its position?
So because of the smaller length of the muscle, and then it slips with the eye movements, and that too when a certain amount of time has passed after the first incidence. So the eye muscle slips more and more posterior into its sheath and goes into the orbit. So we need to see whether it's a slipped muscle or is it in the facial sheath or is it lost into the orbit. Because the tight attachments in the smaller length of the muscle.
That's right, because compared to the lateral rectus, which can have some attachments with the inferior oblique and you're able to trace it, the medial rectus would not. If it tends to go more back, it's very difficult to actually look for it or fish it out. So indeed, it is a tougher. It's a very, very nice video and good outcome at the end of the day.
Right.
It's also the muscle involved for conversion, so you want it to work at its best. Good video.
Thank you, sir. I think it's a squint muscle.
Lovely to see everybody give up on asking squint questions.
Thank you.
It was a very good presentation. Once again, even the small things that was shown in the video, it was really good. So thank you for the presentation.
Thank you so much, Dr. Prasanna.
Okay, I'll try and ask is there any other suturing technique that you could have used for the muscle, but
We do have fonicial incisions, but we generally prefer them in clean cases and untouched cases. This was already a case of trauma and slipped muscle, so I would want maximum exposure. Plus, this child also had a history of surgery at the primary setting when she had this trauma 1 year before she presented to me. So she had a previous surgery where it was said that the MR laceration was repaired and the conj was sutured. So there's a lot of fibrosis and scarring, and smaller incisions or fornical or conjunct incisions would have been really tough to manage. So a wider exposure, even if it takes more suturing, it doesn't matter as long as you do good for the patient. Thank you.
So the next video is by Dr. Aarti.
A large penetrating keratoplasty in the settings of large cones does have large chances of rejection. Deep anterior lamellar keratoplasty can be technically very challenging with highly irregular corneas with large variable between center and periphery. Hence, we thought of modification in the technique where we did central DAL 7 mm or 7.5 mm and peripheral lamellar keratoplasty 2 to 3.5 mm to achieve clear optic interface in the visual axis and good tectonic support in the periphery. This 18-year-old male with advanced keratoconus was scheduled for surgery. After trephination of 10 mm, anterior stroma was dissected. Then 7 mm trefine was used to approximately 80% of corneal thickness and a 27 gauge cannula was inserted into the stroma up to the center of the cornea. Air was injected gently into the mid-stroma until a big bubble was formed, extending to 7 mm. If the big bubble was not formed after the first attempt, the injection was repeated. After big bubble formation, debulking of the anterior 2/3 of the corneal stroma was performed with a crescent blade. Donor Descemet's membrane and endothelium was gently stripped off with forceps. The donor cornea was punched from the endothelial side with the trefine. The donor cornea was initially fixed with 4 cardinal 10-0 nylon sutures at 3, 6, 9 and 12 o'clock position, and then 16 interrupted sutures were taken to complete the case. Post-operatively, patient did well with final visual acuity of 6/9. We have operated advanced keratoconus, pellucid marginal degeneration, and keratoglobus cases with steep curvatures with this modified technique of central DAL and peripheral lamellar keratoplasty, and the outcomes have been very consistent. Thank you.
Very nice technique and very nice video. Just a question, you didn't nick the central bubble after achieving it. Any particular reason for not doing that? When you were dissecting the central bubble separately, you were going lamellar in that again, rather than nicking it and then cutting that particular area. Any reason why you
No,
did that?
no specific reason for it. That's the technique which I prefer to do. So
Okay.
that's why I use that. The biggest advantage with this technique is that when you have very steep corneas, you can get perforation, and then you definitely have to convert the case to PK, and then you increase the chances of rejection. So we've tried to modify this DALC and use this technique so that you have a good tectonic support in the periphery, and then you get the visual axis clear.
But it doesn't affect any amount of scarring in the interface
Definitely
or
not. Definitely not. We have done around 20 cases for now, and process of writing it, and the results have been very consistent. Never had any perforation in any of the case. And this paper was actually given the travel grant in WOC conference this year. So
very nice. Thank you.
So what is the follow-up period of these cases, and how many cases have been performed?
So we've done 20 cases, and the follow-up have been for more than 2 years. So it's the So it's the same as the post-op period is same as for any corneal transplant.
It's more than 2 years.
Yes, more than 2 years.
And there has not been any case of perforation or anything.
No, nothing very significant.
Okay, this is an innovative technique by you, or it is a modified technique, or?
So there people have one group from Egypt have studied this technique, but they haven't done for pellucid marginal degeneration and keratoglobus cases. They have only done for keratoconus cases. That's the only paper which has been published so far.
Thank you. Good presentation, Aarti.
Excellent presentation. I really like the technique. But again, my question is very similar to Dr. Rashad's. You achieved a central bubble, a very beautiful central bubble. So it would have just simpler to nick the bubble, or is there any particular reason why you choose?
There's no particular reason for it. That's what I told. So this is probably the technique which I am used to. So.
Also, during this follow-up, are there any complications that you've seen in this particular large graphs as opposed to having just a regular regular 8mm?
No, nothing.
Excellent.
Thank you so much.
Please, a big hand for our second nominee for today's Oscar, please.
Dr. Sandeep.
Hello everyone, I'll be presenting a video presentation on band angle needle goniectomy with phacoemulsification and posterior chamber intraocular lens implantation in a patient with primary angle closure glaucoma with cataract as a treatment option. A 63-year-old female with best corrected visual acuity of 6/9, intraocular pressure of 20 on 5 topical anti-glaucoma medications, and nuclear sclerosis grade 2 cataract with advanced glaucomatous cupping was planned for a combined procedure in the right eye. The 24-gauge needle is being bent towards its bevel with the help of a needle holder. Now, a side port is being made at 9 o'clock position in the right eye. Surgeon's position here is temporal. Cohesive viscoelastic is being injected into the anterior chamber to make it deep. Some amount of cohesive viscoelastic substance is put on the anterior surface of cornea as a coupling agent for the gonio lens. Swan-Jacob direct gonio lens is being used to assess the anterior chamber angle. Now, the 24-gauge needle with bent tip is being inserted under direct visualization into the anterior chamber. The bent tip of the needle is engaged in the trabecular meshwork, and the needle is moved in a swiping manner across the anterior chamber angle to strip off the trabecular meshwork. Now, the needle is being pulled out and rotated the other way so that we can treat the other direction also. In a similar manner,
the band tip is being engaged in the trabecular meshwork and then moved across the antechamber angle. We can note the iris falling back and a cleft being created in the antechamber angle. At this stage, the surgeon's position is superior and the phacoemulsification and posterior chamber intraocular lens implantation procedure is to be started. So a triplanar mean port is being made with a 2.2 mm keratome. Now the capsular axis is being made with the microrhexis forceps. Now the hydrodissection is being done after decompressing the anterior chamber. Now the phaco probe and the chopper is being inserted into the anterior chamber to start the phacoemulsification process. Now, after completion of cortex removal, the capsular bag is inflated with cohesive viscoelastic substance and a 3-piece intraocular lens is being implanted in the capsular bag. After removal of the viscoelastic substance, the ports are hydrated. This is the post-op day 1 photograph of the patient. The anterior chamber was well formed and intraocular pressure was 6 off drugs. In this photograph from post-op day 5, we can see that the cleft is still present and the intraocular pressure remained 10 off drugs till post-op week 3. Further follow-up of the patient is awaited. The bent angle needle goniectomy is an affordable add-on to the glaucoma patients who are in need of cataract surgery, although further studies on long-term follow-up are still awaited. I want to thank everyone for their time.
Sandeep, a nice video.
Thank you.
I just have a few questions to ask.
Yes.
This was an angle closure patient, right?
Yes, sir. Post-iridotomy.
What was the rationale behind doing a bent ab interno needle goniectomy before a cataract extraction?
Sir,
just wanted to know the rationale behind that.
Sir, it has been described both ways, but in general, I prefer to do goniotomy or goniectomy or like the glaucoma surgeries uh, in a naive eye rather than an operated eye. So that's why it has been described to be done after phaco also.
Yeah.
Like the phaco can be done first and then the angle procedure can be done secondly, but I think it's more convenient and for a beginner it's easier because the chamber stability will be better with just one port.
I do partially agree with you. One of the pioneers of MAG is Dr. Swati Upadhyay. She says she does suture gap before she does cataract extraction. But having said that, if we have a open angle scenario, in those patients sometimes the angles are open, right? In an angle closure patient, sometimes we won't be lucky to have the angles open in the first place.
Yes.
Sometimes if the trabecular meshwork is not visible, post a cataract, for the benefit of the neophyte MAGS surgeons in the audience, sometimes I feel post cataract surgery the anterior chamber deepens and that gives us a much better control over the trabecular meshwork. So
yes,
that was one observation that I wanted to ask. And what was the high molecular weight viscoelastic that you are using?
The sodium hyaluronate
Sodium hyaluronate.
Yes.
Were you able to taper the anti-glaucoma medications in the post-op, because 5 medications and you were able to stop it one shot, or how did it go about it?
We stopped it on the day of surgery itself, and on the day post-op day 1, I just noted the pressure, and from there onwards, the patient has been off drugs.
There were no IOP spikes,
No.
no inflammation
No,
or
sir.
anything.
No, sir.
So that was one thing that I wanted to ask. Given my friend Amit, I think he does extensive work here on MAGS. So there is also something called combined MAGS, which again Amit and Saiban, who's not here. So for the benefit of the novice surgeons here, I think MAGS is revolutionizing the field of glaucoma surgery as we know. We not only have the bent ab interno needle goniectomy, we also have the suture GAT, which is a very cost-effective alternate by pioneering by Dr. Venkatesh sir from Aravind and Swati Upadhyay. We also recently have the Tanito hook, the gonio scrubber. They just say that with the gonio scrubber, you just go and scrub the gonio. For the benefit of the audience, I'm just sharing this info. We also have the Tanito hook from the company SP Lat, and we also have the iStent inject and the iStent second generation, first generation and second generation. And I think Amit would agree with me on certain points which we had.
Sorry, pardon, sir? Okay. So because the pressure was well maintained, although the pressure.
But 5 medications, I think 5 medications means oral Diamox as well.
Yes, sir. So the patient
and almost GOA.
Yes, sir.
It's an ideal candidate for TRAB. I feel I would not touch these cases with a MIGS
Yes,
because that's probably the last surgery that this patient's optic nerve would afford.
Yes.
Right. So we want to give the best chance. I think initially we need to do it more in mild to moderate cases
yes,
rather than directly jump to advanced glaucomas. The other thing is, how are you achieving near hypotony pressures with MIGS? That's my question. I think 8 and 10 you mentioned,
10,
right?
yes, sir. 10 of drugs.
How is that happening? Because MIGS is basically opening up the trabecular meshwork and allowing the natural pathway, the
Yes,
aqueous
sir.
to drain through the natural pathway.
Yes,
So I think it will only achieve the physiological levels of IOP reduction, right?
Sir, so the
getting 8 and 10, I don't know. I've not seen 8 pressures with any of the MIGS that I have done. Anyhow.
So the reason for opting MIGS in this patient was that patient was planned for cataract surgery, and MIGS was just an add-on procedure which we planned because the patient's pressure was well maintained
on 5 medications. I think you would do a combined
yes,
surgery, right?
Yeah, combined TRAB would have been done, but it was just thought of as a viable first step instead of more invasive glaucoma procedure.
Almost GO, I think that would be the last step,
Yes,
right?
sir.
So we'll go with the TRAB, I think. Anyhow, patient is doing well. That's the main point.
And
but I would suggest to all the young surgeons that I think initially we need to do it in mild to moderate cases.
Yes, sir.
Right. And TRAB is, the indications for TRAB remains as it is. MIGS is not to replace TRAB.
Yes.
It's to support those patients who we won't do a TRAB because they are in the mild stages, and we need to do a cataract also. In those patients, I think MIGS is the best thing to do.
Yes.
Thanks. Great video.
Thank you, sir.
When you see MIGS in so many different procedures, so if you see something like iStent, you're just inserting a small thing, but in procedures like this and in GAT, you're literally stripping a large part of trabecular meshwork. So shouldn't the IOP reduction be more in this as compared to?
I think this is the same question that I asked in the AIOC last year when I first went to an IC on MIGS, and we don't know the answer. iStent is just taking 1% of the whole trabecular meshwork, whereas in suture GAT we are stripping off the whole. And probably the answer is that we are opening up the physiological pathway. So the IOP reduction would only happen up to a physiological level, right? And stripping out the trabecular meshwork. We are excising this trabecular meshwork in bang, and a suture is just ripping off the trabecular meshwork in suture gap. So the trabecular meshwork, some part of it is still there, and some amount of scarring will happen. So that kind of IOP reduction would happen with bang or say suture gap, whereas iStent is an implant there which is patent, and hence the IOP reduction with only that 2 points of stent, I think, would be much better in the long run also. That's another advantage.
Zain, to add on to that, there are totally two school of thoughts. One school of thought and the pioneers of suture GAT, they are destroying the trabecular meshwork 360 degree. That is the school of thought that down south, Venkatesh sir and Arvind, Dr. Swati, they are all pioneering towards it. The other school of thought that the iStent and the injectables, they say to preserve the trabecular meshwork because we don't really know. We are too early to comment because we don't really know if we destroy the trabecular meshwork 360 degree, what really happens if we add a medication which acts through a trabecular outflow mechanism. So this is a question that has still not been answered. And if we destroy the trabecular meshwork 360 degree, the hyphema or the microhyphema, with iStent we get what sometimes is a microhyphema, but with the suture GAT sometimes we get a macrohyphema. Literature has says that sometimes a peripheral anterior synechiae may also form. So short term, what the iStent group of people are telling in their papers are that the suture GAT or the bang that we just saw, it seems to be promising for a shorter term, but what if a complication such as a peripheral anterior synechiae or those things set in, and the trabecular meshwork which has more properties than just aqueous drainage. They say it has a phagolytic property and many more properties of trabecular meshwork. It's more like a destructive surgery. So that is one school of thought. The other school of thought with the iStent people is preserve the trabecular meshwork. You are just destroying only 1% of the trabecular meshwork. But having said that, to add on to Dr. Amit, I think patient selection is the key. For the benefit of the audience, if it's a mild and moderate glaucoma, and go ahead with the bang or MIGS, whichever is working well in your hands is finally matters. The excisional trabecular meshwork surgery like bang or suture GAT, these are all excisional trabecular meshwork which we destroy the trabecular meshwork, or even the Tanito hook, or you named it. So those are all cost effective. Even we have the KDB which is slightly costlier, but it's still cost effective. If you want to go for an higher economical one, such as the injectables, which is the iStent, so it works, which works well in your hands. Choose it according to your patient. Patient selection is the key. And again, if it's a GOA patient, go ahead and do a trabeculectomy with a cataract surgery. That is one. The second learning point is you can do the MIGS before or after the cataract surgery, but preferably in an angle closure case, I would do the cataract first, deepen the chamber, and then get the angle view and then proceed. But anyway, nevertheless, it's a great discussion that you have your video has generated. Thank you for the video, and very wonderfully done. Thank you.
Thank you, everyone. Take a bow. So, big round of applause for him for getting such great discussion out.
Dr. Nikunj. So this will be the fourth video. Mike.
It's not visible. यहाँ पे भी नहीं आ रहा है.
यहाँ पे.
Hello, I'm going to talk about non-diffractive external depth of focus toric IOL in a post-RK patient with a 16th pulse. Challenges with the post-radial keratotomy eyes are difficult IOL calculation due to irregular cornea, managing patient expectations that they would want a refractive solution, and a different surgical planning as there are so many challenges intraoperatively. In current era of presbyopia correcting IOLs, we have a lot of options in the form of diffractive IOLs, but they have limitations when it comes to post-radial keratotomy eyes. I'm going to share a case of a 55-year-old gentleman who had undergone radial keratotomy for his high myopia 30 years back. His refractive error showed mixed astigmatism. He had grade 3 nuclear sclerosis and 16 radial keratotomy cuts. The first step in managing such cases is counseling of the patient, and you need to give your chair time to explain that it is difficult to achieve independence completely from glasses. The second step, and one of the biggest challenges, is to determine the correct spherical intraocular power calculation in such eyes, as best of the best IOL 700 also had blank report. The corneal topography showed flat cornea with little bit of irregular astigmatism. For such cases, we need to use online calculator for post-RK patients provided by American Society of Cataract and Refractive Surgeons, where we need to fill the data including post-RK refraction, pre-RK refraction if it is available, and data from corneal topography and optical diameter. So at the end, it will provide us a range of IL powers, and we need to determine which one we need to put. For post-RK patients, we aim to target myopia postoperatively, and in this case, I decided to implant 26 diopter IOL. Next step is toric IOL calculation, and for that, it is important to know which keratometry values to use. After comparing the keratometry values between IOL Master and the topography scan EKR map, I decided to use the values from 4.5 mm EKR values, which showed 2.6 diopter of astigmatism. The toric IOL calculation was done using online calculator. The next step is surgical planning. After doing reference axis marking on slit length, the final toric axis marking is done before starting the surgery. The side port incisions are made between the RK cuts. Avoid overfilling of the OBD in the anterior chamber. I decided to make transconjunctival sclerocorneal incision in this case, as this was a case of 16 cut RK and there was a very little space between the two RK cuts. Coaxial illumination helps to get the better view. Capsular axis is done of a circular fashion of adequate size, just like a routine case. The phaco parameters also needs to be changed, and low irrigation, low IOP, and low vacuum needs to be used. It is important not to let the anterior chamber collapse and always inject OVD before removing the irrigation source. Irrigation aspiration of the cortex is done just like routine case. A 26 diopter non-diffractive EDOF toric IOL is implanted into the back. It is very important to remove OVD from behind the IOL before aligning the toric IOL to the final axis. The patient had good visual and refractive outcome, and he was able to read 612 for distance and N10 for near without glasses. Thank you so much for your kind attention.
That was actually an excellent video. Very, very difficult cases to manage.
Thank you.
And beautiful video. So I have one question. How did you choose the lens? Like with what basis?
Gentleman, and I sat with him. I discussed the options. He actually wanted a trifocal because he heard about trifocal somewhere that you don't need glasses. Yeah. So all those questions also, they come with expectation of trifocal. So I straightforwardly said no to that, and I told sir that we can do something which can work, but I still don't know. And before planning this case, I discussed with multiple people also if somebody has tried that also, like Dr. Shell Vasad I also discussed, and few other people, but they all said that they have not come across a case where they've implanted a EDOF toric in a post-RK patients. Then I was searching everywhere, if I can plan it or not. So then I came to see about a video by Dr. Kim and Dr. Uday Devgan also. He was also against all this, any kind of EDOF or obviously trifocal is a big no, but even EDOF in a post-RK patients. But Dr. Kim has shared few more cases like that, and he has done VVT toric no financial interest in a post-RK patient and got excellent results. So important thing was that I explained the patient that I cannot give you complete independence from the glasses, but whatever best refractive possible outcome we can plan, because refractive surprises after RK is it's a known thing, so we cannot promise that. So because of the patient's wish, we went ahead with this IOL.
That's excellent. That's a very good option where you can use an EDOF, because these are patients who are very demanding.
Yes.
and they want glass independence, which we cannot give them.
Absolutely.
And their visual quality goes down if they get a trifocal. So
Yes.
how was the visual quality post an EDOF? Like,
He's extremely happy because another thing was because he also had a grade 3 nuclear sclerosis cataract with a RKI, so the contrast for him was already very poor in that eye pre-operatively. So the difference between pre-operative and post-operative was amazing for him. He is able to use his mobile phone independently without glasses with that eye. Other eye is yet to be planned. And for distance also is quite comfortable because pre-operatively he had a mixed astigmatism, plus he was hyperopic actually. So even when I have made him little bit of myopic, he's happy because by default he was actually myopic, right?
excellent case and very, very nice tips that you gave throughout the surgery.
Thank you so much.
Very nice video, Nikunj. I strongly would emphasize what you did with the scleral incision, the slightly limbal to scleral incision, because that is a very, very key point in the surgery. Otherwise, I've had a patient one where
RK
the
cuts are
cuts opened up sequentially. The question for you is regarding how do you choose a toric in RK patients, whether to implant a toric or not based on the EKR? What do you look at specifically in that?
So in EKR map, we look at the keratometry values in a different zone from center to periphery, and I still compare it with the whatever IL master is giving me, because that will give me around the area of 3 millimeter zone. So, and I compared it with the EKR map, and I took the 4.5 millimeter values because that is recommended. There is still a debate that you can take a little central values also, but I mean it is still a topic for debate. But in this case, obviously you have to look at 4.5 millimeter zone EKR map and take the keratometry values from there, and you can include that in your toric calculation.
So one thing I also do when I'm looking at the EKR is how the keratometry is changing on
changing
1,
over the
2,
zones.
3, 4.
Yes.
Because sometimes it varies very grossly, and in that case, if your axis is changing very grossly or your values are changing, then maybe a toric is not a great idea.
Absolutely right.
Whereas
Absolutely
if you have a more kind of regular gradation of it, then you can go for a toric.
So if the change is also a smooth way, it is increasing in a particular manner from center to periphery, then also you can plan. But if there is a gross discrepancy between 1 millimeter and 4 millimeter, definitely you would avoid a toric, even monofocal toric also in that case.
Nikunj, great video. The rationale behind how you are choosing was very well emphasized. Keep it up. Yeah.
Thank you so much. Thank you.
So, big hand for him. Come on. Next.
Experience is a double-edged sword. We often tend to follow what has worked for us in the past, and our creativity to innovate something new takes a beating, as we do not stimulate our mind enough to develop new methods of doing the same thing that we have been doing over and over again. A subluxated IOL is like a sinking ship. It could be subluxated in multiple quadrants or clockars. To decipher how you would reduce that IOL back complex becomes extremely challenging in each and every case that we deal with. We have been taught to remove a subluxated IOL and implant another intraocular lens in the eye in order to restore vision. But what if we could implant the same subluxated IOL without explanting it from the eye to restore vision of the patient? What if, by reducing the manipulations that we do in order to explant and then reimplant another IOL, is markedly reduced by a technique wherein the chances of using the subluxated IOL are heightened by more than 90%. In this video, we will be demonstrating a case series wherein we have saved the IOL that was subluxated, granting restoration of vision to the patient with a favorable long-term outcome. We begin with loosening the anterior capsular adhesions from the lens in order to free the back complex. We then pass a 9-0 Prolene suture through the limbus and railroading it with a 26 gauge needle from the opposite side 2 millimeters behind the limbus. This needle goes within the IOL back complex, through the capsule, underneath the haptic, and comes above the optic just underneath the capsule. To facilitate this maneuver, one could also hold on to the capsule and give counter traction so that the needle can be easily passed. Once the needle is out anterior to the optic of the lens and posterior to the capsule, you railroad the 90 proline from the opposite side into the hub of the needle. This procedure stabilizes the bag and we get a good hold on the IOL bag complex like a noose. The second needle is passed from 1 millimeter behind the lens parallel to the previous needle which comes out of the pars placata region above the capsule. The second arm of the 90 proline is fed into the hub of the second needle and you pull it out on the same side. As a result of this, a loop is created of the 90 proline, due to which a U-shaped knot is formed that brings and holds the IOL bag complex in its place. Repeat the same procedure on the other side, 180 degrees from your initial maneuver, with one loop passing through the bag, below the haptic, above the optic, and in front of the anterior capsule, which is holding the bag in place. In order to achieve more support and stability, you can repeat the same procedure perpendicular to the previous two knots. This gives additional support at places where there is onular weakness. Once the lens is secured, you can tighten the loops on either side so that the lens is centered and stabilized. Do not tie the suture one at a time. Only tighten the suture when both arms of the needle are out on both the sides. Otherwise, the lens would be pulled on one side more than the other. We have had a long-term follow-up of these patients. The lens remains steady with a follow-up of 18 months post-operatively, with the initial subluxated lens being central and well supported by the loops created by the surgeon. This innovative new technique holds much promise for all young surgeons in the future. Thank you so much for your kind attention.
It was a very nice video and I think a good number of animations and very well presented. So you used all the AV module modalities there. So is there a certain certain clock hours of subluxation below which you would say that this can be done, or beyond which this should not be attempted?
So basically, we've done it in about, even a case in about 7 hours of 7 clock hours of subluxation, more than 6 clock hours also, and we found that the lens was saved, the bag was stable, and actually the main thing here is we've had a long-term follow-up of 18 months in these patients, and they're doing very well. There's absolutely no change, because we documented on anterior segment OCT also. There is no change in the positioning of the bag or the lens. So we've done it in more than 6 clock hours also.
And what is there more PCO formation or risk of that happening because of some inflammation?
Not till now. Not till now. We haven't seen it till yet.
And do you think a regular capsule
maybe in the future, yeah, that could be a thing, but at least 18 months follow-up we have not seen it yet.
Right.
Dr. Rohan, congrats on such a wonderful video and an innovative technique.
Thank you.
What is the learning curve and what are the complications that a novice surgeon has to anticipate? Or it was such a wonderful video, but beyond this,
yes.
What are the learning curve and the complications that we should encounter in this procedure?
So basically, in some cases, the capsule is so fibroized that it becomes very difficult for us to pass that needle through. So for that, holding on to the capsule with a microrhexis forceps and then passing the needle gives a counter traction. Now that counter traction then helps you, just like you're doing it on the sclera, same way. The only thing is that you're doing it behind in the capsular bag. So that is one thing that is important, that we have to first decipher that how much fibrosis is present over there. Because the first step is actually to loosen that fibrosis that is all around over there. If you have been able to loosen that fibrosis that is all around over there, then you can go ahead with this technique. The other beauty of this technique is that you can actually abort at any stage, right? And you can go back to the normal thing. You can go back to removing that entire, either the lens or the entire complex if the need be, and then implant maybe a iris claw or a scleral fixated. But in our experience, what we have seen is that most of these cases, if they come back to us not too far from their initial surgery, then that bag is not that fibrosed. So then we can
During the initial stages, were there any cases where you had to abort and explant, or how did it go about it?
One case we had to, yes.
Yeah, thank you.
Rohan, very nice video. Just a question regarding pupillary dilation and what kind of role that plays in this, because I noticed the pupil is a little bit smaller in yours. Do you generally dilate the pupil fully, or?
Yes, we generally dilate the pupil fully. We would like an ideally more than a 5 millimeter pupil in this case. So that basically, again, it's all about that fibrosis. Where that fibrosis is coming from, that should be visualized. If that can be visualized, then it becomes easier.
And did you consider putting any iris hooks in this or anything?
No, that would make it more manipulative. Like the whole point of doing this is that you don't want to remove that entire thing and put another thing in. You want to basically use whatever is already inside the eye. So no.
Thank you.
I think take a bow for a finalist for today for the Oscars. Please come. Dr. Rohan Mehra, everybody. So as Zain is collecting and doing his math, we have the People's Choice Award. So everybody get ready to give your vote by a shout so that everybody gets up early in the morning. So you have to say yay in no specific order. For Dr. Aarti Heda. Yay! Come on, be louder, come on. Okay, so Dr. Rohan Mehra. And Dr. Sandeep. And Dr. Anujun. And for a final one. All right. So we have a clear winner. Judges, whose was the loudest? So our People's Choice Awards, I'll ask Dr. Karan Bhatia and Dr. Aditi to come on stage and give Dr. Anujun the award for the People's Choice Best Video. If Zain is slow with his math, we might have Dr. Prasanna do a 1-minute dance. Huh? No, it's impromptu. No license for impromptu dances. All right. I would like the judges to tell us how difficult was the competition. So, Dr. Digvijay.
I think it was very close. I was totaling my scores and I was wondering, have I given everybody very similar points or not? But it's a very close thing. I think what stood apart in some of the presentations was the use of animations and certain AV modalities and graphics that helped out. But I think each of these cases was unique in its own way and well presented. Excellent.
Dr. Ramya?
All finalists for a reason. The judging was very, very close. And because they were all such different parts of the eye, it's very difficult to compare. So we gave marks and then we saw that it was very, very similar. So only when we add, we'll also know the result.
Dr. Rashad?
Yeah, I think it's very difficult to separate between them, especially because they're different areas. Probably you'll have to create categories next time. I think it's kind of difficult.
We had great number of videos. And Dr. Prasanna, ready with your dance? Oh, the awards are inside.
Congrats on a wonderful session, Zain and Aditya. I think it was a great learning for us also, I believe. And all the 5 videos were equally good. And as Digvijay sir told, it was all kind of very, very difficult to judge. And each one of the videos content were much better with a lot of animations, audio quality, and it was very short and crisp. It was very succinct. I think the audience also would have learned a lot.
A big hand for all of our videos. I would request the judges to come and center of the stage for the announcement. You can tell them in the So the best video goes to Mementos. Okay. So can we have all our finalists on stage, please? One after the other. So Dr. Anujun, please come. Also the recipient of the People's Choice Award today. Big hand. Dr. Aarti Heda. Dr. Nikunj. Excellent video. Dr. Rohan Mehra. Great work. And Dr. Sandeep. Excellent. I would also request Dr. Digvijay to felicitate Dr. Rashad. For his excellent judgment. And Dr. Prasanna to felicitate Dr. Ramya. And now what we've all been waiting for, the winner of today's Oscar goes to Dr. Nikunj Tank, who didn't tank this. Big hand, everybody. Clearly the organizer. Can we also get all the nominees on stage for a group photo?
For us today, and I think in a wonderful way. About to close outside, and if anybody wants to have breakfast, please have it there, and please collect your participation and faculty certificates from the registration counter.
So moving on to the next session, publish, ponder and prosper. So I'll request the panelists for the session, Dr. Prasanna, Dr. Rajat, Dr. Neelam and Dr. Rolika to please come on the stage. So this is the journal club session. We have a monthly YOSI journal club activity. So, so based on that, we have designed this session. And a very good morning once again. So I'd start with the introduction of panelists. Our first panelist is very dynamic Dr. Prasanna Venkatesh Ramesh. He's a research director and glaucoma head at Mahatma Eye Hospital at Trichy, India. Then we have Dr. Rolika Bansal. She's pursued a fellowship in ocular oncology and oculoplasty at Center for Sight, Hyderabad, India, under the preceptorship of Dr. Santosh Honavar. Then we have Dr. Rajat Kapoor, who is an ex-fellow and consultant in pediatric and neuro-ophthalmology at LV Prasad Eye Institute, Hyderabad. Currently is working at Pushpagiri Eye Institute, Hyderabad. Then we have the next panelist, Dr. Neelam Khatwani. She's a vitreoretina fellow at HV Desai Eye Hospital, Pune. Moderator would be Dr. Anujit Paul. He's pursuing his vitreoretina fellowship at BBI Foundation, Kolkata, and myself, Dr. Noorpur. So, and the other panel is Dr. Sonal, who's also our YOSI president. She could not make for certain health issues. Before we begin our journal club, we'll just have a pre-recorded comments on the journal club by her. I'll just play this video. Can we have the audio, please? There's no audio to the video, please.
Start a research-related group for the webinars for Young Ophthalmology Society of India. Hi everyone. So I wanted to start a research-related group for the webinars for Young Ophthalmology Society of India. You see, I felt that to really understand the language of research papers takes lots of efforts on one's part. There are subtle nuances, and building on that understanding is the very first aspect to building on our capabilities to write and get published later after completing research successfully. Study designs and biostatistics are complex subjects too. Dr. Sunny Sen Gupta sir, the assistant editor IGO and one of our senior YOSI members, was instrumental in starting this and helping us and guiding us. He was one of the driving forces behind starting the YOSI Channel Club for YOSI members. I believed in his directions and I spearheaded the program, taking help from the members of YOSI who were really dedicated towards the cause. From being clueless hunters of seed articles for thesis during your first year of residency to published authors, at all stages one needs to learn the subtle differences of words in scientific writing. Whether you are a fellow who wants to devise better research hypotheses, or you want to improve on your surgical results, or you are learning how to write responses to reviewers, then also you need to really understand scientific ophthalmology publications in detail. So journal clubs benefit us all at all stages of learning and beyond. I must congratulate Dr. Anujit, Dr. Nupur Goyal and all the team members of YOSI Journal Club for doing an arduous task month after month with great dedication. Thank you so much for involving me in this session.
So that was Dr. Sonal Kalia, who was the spearhead of the Journal Club sessions. We've having this regular activity, very successful sessions. So thank you, Dr. Sonal. So moving on to the first talk, how to interpret a journal article. So we need to understand the need and the purpose. Why do we really need to know? And then we'll go on to how we interpret. So what is the need and the purpose? Not only to determine if the study has merit, but to also understand how it relates to clinical circumstances. And does the research study actually apply to your clinical practice? If so, how? So how? Now we go on. It's always good to go by a step-by-step systematic approach. So for this, we have a MARI algorithm, which was proposed by Riegelman in 2005. It stands for the acronym Method, Assignment, Assessment, Results, Interpretation, Extrapolation. So I'll be covering each of this in detail. So MARI is the acronym for method. So this involves identifying key issues about study hypothesis, population, and sample size. It's basically to identify whether you need to assess whether the article is giving you clarity about what was studied, how the study was conducted, and who participated in the study, and also the power of the study. The next acronym A stands for assignment. So how the participants were assigned into groups. So you identify any confounding variables, any masking or blinding. Are the participants or the investigators aware of the participants' assignment to a particular study or control group? Then you move on to the assessment. So this is measurement of the outcomes or endpoints in the study and control groups. So whether the assessment which was mentioned in the article was appropriate, that means whether the measurement of the outcomes, does it address the study question, whether it was accurate and precise, that means is the measurement or outcomes, it's a phenomenon that the investigators seek to assess, and it is complete and unaffected by observation. So is the follow-up of participants nearly 100% complete, and is it affected by the participants or the investigators' knowledge of the study or control group assignment? Then you look out for the results of the article. So this is comparison of outcomes in the study and control groups. So estimation, what is the magnitude or strength of the association or relationship? What is the inference? What statistical techniques are used to perform statistical significance testing, and any adjustment? What statistical techniques were used to account for control or potential confounding variables? Then you move on to the interpretation. So this is the meaning of the results for those who were included in the investigation. So the points that you need to look out for are contributory cause or efficacy. Does the factor being investigated alter the probability that the disease will occur, or work to reduce the probability of undesirable outcomes? If there is any harms and interactions, and if the subgroups, the outcomes observed in the subgroups within the investigation different from the outcome observed in the overall investigations. Next, coming to extrapolation. So this is the meaning for those who are not included in the investigation. So whether you can apply the similar results to similar individual groups or populations. So do the investigators extrapolate or extend the conclusions to individuals, groups, or populations that are similar to those who have participated in the investigation? Can it be extrapolated to beyond the data mentioned in the article? So do the investigators extrapolate by extending the conclusions beyond the dose, duration, or other characteristic of the investigation and to other populations? Do the investigators extrapolate to populations or settings that are quite different from those in the investigation? So this is the crux we follow to critically analyze an article, and this is the method that we are also following in a YOSI journal club. This was something which we were introduced to during LVP. Dr. Rajat and Dr. Weber would agree to that. So you go step by step systematically. So it's easy for you to, all your points are covered, and then it's easy for you to understand that what are the merits and the demerits of the article, and if you can actually apply it in your own clinical practice. So relevance of the journal clubs will be further covered by Dr. Weber and Dr. Ayushi. So my take home message would be, follow a systematic approach, step by step approach. Mari is a good algorithm to follow. Keep practicing. So how you can practice is, keep attending journal clubs, more than attending, try to present. So that's how you can do well. So thank you very much. So I would like to invite our next speaker, Dr. Weber Sethi. He works at Arunodaya Deseret Eye Hospital as a vitreoretinal surgeon, and sir is going to speak about relevance of journal clubs in clinical practice.
Hello everybody, how are you? And I hope people on the breakfast are back. Shall we wait for 2 minutes? What was the breakfast menu today? I missed out. Okay. So relevance of journal clubs in clinical practice is very important, because that's why we're going to be, that's the main reason why we learn and to apply. So let's take you across to some interesting scenarios. In private practice or in clinical practice, we come across many scenarios and have many dilemmas. Okay. The only thing that really helps is going back to journal clubs and looking at the evidence, because evidence is the key. So I will not be taking you through anything in detail, but let's see what we see in a clinical practice. Clinical scenario number 1. This patient is a diabetic. He has center involving diabetic macular edema. Vision is 6 parts. His systemic parameters are normal. I'll ask the panelists, what would you do in such a case? Anybody from VR would like to answer this? Just a short thing. Would you treat?
Yes, I would.
Good vision, central involvement DME comes into your clinical practice. Parameters normal. Would you go ahead and treat this patient? Would you inject? What would be the evidence behind it? So
The evidence.
you can observe.
We will try to
Cut it short.
give, intravitreal injections. We
Correct.
will
So
go for it.
we can, but studies have shown, protocol V, DRCR has shown us that these patients, if the vision is very good, better than 6/9 over 2-year period, you can even observe them if the vision does not deteriorate. That's very important. Clinical scenario number 2. This patient's vision has worsened. Now it's 6/18. Which anti-VEGF would you choose among your armamentarium? That's the dilemma you normally have, right? So if the patient is affording, okay, keeping that aside, which anti-VEGF would you choose? Anybody like to answer, and why? I mean, there could be many, but there should be some evidence behind your decision. So protocol AC recently has published. No, these evidences are a backbone. We don't always have to rely on it, but they give you a basis on which you can treat. Aflibercept monotherapy has been shown in a head-on trial versus bevacizumab over a two-year period that it gives you better visual gains and better macular thickness. In the study, the patients who were started only on bevacizumab, 70% of these patients had to be switched according to the switching regimen to aflibercept over the 2 years, of course. So something, if the patient is affording, and nowadays there are patient support programs, it could be a very good idea to start with aflibercept. Clinical scenario number 3, proliferative diabetic retinopathy. Patient is compliant, sorry. What treatment would you choose in the case of PDR, and what would change your decision making? Would you do a PRP, or would you give an anti-VEGF monotherapy initially and deferred PRP later?
We will do an OCT first to see whether macular edema is there or not.
Correct.
And whether it is center involving or non-center.
So if DME and PDR is there, then what would be your choice?
If there is no macular edema, we will first go with PRP then.
Correct. So exactly. So protocol S has shown us that though if there is coexistent DME on OCT, anti-VEGF can be considered as an initial therapy. But we have to keep in mind that the gold standard remains PRP. You can only give it to some extent, and later on the patient must also receive PRP. So there is no substitute PRP, like there is no substitute TRAB later on. Same way, but anti-VEGF can be given initially to control the disease. But there is no DME and the presence of substantial traction, PRP should be done. So, patient has PDR, he is not compliant, he is staying very far away. Now the plan is PRP, but patient normally we do PRP in more than one session. So what can you do it all of the PRP in a single sitting? Is it safe? Can it increase your CME levels? So yes, we can. Yes, we can. Protocol F tells us yes, it's possible. Because if you do it in one, if the patient tolerates, if you're doing the multi-spot laser, you can do it with no increased risk of CME. Scenario 5. Patient has rebound DME, you treated DME, comes back. When do you re-inject? Do you re-inject immediately looking at the DME, or are there some parameters you can look into your clinical practice? So you can follow a 5-10 rule. If the visual loss is more than 1 line or 5 letters, or more than 10% increase in the central macular thickness, protocol T has suggested you can treat. Again, when to switch in after 2 injections of anti-VEGF, if there is still the 5-10 rule can be followed. If there is less than 1 line gain or less than 10% reduction in the central macular thickness, then you can switch or stop treatment also. So this patient in my clinical practice came. You can look at the clinical picture. Patient has big drusenoid PEDs with pigmentary mottling. This is the OCT. You can see subretinal fluid there. What do you think the diagnosis would be? We do an FFA. I did an FFA with this patient. FFA was, there was no leakage, only late staining. So the question here is, what are we dealing for? Would you treat this patient with anti-VEGF? There is subretinal fluid. Or would you go back to literature and look at something else? Because in FFA you will find leakage if there is subretinal fluid, right? You will want to treat that. So this is basically a non-neovascular AMD with subretinal fluid. So there's an entity now which we know, which is non-neovascular AMD. So you don't treat, you don't inject such patients, you just observe them. And finally, some other OCT biomarkers like basically minimal subretinal fluid over a CNVM can be left. It's been shown by fluid study, and intraretinal fluid findings and other findings like outer retinal tubulations can give you the visual prognosis over a long term, can help you counsel the patient. So evidence-based practice is very important. Thank you.
So thank you, Dr. Weber, for adequately bringing out the relevance of journal clubs in clinical practice. So I would now invite our next speaker, Dr. Ayushi Agarwal. She also recently won the Best Journal Club Award for a Plasty article that she had presented in July 2022. So Ayushi is a clinical and research fellow in ophthalmic plastic surgery and ocular oncology services at LV Prasad Eye Institute, Hyderabad. She is the associate editor, team Bioslides, and she'll be talking about the relevance of journal clubs in residency and fellowship. So over to you, Dr. Ayushi.
Good morning, everyone. Thank you, Dr. Nupur and Dr. Weber, for the wonderful talk, and thank you, Yosi, for the wonderful opportunity. So most of the times, we are allotted a journal club in our residency and fellowship in our academic schedule without having a formal discussion about what it even is. Do they really add anything to our already hectic lives? And the most recent question somebody asked was, if an article is published in a good journal, then why are we even critically appraising it? So yes, despite all the resistance that we face as residents and fellows, we do need journal clubs. So let us find out why. Journal clubs inculcate reading habit, which is a fundamental part of any residency and fellowship training. It also builds up your presentation skills, and both these qualities are important and should be mastered as early as possible in one's scientific career. Journal clubs keep you updated on the current literature. Now, be it a trial or any epidemiological study or cutting edge technology, recent advances take time to reach the book pages. Also, it is useful for residents from a thesis perspective where they can identify the lacunae and subsequently build their protocol around it. Journal clubs promote a research mindset by enhancing your curiosity and creativity. It also helps you understand the art of manuscript writing and any relevant specifications particular to your journal of interest. Now, we all know that statistics can be a real struggle, and hence, incorporation of a clinician researcher in your journal clubs can be a real asset. JCs familiarize you with the concept of Table 1, which is usually the descriptive stats of any original article, the tests of significance, the what, when, and how, and an important thing that what's statistically significant is not always clinically significant, and vice versa. Now, JCs also develop your critical appraisal skills. In a world of publish or perish, learn to filter out what's relevant for you, as not everything is a take home. Critiquing a paper will not only build your critical thinking skills, but also improve your research knowledge by analyzing the paper for the presence of bias, confounding, and learning strategies such as randomization and blinding. You also learn to look at the quality of the paper through a checklist approach. I recently had a journal club on this systematic review and meta-analysis, and it was the first time I came to know about what PRISMA guidelines is and what they consist of. JCs prepare you for an academic debate, which is a difficult science in itself. Here you may have a difference of opinion for that article of discussion and yet respect the other's perspective. Journal clubs also help you in practicing evidence-based medicine by bringing research to the clinics. We recently had a journal club on the prevalence of sleep apnea with floppy eyelid syndrome patients, and we found that almost 57% patients who presented with this disease had sleep apnea, and more than 79% were diagnosed at the time of the study. So this led us to incorporate a screening tool in our OPDs for sleep apnea in these patients. Know your authors, their area of study, because it also provides a window for professional networking and potential collaborations in future. So this was a landmark study explaining the benefits of selenium in mild thyroid eye disease by the European group. But the question remains, is selenium deficiency also prevalent in other population, and does selenium have any role to play in that subgroup? So journal clubs also help you in realizing the epidemiological bearing the proposed article can have. They enhance your skills as a group leader rather than just having a primary didactic role. It is scientifically proven that these kind of journal club formats can bring about excellent leadership skills in the students. So in order to ponder, publish, and prosper, start early, start now. Your critical appraisal skills will enable you to write letters to editors, which in itself is not an easy job. It also provokes you to formulate your own research question, and maybe you can publish your own study in the future. It also provides you an opportunity to be a better reviewer for top-notch journals in the future. So in our institute, we have 2 journal clubs almost every week. But not all academic institutions have the same education structure, and hence JCs shouldn't be limited within the walls of that institution, and for that we have the virtual journal clubs. So we have AIO Ophthalmology Journal Club, but it is exclusively available for the AIO members, but the recorded version is available to all after the event. We have Dr. Sen Gupta's Research Academy. You can just drop him a mail and you can ask for a group or a one-on-one discussion on the journal club. Then we have the YOSI Journal Club, where we have a presenter, a monthly mentor, 3 experts talking in for and against, including recent advances. We have a research expert and a moderator, and I was fortunate to be a part of it twice. Then we also have the ACRS Journal Club, the iWorld by the University of Iowa, joint journal clubs, and the state societies. So to conclude, I would like to quote Sir William Osler, who is credited with the first organized journal club. So he said, journal clubs should afford opportunities which after graduating you never obtain, of learning how to prepare and express your ideas correctly. Having said that, the relevance of journal clubs is not restricted to residency and fellowship, but goes beyond it, as Dr. Weber has beautifully explained. So thank you all for your patient listening.
Thank you, Ayushi. That was a wonderful presentation highlighting the relevance of journal club when you are in training, and I hope this will motivate more and more VIOs to participate in the journal club activities. So thank you once again. Now I would hand over the mic to.
Once again, I would like to add
Sure,
one
please go
pointer I would like to add. So that is that I agree with Ayushi. I think most of the times when floppy eyelids patient come, I land up asking them, do you sleep your face down or do you have sleep apnea? It happens to be true. So that is there. And one more thing I would like to add, when you are having a journal club session, try to criticize the paper also so that you learn how to review.
Right.
So whenever the paper is going on, like, you have, as you said, you have to see the pros and the cons as well. But it's a training for a reviewer as well. So when you start looking, start calculating, okay, so maybe this number is right or wrong. This will just help you. So journal club is not just for knowing the subject, it's also for knowing every step of research. So it's
So that's what we follow the Mari format, as I mentioned in my presentation. Going step by step systematically, it helps you bring out the good and the bad in the article, and then take it forward. And yes, as Rolika mentioned, it also gives you practice to being a good reviewer as well. Thank you, Rolika.
Thank you.
So now I hand over the mic to my co-moderator, Dr. Anujit, who's been a very crucial part of the Journal Club team. I'll hand over. You can take over the next session.
Thank you so much, ma'am. I would like to call Dr. Anujun ma'am to this podium, and while she's preparing, there is a short introduction for her. However, ma'am needs no introduction. She's been a prolific part of journal clubs and YOSI events for a really long time. Just to summarize her long CV, she is an assistant professor of glaucoma services at GNNC Maulana Azad Medical College with over 50 PubMed Index publications and numerous awards. With that, I send the mic to Anu ma'am to begin her presentation.
Thank you so much for the kind introduction, Anujit. Always very humbling to be a part of YOSI. So I'll be talking about publishing in residency, a foundation of good academic career. So once you enter ophthalmology as a resident, you want to be a good clinician, you want to be a good surgeon, an academician participating in activities like this, which are meant for the young ophthalmologist, and a researcher. But why do this research, or why publish? It helps you to leave a permanent mark etched in the pages of history and have a global impact and be known. It's also mandatory for a few government jobs. It helps you to be a part of the research community, and once you've done a lot of significant work in your field, you might even end up being the authority on certain factors. The academia has evolved from publishing to publishing or perishing, and now publishing and you may not perish. So we all look up to certain role models in our post-graduation or residency. These are a few of them, and we see the publications, and we're in awe of them. And we also have our very own your role models like Anirudh, Prasanna, Akshay sir, Nilesh, who've had more than 100 publications to their credit, which is incredible given their small journey. And this helps to have the impact, the author impact, which is measured by certain indices like the G index, the H index, the I-10 index. Just to tell you briefly, the H index is the number of articles which have been cited that many number of times. So if you have 6 articles which have been cited 6 number of times, your impact factor your H index becomes 6. And for that, you need to have high quantity articles as well as high quality articles which get a number of citations. But for this, you need to be publishing regularly and for a long time to have those many number of citations. So that brings us to the question, when to start? There is no better time than now. The earlier you start, the longer years you have for that paper to be on record and for getting more number of citations and improving your impact. Now, there are numerous benefits of starting in residency. One very big advantage is that you have a mandatory thesis writing. So it's not a choice. You have to do it. It's one of the original studies, thoroughly supervised, so the onus does not just lie on you. You have a comparatively very large sample size with a very long-term follow-up of probably 1 or 2 years. And you already have a well-written detailed manuscript by the end of 2 to 3 years. So, it's just a small task to copy and paste that into a research paper. You also get exposure to research orientation programs and exposure to ethics committee and statistics as a part of your curriculum, instead of, actively having to work for it. You have the mentorship of your team, which consists of professors or thesis supervisors, your senior residents or fellows, your senior PGs, and your co-PGs also for moral support. And not just your thesis writing, you're sitting in the OPD seeing cases on daily basis. And you can take part in different roles. You can have different types of publications. You see some unique case and you're not very good at writing, so you could just take a clinical image, write a brief description of maybe a paragraph and send it across. You've come across a case which looks different to you, haven't seen it before, just write a case report. It hardly is 1 or 2 pages. If you come across 3 or more cases of a similar thing, you can write a case series. Once you're towards the end of your residency and you have a good exposure to your subject and a good knowledge, you could write letter to editors after going through the articles in published journals. And if you're really interested and keen and hardworking, you could go in for the original articles as well, along with your thesis. You could also take part in different capacities, and that's the beauty of writing in post-graduation. You don't have to do it all. You can choose what you're good at and just take up that particular. You could just go into data collection or patient recruitment or slit lamp photographs or the manuscript writing or uploading. So you'd be a part of that paper in whichever capacity. And with time, your performance increases and you can achieve more in less time and becomes less stressful, and you can achieve bigger goals with smaller actions, which improves your overall quality and the impact. So an early start is a smart start, and there's no good time than starting now. And what might look like a Herculean task right now, by the end of residency, you'd be going kicking, and you could take up all the roles that were previously described, and a patient comes to you and your research minds become active. Thank you.
Thank you so much, ma'am. I think the best message here is to just start. And it's not about being perfect and having the perfect start, but to just start and then aim towards perfection. With that, thank you so much, ma'am. I would like to invite Dr. Rolika Bansal, ma'am.
I like the way how you told if there is no good content for an original article, start with a case report or ophthalmic image. I think me and Anujit were also having that same discussion. I think that is very vital for a neophyte, because people try to start with a review article or an original article and they end up not finishing it up and they lose the interest in publication. So I think even a good case report or even a striking ophthalmic image, as you said, that starts the seed for the first or second article, then it becomes a habit. I think very well highlighted that.
It always gives you a push and motivates you
Yeah.
further once you've achieved something significant.
Yeah, so you
rather
finish
than
something
being-
small and then that was a very lovely point. Yeah.
Thank you so
Thank
much.
you.
Thank you, Anujit.
Thank you, ma'am. I would now like to call upon Dr. Rolika, ma'am, another personality who needs no introduction, a superstar in her own right. Just a brief introduction while we wait for her to start off. Dr. Rolika, ma'am, pursued her fellowship in ocular oncology at Center for Sight, Hyderabad, under the guidance of Dr. Santosh sir, and is now going to go ahead with her international fellowship at the Wills Eye Hospital, Philadelphia, in the United States.
Thank you so much. Thank you for that shortest. Thank you very much for the shortest introduction, and thanks everyone for putting this together. I'm sure that the OC team has not had it easy. It has been very difficult, and thanks a lot. So I'll be talking on writing case reports and original articles, and as Prasanna sir said, we should at least start small. And I would like to put it and reframe it as all things are difficult before they are easy. And my disclaimer would be I have no financial interest, but let's move on to this slide, and that is I'm not a procrastinator. I'm just extremely productive and unimportant things. How many of you can relate to this, right? And how many of you have made your slides like last night, yesterday, or day before? Max. Today, like me. So you come in the category of serial chillers. So congratulations, you're in my team. I definitely am the pro at procrastination, and I must warn you about this addiction. So that is my disclaimer. Wherever you are, whoever you are, it will find you. This is an addiction, and this presentation is full of hypocrisy. So kindly remember that. So this is exactly how my mind works. Like when I have to start my paper, I have 1,000 things which I really might not even think about, and those things will definitely pop up in my head that very moment. And I will take you through the 7 steps of writing a manuscript in a very short way. And that would be, the first would be topic case selection. So this is now we are talking about the theoretical part. So topic key selection is very important. It's important for us to understand what is new, and like if you have a new clinical condition that you're looking at, or any unexpected association, a new mechanism of pathogenesis that you're trying to establish, a novel diagnostic tool, innovative treatment modality, adverse effect. Remember, you have to talk about something new, logical, and something that presents a clear message out there. So your paper must be something to add to the pool of existing knowledge. That's quite important. It's not just about writing a paper, it's about writing a relevant paper. Next part is the review of literature, which is quite important because I would consider review of literature as the second part and not like the third or the fourth part, because I need to know what is there. Like an innovative idea might be in my mind, but probably it's been done 10 years back. Right. So you should survey whatever is available. These are the facts that we know about. Digitalization has significantly increased, and it is now easier rather than going to like the old school libraries. We have, thanks to Sci-Hub and PubMed, etc., that we have everything available. So it's important for you to understand the search engines. These are the search engines that are available, and I'm sure that you all know about it. I would just say that this is a search engine that I prefer, and I have a reason why. So this is the reason. As you can see, this is on Google. When you search, it's like 7,30,000 which come in the same search results that come with the same topic. When you move on to Google Scholar, it's 18,300 results that you're looking at. And say, for example, it's the same topic that I'm copy pasting here. Next is Elsevier, which gives you 2,611 results. And when you move on to PubMed, you will end up finding approximately 226 results. So you see how it gets narrowed, right? But at the same time, it is also getting confined. So you might miss on the topics or like the papers if you start directly with PubMed. So it's a double-edged sword. I will not be briefing you about the next slide of mine, which just tells you about literature in general. So software management is extremely important. Your time is extremely precious. Please stick to a software management like for citation, etc. I prefer Zotero personally. People prefer Mendeley, but again, these are several software reference management softwares which are important. And when I start my review of literature. There itself, when I'm looking at the articles, I have different columns that I keep maintaining, and this I don't think I have time to explain how Zotero works. So journal search is quite important. So if you have a paper in mind, imagine where would you like to publish it. Which journal is going to have a high impact factor, which journal matches your aim of the study, and which has previously published similar articles. Open access, paid journals, and please remember predatory journals are quite harmful. It's like I would like to call them the phishing journals, but they're basically the predatory journals that you should look at. They exist. There's a whole list of them which is available online. Okay, so remember the guidelines. As she has talked about Murray algorithm, Dr. Nupur. Similarly, you have guidelines for each and every type of study that you would like to do. Even for case reports, it's the CARE guidelines. So it's a checklist which helps you in drafting. It keeps your manuscript streamlined. And as per the previous articles, and these are the different guidelines that are available: CARE, record, stroke, consort. These guidelines just help you in getting the flow right, or making sure that you have covered things right. So then comes to writing the manuscript. Remember, original article is all about, you need to add everything about what was done, why was it done, how it was done, result of what was done, significance of what was done, and remember what makes the article different. What are you adding? It's not about adding the similar information. Everybody knows about it. Let's skip the part of like trying to add one article to your CV. Let's add more to the pool of knowledge available out there. In case reports, I would like to just say that, remember, check your documentation first. It's important for you to know what pictures you have. Right, because sometimes you all done into the article and then you realize, oh, you don't have pictures. So and it all goes for waste, because how will you make a point if you don't have pictures? And just a pointer, start documenting even if it's with your smartphone. And again, I know I have shortage of time, so this is something I can hand it over to you guys, and that is an author's checklist and a reviewer's checklist. So introduction, methods, results, discussion. You can take a screenshot if you would like, but this is important for you to understand that what would you like to add and what is the reviewer looking at. Because when the paper goes to the reviewer needs to at the same time check out certain things. So if you've already covered what the reviewer wants, your paper will move on in the pipeline faster. So publish, don't just stop. I would not say publish and perish. You should actually publish and flourish, move on, shed off the inertia, stop your procrastination. I told you hypocrisy, remember. So send articles in the pipeline, publish early, and publish in every phase of your career. Even if you start small in your residency, does not matter, you will move on. As he said, review articles don't start from them. I still haven't had written any, thank God. But follow up on your articles, it's quite important because you need to know what are your citations, what impact did you put out there, and read similar articles, read commentaries, organize your research, your mind, your life. So begin while others are procrastinating, work while others are wishing. I wish I would follow this, because if I would do that, then serial chillers will be converted to serial winners. So I hope you all do that. I haven't done that ever. Thank you. Sorry for highly exceeding the time limit. This was a very short.
Thank you, ma'am. Thank you so much. But you shouldn't misguide the audience and tell them you're a serial chiller, because you're anything but that. So we move on to the last session, the last topic for this session, and that is publication ethics. So long we've been delving with how to publish, where to publish, when to publish, and all that. But let's look at some rules that we must follow while we are publishing. There'll be a lot of the Hindi film industry, which will be involved over here to elucidate my examples. No offense, you can add in wherever you feel like with a relevant movie. So everyone, when it comes to publishing, they look like this gentleman over here. They want their name right up in front. So the flow of the presentation is going to be as such. We'll try to know and understand how to go about an ethical publication, to sensitize about publication misconduct, and to evaluate and safeguard ourselves against predatory journals. So as far as publications and authors are concerned, it's almost like the production industry in the Hindi film industry. A publication is the most common form of research outcome dissemination, and researchers remain the sole owner of the published work unless the journal improvises otherwise. Publications can be in the form of articles, books, book chapters, conference proceedings, and preprint articles, and the involvement can be in terms as authors, journal editors, peer reviewers, and publishers. So why go about following an ethical publication? Just like movies based on original stories, you get a chance of telling something which has always been hearsay and compiling it together. So in terms of publications, you end up protecting the life of a human being with your ethically published work. You accelerate scientific progress, and you show an ethical part to your followers, your contemporaries, your juniors, and finally it helps you in image building. So a couple of points to remember are how to go about authors and contributors, how to waive conflict of interest, and how to sensitize yourself against publication misconduct like plagiarism, research fraud, and salami slicing. So this is a very, very important slide. Who is an author? An author should take sole responsibility for published work. So the Committee on Publication Ethics states that the contributions of an author should be as such. That means they must have significant, and I highlight the word significant, contribution to the concept or design of the work, with significant contribution to acquisition, analysis, or interpretation of data, and must play a vital role in drafting, editing, and revising of the final draft. So in cases of multi-author papers, like in multi-starrer movies, you're often confused as in who's the headliner of the movie. So we must make sure that to collectively take a decision in all aspects of the work, decide all this prior to publishing the work, and each author should be able to identify their correct areas of interest and the correct inputs in a multi-author paper. So that brings us to who is not an author. So anyone who has only provided minor assistance in writing, technical editing, language editing, proofreading, or even procurement of funding and supervision. Like the movie you see over here, the lead actress is somebody else, but the movie also featured a number of actresses, but they are not the headliner of this movie. They are just here to increase the star factor of this movie. Similarly, an author also goes by the same example. So let us look into some types of unethical authorship. So the first type that we see here is guest authorship, when an authorship is given to increase the chances of acceptance of an article into a journal. A movie headlines a different star, but projects another star so that the movie does well. Another example of unethical authorship is an honorary or gift authorship. This is where an authorship is given for assistance that is not pertinent to the article for submission. For example, in the movie Dhobigat, which was a movie by Amir Khan's wife, did not feature Amir Khan significantly, but still had him right up in the headlines just to get the movie get going. This is another very famous example of unethical authorship. This is called ghost authorship, where the authorship is given to someone who is in no way involved with the article chosen for submission. In this picture, we all know that they were in the Infinity War, but he was featured in every single trailer leading up to it. Finally, this is where I fell short in my presentation because apparently the Hindi film industry doesn't have examples of this yet. But another example of unethical authorship is ghost authorship, when the authorship is given to someone who is in no way involved with the submission of the manuscript. Anonymous authorship, where the authorship is given to someone in terms of the initials to avoid conflict of interest with another paper that he or she may have published in another journal in another state or country. And surrogate authorship, where the manuscript is written by somebody else totally without the original data and then published. So there are some ethical and unethical conventions that we follow, which we as young ophthalmologists should safeguard against. The first type is multiple submissions. That is unethical and illegal to submit a report to a journal, to more than one journal at the same time. And multiple publications, that is unethical to submit the similar paper, publishing it by just changing the name and the language of the paper. We've had multiple iterations of movies that have been redone and recast just to gain audience satisfaction. Suggesting potential reviewers and correcting errors are also other examples. Now we come to publication misconduct or plagiarism, where if an author intentionally uses another manuscript that is published in terms of its data, words or phrases, or ideas or concept without the permission, credit, or acknowledgement. This is very important. This is cited to us by the Hindi film industry very well, where the entire story is just lifted and projected as a totally new story. Another example is publication misconduct or research fraud, whereas examples cited here are fabrication, whereas you make up the results or the data or the recording while reporting them, and falsification and fabrication of material data, whereas your story is entirely different, but you take a headlining image from a famous movie or from a famous publication and just use it as your own, hoping that nobody will realize, but we do realize that. So from the first picture of somebody like Hrithik Roshan, totally confused but eager, now everyone's face is like this. It's a bitter world out there, but how do we avoid it? These are some ways to avoid it. Always keep a record. Keep your record accessible, maintain clarity. Finally, I just go about salami slicing. Salami slicing refers to converting one meaningful manuscript into multiple small separate papers so that to increase the number of publications. We've all seen this being done most recently with Drishyam and Drishyam 2 and Drishyam 3, which is about to come out. And finally, to avoid predatory journals. Predatory journals are all around us. They are in plain sight, but we must figure out how to avoid them. So they offer publications in return for a sum of money. They are non-indexed or claim a fake indexation. They have no peer review, and they are unable to follow standard guidelines. You want to identify these journals right from the get-go. So they have an unstructured web page. They advertise to attract authors. They have prompt publication, which is promised. They'll send you multiple emails in your inbox and tell you that they'll publish you in 14 days if you send their manuscript right now. And then they'll ask you for a sum of money to get this article published. So the take-home message over here is that to be clear with your authors right from the get-go what roles they play, whether they're part as the first author, contributing author, etc. Waive all conflict of interest right in the beginning and avoid all types of publication misconduct. Thank you very much for your attention.
Prasanna sir, can we keep him in our team, please, for the Bollywood quiz? Thanks for the revision, though.
So I think that was a fantastic presentation, Anujit. Very, very well collated, the Bollywood part especially. Ayushi, do you, till Prasanna setting up this thing, do you want to ask one question?
So if Anujit and anyone can answer, what do you do when there are multiple authors involved to avoid authorship feud?
I would just tell you something that we follow as Dr. Santosh Ronaldo has taught us, and that is the first author always happens to be the person writing the manuscript. That is the rule we follow because it takes a lot of toll to write the manuscript actually more than anything else. And the corresponding author happens to be the person who's guiding you, your mentor, and everything in between should be as per credit and as per the time involved. Even if they're putting in half an hour of their time as a part of the manuscript, it should be duly credited. So that's what I would say. To the first author to the corresponding author, it's absolutely as per the timeline, the time that they have contributed, and everybody should be credited. That's important.
Yeah, actually, I also wanted to know between the fifth, sixth, and seventh, because for us, we say that it doesn't matter, but the person who is the seventh one can feel that I did more than the fourth and fifth one. So, is there any legal way to deal with the feud?
I think just very important to have clarity from the beginning. When the idea comes, when whoever is the, like, your mentor or whoever has the idea of the study, I think at the outset you kind of know who are the three or four people or five people who are going to be involved, and then okay, this guy is good with stats, he's going to do stats. There's somebody else who's good with, or there may be a fellow of yours or a resident who will be collecting the data. So effectively, important is to have clarity right from the start, so there is no, obviously there are, it's a human nature to kind of always feel left out, or kind of, so you can't really avoid that. But when you have a strong group, and I have seen, I have observed closely like how Dr. J Chablani works, and like he has dedicated tasks to people. This guy is going to answer the review to the the suggestions, the kind of review of the thing he will do. One person will do stats, one person will do, and they are very clear about it. And I think the team leader also has that responsibility, that he guides, and he also does one thing, that for example, in one particular journal or one particular manuscript which is published, if he is not able to give a due credit to one person who has contributed to that for whatever reason, he does try to compensate in the next manuscript, or subsequently. So I think important is that you have a group you can trust, basically, and then be clear from the beginning.
Thank you so much, Dr. Rajat.
I would just like to add one point that's absolutely correct, right? Send out an email. Send out an email to all the authors or the co-authors involved, and that this would be the list, the sequence of authors, and if they're okay with it or not, have them reply with it. So that's an obvious consent. And remember, whoever has to feel bad will anyways feel bad at the end of the day. You can't.
Ma'am, just to add to that, when do you send this email?
At the beginning. At the beginning of
just
the
after
project.
conception of the idea.
Yes, that's the right way to go about it. And if you have taken up a project which was being followed up by somebody else, make sure that they are also duly credited in your project.
Thank you so much, ma'am. With this, we move on to the last segment of this session, which is the Journal Club Roundtable. This is a new concept that we've started from this session of the AIOS YOSI Forum, and we hope it goes forward. This is an informal discussion on manuscripts that were published from the aspect of its publication standpoint, not from the aspect of its research outcome or its impact on clinical sciences. We want to know the journey of the authors, the difficulties they faced, how they overcome them, and any insights that they would have for the audience going forward. With that, we start off with Dr. Prasanna sir, who needs no introduction.
Thank you, Nupur ma'am, Anujit, for conceiving such a wonderful session. And so let's have a quite informal discussion. Anujit wanted me to share what was going through my mind when we had a publication that I was conceiving upon. So first I would like to acknowledge my mentor. The role of mentorship is always very, very important. Thanks to Anujun, who also pointed out my serial publications. I have more than 50 publications in IJO and 35 in my regional journal. I'm also the assistant editor and associate editor in my national and regional journal respectively. So I'll just take you through a very practical approach. Bear with me for the next few minutes. When I started AI, so how did it go about things? So this was my original article. I'll not go into the depth of the article. I'll just give you the tips and tricks that was going into my mind as how I conceived that article. So we were utilizing artificial intelligence and we were trying to incorporate human intelligence with artificial intelligence. So we just went to the review of literature and browsed what is known and what is unknown. The machine was having so much of power, meaning the black box of AI. It was not really known how the AI was actually functioning. So we went ahead and we told that we are going to create an explainable AI, because currently there is only an inexplainable AI. So this was a very clear rationale. We told that the predictions of AI are not fully understandable. We want to create something that is understandable. So how we went about creating it is, we started giving the process of annotation. So we created an annotation flowchart, and it is basically marking. So the process of annotation is what we brought in. So I'll just share to you how we went about it, rather than all the technical aspect of it or the writing aspect of it. So we just told that if this is going to be the figure, we are going to mark by human intelligence what is a bionetting sign, what is going to be the vertical cupping, so where is the RNFL defect. You can see that a single fundus image was marked manually by a human being for more than 15 minutes or 20 minutes. The image was done extensive marking, so that is the annotation. And you can see that if this is going to be the image, the cup, the disc, the peripapillary atrophy, the RNFL defect, and you can see the total annotation. So we brought in a concept of human manual annotation, and then the methodology was quite tough. Always it's a team effort. Rope in, if you're not able to code, then rope in a coder into your team, because you have to go and create your own toolbox. You can't repeat an AI toolbox which has already been invented. And for statistics, though I do prefer and I do like to do my own statistics, if things go beyond hand, always get a good statistician on board for critical numbers and other things. So this is how I went about doing the AI project of mine, and this is published in a PubMed journal. And it doesn't end with publication, my dear friends. Whatever we try, there will always be a limitation which will give us the idea for the next particular project that we want to go. So whatever limitations that I had, because I was not able to crack a low resolution image, I was using only with high resolution image and a multimodal AI. I was using only a fundus image. Now we are incorporating fundus, OCT and visual fields together for a next better project. So I always feel the end is the beginning and the beginning is always the end. It's always a loop where this is the idea and conceptualization. These were the 5 points that Anujit wanted me to put out. How did you get the idea? As Anujit, you saw, he was more into movies, I guess. I used to play a lot of video games. AI and AR always brings out the best in me. It always fascinates me. The materials and methods, statistics, difficulty. I always feel when you go for an original article or for a review article, it's assembling a right team is very important. The results and discussion, when you have a different project like an AI or an AR, constructing it for the readers to understand is very important. Keeping it simple will be the review process that you will respond to the reviewer. Otherwise, you may end up the reviewer telling it's a very technical paper, it's not suitable for an ophthalmology journal. And the take home message of this particular thing is we were able to create an explainable AI, right? So moving on to the second part, the AGM complaints. We did do a study on anti-glaucoma medication complaints. You can see the heading of the study. Complaints, when it always comes in India, the patients who are always taken into the study or consideration is the rural population, the illiterate population. But if you see, there are not many papers in PubMed on urban center population, the people visiting an urban center, a tertiary eye care center, a literate primary glaucoma patient, because these are patients we think they use the drops regularly. They actually fall into our cognitive blind spot. So we made sure we examined this patient, and it was quite shocking. Even a highly literate patient who walks into an urban setup, his compliance rate was only 50%. So it was as equal as a rural setup. We had a very strict compliance rate, missing a drop, even single drop missing in a month. So then we went ahead, completely evaluated with the help of a questionnaire. And for questionnaire we used, it was more like a focus group discussion, and the questionnaire was arrived, and you can see that the compliance was only 50% and the non-compliance was 50%, and many new data was arrived. It was not a statistically significant study. If you can see the table again, I'll just show you this particular thing. You can see the p-value here. None of it was actually statistically significant except one, the medical expenditure, which is 0.007. If you see the other all p-value, this was actually not a statistically significant study, but we went ahead and published it, because that was the reality of the people in that particular group. Because of the high variability, the different people that was visiting us had a different story to tell. A patient 2 had a different story to tell. Patient 12 says, I was not educated by the staff because the staff felt, he was a gastroenterologist, the sisters did not educate him. So each patient had a different story. Patient 59 says, I am buying 3 to 4 bottles as my occupation demands. He's a frequent traveler. Patient 65 is another different traveler. He buys 3 bottles for 3 months and he keeps each bottle in a different place. So we started getting more idea in this particular group. These are information that we got from this data. And how did we conceive this study? We felt the urban literate patients who were visiting in a very high tertiary eye care center were always neglected. When it always goes into compliance, it was only the rural patients who were being studied, but these patients were getting neglected. And a solid questionnaire was arrived by a focus group discussion between 3-4 glaucomatologists along with the patient interactions. Results and discussions, I always believe in constructing it in a practical way. Keeping it simple by tables and figures is very, very important. And also compliance issues were evaluated and arrested for the cherry population or the population who we think or expect they'll be knowing better. They were also not very great. And coming to the last part, this is again another innovation of mine, a novel one, augmented reality in ophthalmology, published in the European Journal of Ophthalm in the recent March issue 2023, so which I demonstrated yesterday as well. So you can see here, this is the holograms that we have innovated, which is quite new into the field of ophthalmology. We are trying to project it into pedagogy, that is teaching, as well as EMR. We have our own 4D EMR, and also we are trying to project this for patient counseling as well. So in these kinds of novel papers, the challenges that we face while writing these kind of papers is how can we put it forth that the reviewers will understand these papers, because there are so much more that we need to explain while writing such things. And again, this is a simulator that we have recently innovated for the MIGS one, the generation 1 simulator. You can see that the metaverse is something that is catching up, and we are doing some extensive work on that. So you can see my friend here is coding his fingers in the metaverse, and he takes the G1 eye stent and he just places it into the angle. If he places it correctly into the angle, you can see that the eye stent, which is bigger, it shows a green color. It means he's placing it correctly into the Schlem's canal. So this is a 3-dimensional counseling tool or a simulative tool that we made, and we had to write it well, because you just can't make it and say it's an innovation. You'll have to validate it, you'll have to evaluate it, and then get it forward. So this is again showing it in the figures as well as in a table. So we started with pedagogy, and we told with this technology and without this technology, how are the structures consistent pertaining only to glaucoma. And the conceptualization was, I hope many of you would have seen the Blade Runner movie 2049. There is a very mystical holographic scene in that particular movie that was always going in my mind. What if we can make this a science-based reality? So that was my inspiration. Just like Anujit, a lot of movies. I also keep watching a lot of movies. So that was the inspiration. Again, anything I always believe it's a team effort. It's not a single man's effort. It's always a team. A solid team is needed, especially in creating something or innovating something, and getting the discussions and results. Again, make it practical for the readers to comprehend. Review process of these kind of innovations, I do send a supplementary file in the form of a video, because nothing speaks better than a video. Though I may give a lot of pictures, a form of a video really helps, and then publish it. It's as good as patenting it. And the first holograms with real confocal images was then invented and published. So again, this is just a dashboard picture of my IGO portal alone, taken a month back. It's always the rejections that keep pushing us forward. The more publications is what people tend to see. It's just the tip of iceberg. I'm still trying to catch up with my article published, but now this dashboard is actually retired. So I think I'll have to retire with 66 rejections and 53 acceptance. So the rejections is what motivates us. It keeps pushing us forward. We just need to keep pushing us. And then automatically, like the previous speaker cited, Dr. Anujun cited, the H index, that really matters. And 2022 was my breakthrough year. Once you get your citations and your peers starting to recognize you, it just the ball sets in rolling. And this is some of our articles that I want to share. I think even a simple image in American Academy of Ophthalmology, I have not published any original article or review article yet, but this is the cover image that we publish. Even any one of you in this audience today, all it needs is a good solid image, and you can start the ball rolling even in an international journal. It's as easy as it is. And then you can set it up, and these are all some of my other publications. I'm primarily a glaucoma and a cataract person, and you can have your own publications rolling, and these are some of our innovations. And I think I'm open for discussion. I once again thank Nupur ma'am and Anujit for giving me this opportunity to share the cognitive framework of how I went ahead with my publications. Thank you.
Thank you so much, sir. It is indeed extremely humbling for you to expose your IGO internal portal, and for everyone to see that for so many publications by an author, he has so many rejections that he's not afraid of talking about. And that is the learning curve that we want to dissipate through this journal club, is that he has 66 rejections. Imagine we go through one rejection and sometimes we think about, okay, maybe we should just forget about this article completely because IGO has rejected it, so everyone will reject it. But that is not true. He is a living example. Thank you so much, sir.
I started with 20-0. Now
There
it's
you
much
have it.
better.
There you have it.
Yeah,
Thank you. Thank you so much, sir. Thank you so much. I'd like to invite Rolika ma'am once again for her second presentation and her study, the cosmic study, and how she went about conceptualizing and harboring and then finally publishing it in such trying times of COVID, where we were all stuck behind the laptop screen.
Yeah, thank you for inviting me for the round table. And Anujit, I agree, this is a very good idea that you guys have put up and a very difficult one for the ones who speak about it. So I will be talking to you about the cosmic study, and there is no particular speaker for this talk. It is the entire cosmic study group talking to you. I'm just speaking on their behalf, right? So this was a study which was done, I don't know if all of you know about it or not. It was a study which involved 2826 patients and multiple centers, and this was an expedited article. And why it was conceived in the first place was because the government was out of regulations, the government had no data, and the government was not really coming up with solutions related to mucormycosis, symmetrization of the patients. So the entire idea behind this was of Dr. Santosh Navar, who decided that let's just come up with a solution for the people, even though we were swamped with work in the COVID times. And so just let's take a guess. How many days do you think the study took? Like, I really want you guys to raise your hands and take a guess, not you. Anybody else? Just 2,826 patients, 5 days, okay. 25 days, okay. Anybody else? From the inception of the idea till the publication, what do you think, how many days it took? Sorry? 1.5 months?
4-5 months.
4-5 months and 3 months. So I would always say this when someone asks, guess what? I never say, I just say what. So don't take a guess. The entire idea of inception was from 24th May 2021, and 8th June we had the publication out. Don't clap, it was not easy. It was the toughest duration that I have had in my entire fellowship. So this 24th May was the inception of the idea. One day we were happily in the OPD and absolutely working, and suddenly somebody comes out of the room, and that is Dr. Santosh Navar. He pops out of his OPD room and he says, I have an idea, let's just do this. And we are looking at each other. How? We are like absolutely low on manpower. We have patients pouring in because post-COVID, suddenly we have like an influx of patients which were not expected. And we really were wondering, because that time we were just two of us, 2 fellows and 1 new fellow. So we were like absolutely like, how are you going to do this? We have no idea. And the survey was out on 26th May 2021. And 5th June is when we sent the paper out. Trust me, it was the biggest relief of our lives. And 28th June was when we received it back again with the reviewers' questions. So not yet. And all the madness and chaos was in between all of that. And I will be taking you through the timeline, and that is this. So as I said, 24th May was the inception. 25th May is when the ethical clearance was sent out, because it was a very important study that we are putting out there. So the ethical clearance was requested as an expedite. And 26th May is when the survey was out to all the centers of everybody who is a part of AIOS was sent out a request to be a part of the study, and all the multiple centers were requested. And trust me that a multiple centric study would ideally take 3 months to 5 months. I agree with you. And 27th May is when we started writing the manuscript, because we were absolutely dividing ourselves. So it was Dr. Mritika and me who divided our work. So she was absolutely taking care of manuscript initiation. So she started writing it. Review of literature was really not an easy thing. I was collecting the data, and the image was also, it was important for us to collect photographs from all over India, because it was not just about our center. So we had to reach out to multiple centers where documentation was possible, because in COVID times, many people were not able to even document because they were just in a hurry to treat. So who had the time to click pictures, right? So we had to reach out to ENT specialists, we had to reach out to other centers of ophthalmology as well as medicine, and collect data. And data collection was going on, so we had to communicate with the multiple centers as well. We had to tell them to streamline, because we had made an Excel sheet, sent it out, but not everybody was filling it in the way we expected. And I remember receiving 128 Excel sheets. So you can just imagine how difficult and how chaotic my screen looked that time. And the Excel sheet started pouring on 29th May, and it took 2 days entirely without any sleeping hour to streamline the Excel sheet and arranging them together along with the clinical work that is going on, I must say. And 2nd June to 4th June is when we were able to filter out each and everything. We had to make sure that wrong data doesn't go in, because we are making a statement which is extremely important. So the data that we put in has to be accurate, to the point, to the decimal. Even when we had multiple variables, like say diabetes mellitus. So now diabetes mellitus was not covered by every Excel sheet. So if you notice, go back to a paper, the N value of every table is different. So the N value had to be calculated for each and every table separately. And the manuscript writing, author listing, and multiple corrections. So when you work with a perfectionist, trust me, it's a dream, but at the same time a nightmare as well, because every single thing had to be perfect. Every single thing had corrections, and every hour we used to get corrections. So we would be in the OPD, see the patient, run to the laptop, add in a correction, send it to sir. It was going on to and fro. And 5th June is when we sent it off. We felt done and dusted, but as I said, not yet, because we received it from 7th to 8th is when we received the reviewers' comments, which were extremely important. And since it was an expedited review comment, we had many comments to add to. And 8th June is when we said, sir, please, now we need a vacation, because for the past 10 days, none of us slept, including our mentor. So that is something that I would say was a plot. Like at 3 a.m., it used to be like, okay, now my alarm, where is the table? Where is exactly the table that I had asked you for? So I think in 2 weeks, total, I would say, we landed up learning something which was probably designed to be learned in 3 to 4 months. It was definitely not easy. I wouldn't say it was a nightmare, it was joy, but difficult at the same time. This is the distribution that we had covered, and we were still keen on covering more number of states, but we could not. And this is exactly how. So this is when the first map was made, but eventually it looked like this. So in between, there were at least 20 maps which went to and fro. These were the pictures that we had collected. I don't think you can see over here, but there are small comments that pop up over here that come from Dr. Santosh Navar, which are like, this needs to be changed from A to B, B to A, C to D. This is how our laptops looked like that time, because there were multiple comments. And these are the pictures that we had to collect, reject, accept, cited. And this is the author list. And I must say that putting this author list was the most difficult part of my entire writing, because I had to make sure every spelling is correct. I had to make sure the number is correct. And there is no software yet made to put the authors in the correct sequence. So no, we have it, but it did not work that way because it had to go in numerical order, and at the same time as per credibility. So Mritika is the one who wrote the paper. So as I told you, the person who writes it always comes first as per our rule. And Sir and I were the ones who landed up. He was, of course, the man behind the idea, and I was analyzing the data, expediting and cleaning out the Excel sheets, image collection, etc. And this was the second part of the list again, which was not yet done. And these are all the centers who have contributed. Along with the other authors who were the sub authors who were to be duly credited, as I said, it is very important. And this is something which I collected exactly 3 minutes, like, sorry, 10 minutes back. I've already exceeded my time. So this is how many citations we have received by far till the second. I said follow up on your paper. I never did. So this is what I have received by 499 accounts and 521 posts. And it has been tweeted 495 times. I wonder how. But let me tell you one fact. I would never look back on this manuscript. It was a very difficult time for us. And so these are the metrics how the paper was viewed in the phase where it was required. I tried to take out the 5 year, but it was not loading. So the demographic breakdown of how it was done. So keeping all the modesty intact here, and that is this paper hopefully added to the pool of knowledge which was required that time. That was our motto, and we were able to have the government make fresh guidelines for the patients of mucormycosis, because we were not getting a lot of funding. So this paper was entirely about that, and in the process we were happy that we got the platinum award. I don't think this was ever on anybody's mind. That was not the motive. The motive was served the day we got answers that yes, we are able to get funding for the patients. So it's the teamwork which made the dream work. Thank you.
Thank you so much, Valika ma'am. I mean, I think the numbers only gave everyone in this August hall goosebumps just to see the numbers. And just to add on to everything that you said, they followed up on this article months on end. Every author needed to be given a certificate after the thing once. So
I'm sorry for being late for that.
even 1 year down the line, she has been working behind this article, completing it even after its publication, because there were so many things that had to be
Yeah,
done.
so since there was only one certificate given out by AIOS, we had to make sure that all the authors get the duly credited certificate. And for sending it, it would break. So we made an innovative idea of rolling it and putting it in a box like the Royal College of Ophthalmology, and we sent it out to all.
Thank
Sorry
you so
for the
much.
delay.
So this is just an example, just goes to show how something so difficult, which seemed so difficult, it was so difficult at that time, but bears good results. So for the young audience out there, this is an example to follow. The numbers are scary, but it can be done and it has been done. And definitely everyone here can replicate this going forward. Thank you so much, ma'am. Just before wrapping up the session, I'd like to ask a couple of questions to our panel members. Just to summarize the entire session, Dr. Rajat, sir, I would just like to ask you that going through this entire session, what do you feel are the main hurdles for the young ophthalmologist, whether a resident, a fellow, or in practice, to publishing at this point, and how can they overcome them? Just one concluding remark.
So, considering there are so many institutes in this country and every institutes work differently. So, first hurdle will be to not have a correct institute or a correct mentor, which is like, you're born into that, you're born into a certain family like that. If you go to an institute which does not have any background of having publications or, any mentor who's into these kind of things, then of course you don't start thinking that way. So that is something which is not in your control. Okay. But yes, you can be motivated by attending such sessions, and when you go to meetings, you hear people who are doing it, and then just catching a habit kind of this thing. Other thing is intent. So see, everybody is doing clinical work. If you are a resident fellow, you are going to be swamped with work in anywhere you go. You will be given night duties. You will be given. So this comes out of the time which you have left. If you are willing to dedicate a part of that time of your personal space and time and then do this, so it requires a lot of extra motivation, right? So that is again something which is depends on the person, whether they are really motivated enough to go that extra mile beyond their work and beyond their extra duties and stuff like that. So I feel the hurdle is the mind. And again, the solution is also your mind. It's just that how you look at it, and how you get inspired by others, and how people around you do it. So and as he said, once you start getting into the habit of it, then you enjoy it. The beginning, the starting, getting the first publication is the, I think it's like a, breaking that inertia. That is where once you get that one paper, and then you think that, okay, it can be done. So I would just like, end my comment with that, saying that just start with a small clinical image. You just see your name on one journal somewhere on PubMed, and that gives you the motivation and the drive.
Thank you so much, sir. I mean, the answer lies within. Just search, look inside. Yes, Radhika, ma'am.
Yeah, I would just say that many of the people have that inertia that they are not from an ophthal background. They don't have a mentor. They don't have an institute. I don't have an ophthal background. I was happy to have a mentor, but working with a mentor is also definitely never easy. It has its all pros and cons. If you start focusing a lot on what you don't have, then you cannot proceed further. So I have a lot of people asking this question. And I would say is that if we put ourselves in a limbo of how will I do this, it's not possible. This study was done at Center for Sight, which is not an institute per se. It's not a huge institute with a lot of infrastructure. It is a small institute, and a large study has come out of there. So everybody has their own, things that they had to overcome and go beyond. And our studies have also, like I think Nilesh would also agree here, that many of our studies we have done even before joining our respective mentors. So it's all about what you want to do. It is really not about what you have and what you don't have.
Thank you so much, Radhika, ma'am. Just one line of concluding remark from Dr. Neelam. What is your take on journal clubs, and what can the young ophthalmologists do to make an impact either by attending or participating in journal clubs? The impact that will have on them.
Yes, journal clubs definitely do have an important role. During residency, apart from reading the standard textbooks, we should also read these journal articles. They keep us aware and updated of the current trends. And sometimes in our clinical practice, they help us to understand a topic much better. And during residency and fellowships, they give us an idea about how to carry out our thesis work or research work. So, YOSI, via the YOSI Journal Club session, provides a platform to attend and also to participate in such kind of activities. Even last year, I participated in YOSI Journal Club and I presented Hawk and Harrier trial. Initially, I found it to be a very big study and very difficult one. And yes, I was allotted a mentor. Dr. Kaushik Tripathi sir was my mentor, and under his guidance, I was able to understand the study better, and then I got a chance to present it at a bigger platform. So yes, such kind of activities should be promoted and should be included in our curriculum.
Thank you. Thank you so much, ma'am. And with that, we will be concluding the session. I will be handing the mic over to the next session. And in the meantime, we can go ahead with presenting the panelists with some mementos.
So I'll request Dr. Digvijay sir to give the mementos to our speaker, Dr. Ayushi. Dr. Vaibhav. I'll request Dr. Divakant and Dr. Karan to hand over the mementos to our panelists. Dr. Rolika, Dr. Neelam, Dr. Rajat. And we can have the session speaker and the panelists for a quick group photo, please.
The free paper session that was conducted in the morning. The first prize goes to Dr. Ayush, the second place goes to Dr. Anand, and the third place goes to Dr. Priya. And for the Surfing the Ideas segment session from the yesterday's program, Dr. Karthikeyan Mahalingam is the winner for that session. Thank you. York session results will be announced soon.
So as we are running short of time, I would like to call the panelists for the next session. Dr. Abhishek Anand, Dr. Rishabh Shroff, Dr. Rishabh Shroff, Dr. Amar Pujari, Dr. Vaibhav Shetty, Dr. Tushar Grover. Okay. So we'll be starting the session. I would like to request Dr. Aditi Ghosh to be on panelist for this session, please. Thank you. And calling upon to the first speaker of this session. So Dr. Anujit Paul, please come.
So Dr. Anujit is a Vitreoretina Fellow at BPI Foundation, and as you can see, his introduction is already there on the screen. I'm sorry about starting it. Yes.
A very good afternoon, and I'll be speaking online resources for residents, but I hope this will be useful for the young ophthalmologist as well. As usual, I've incorporated a lot of Bollywood in my talk, so please excuse me for that. What happened? So there'll be a lot of pictures, so if you're interested, please grab your phones. You can Google all these later on, and it will be helpful for each and every one. So let's start with websites. So the first and foremost, the gold standard, the OG, the MVP, the American Academy of Ophthalmology, has numerous resources for residents. It even has a resident column where you can go in. It has an MCQ column where you can practice MCQs. Its headliner page, iWiki, is what saved me through my residency. I just typed the name of the disease in iWiki, and I was a star resident in my residency program. Not kidding. With that, we move on to the One Network, which you get with an AIOS membership. You can access the One Network, which has a lot of other residency resources. Speaking of AIOS, AIOS also has a plethora of resources, starting from fellowship resources for young ophthalmologists, as well as the AIOS Educational Library, which has flipbooks, guidelines, newsletters, AIOS Times, and a lot more. Mentioning another OG in this sector is Chua's MRC Oft. Our teachers usually prefer this site when they prepared for their Royal College examinations. It is a very simple site with a lot of resources, very simply demarcated. You can have these resources on FFA as well. Coming to the newest kid on the block, but the most successful kid in my opinion, eOphtha by Dr. PPDM Sir. This has become one of the leading resources for residents, with articles summarizing from textbooks, resources all over the net. Not only do you have articles, you have presentations, so you can give SlideShare a sideliner over here and take these presentations for your residency presentations. Moving on to the next residency resource, we have iLearn by Saurav Deshmukh and Krati Gupta ma'am. They have a set of iLearn notes, which they have curated themselves from scratch, so it is extremely helpful. DOS Times was a huge resource for residents in the early 2000s to prepare for their exams. They have fortunately compiled all the DOS Times into one resource by subspecialty. And this is something which I personally found very interesting, is that they have residency resources depending on subspecialty topics, chapters mentioning which book, which resource, which sector to focus on. It also has experts telling you which book they followed when they appeared for their exams, and half of them are university toppers as well. It has a residency study plan and video resources where instead of me summarizing it, they've already done my work. So I just had to screenshot all this and disseminate it to this audience, along with cell phone applications, which we all know about. Our next resource is Ophthalm Bites by Dr. Shashwanti and Madhuvanti Mohan ma'am. They have also curated bite-sized information for residents. This is especially helpful for 1-minute info on very vital topics. But wait just a minute. This is like textbook reading. It is just on a black screen, but don't worry, I have you covered. I know you want to relax, and for that, I bring to you YouTube resources for residents. Starting with some OGs, the Arvinda YouTube channel is excellent followed by the RP Center YouTube channel. They have their entire video recordings available from all their conferences. The iFocus YouTube channel has covered subspecialty topics over months on end. Each subspecialty is covered for 1 to 2 months, and it has a lot of prolific speakers over there. The Shankara Academy of Vision channel is excellent. Cybersight has done a lot of work in documenting a lot of procedures for residents to be done in the correct way and disseminating them. And then there are some of you who are looking at me like this, wait a minute, I'm not interested in any of this. I want to know cataract surgery resources because I want to become a prolific cataract surgeon. So for residents, there are some OG channels that you must follow. Uday Devgan sir actually comments and critiques resident cataract surgery videos, an excellent learning tool for residents. He has these videos on choosing the perfect phaco settings for phaco-dynamics, which is how I learned phaco-dynamics during my fellowship. Karan Bhatia sir also has an excellent video on phaco-dynamics. Also on the YouTube Yosi channel, this is how I shifted from block phaco to topical phaco. His video is excellent. A special mention here to the entire YouTube Yosi channel, YO Slides, YO Tube, YO Pearls. They are also excellent resources going forward. All recordings of Yosi activities are on the YO channel and now on the YO website. Coming back to some cataract resources, Dr. Deepak Meghur sir, he has some excellent resources. I picked up stop and chop technique from this particular video, which I just watched again and again and again till I could do stop and chop. Dr. Saurabh Patwardhan sir, Dr. Pradeep Mohanta sir, these people have been producing and sharing videos for donkey's years on YouTube well before the new guns came into action. And this is a very, very interesting channel for those who do not know, Neuro-Ophthalmology by Andrew Geely. He posts 1-minute videos on excellent neuro-ophthalmic retina uvea cases, which really expand your knowledge. Finally, some interesting mentions, Dr. Pranesh Balasubramaniam sir, who has an excellent research which he spoke about yesterday. Dr. Prasanna Ramesh sir with his amazing videos. And now for the laziest residents out there, I have you covered as well. I bring to you Instagram. Dr. Haidar Ali Chaudhary sir has excellent resources on Instagram. Mad Ophtha, that is an international Dr. Manuel Degato. Ophthalmo Bites, which is Dr. Shashwanti Mohan ma'am's Instagram page. Ophthalmopedia. The uveitis Instagram page, which is excellent for uveitis case presentations. I myself have done some minor work, which I would like to shamelessly advertise at this platform. I know. Now everyone's very happy. All the resources are there. They just have to sit and download them all. But I know there's one thing which I have not covered is resources for examinations. So a disclaimer right out there in front. For examinations, your textbooks are your best friends. It's textbooks, followed by clinical knowledge that you gain from OPDs and OPDs, followed by journals. There is no other substitute for that. However, these are my top picks and my choices for residents. The iFocus online channel has 1-hour videos. The DOS compilation times will cover you for your theory papers, and eOphtha has everything in the middle covered. I know this is the face of everyone with so much of knowledge, but I'd like to remind everyone there is an endless supply, and this is an age of information overload. Please choose what works for you. Not all resources will work for everyone. Thank you, and I hope all is well.
Excellent talk, Dr. Anujit. Great resources you have shared. Next, I would like to call upon Dr. Bhavya Kokani. He is currently working as a consultant with the ASG group, and he has given TED Talks as well. So we are hoping he will throw light on this topic.
Slides. Yeah, good morning. I've realized that more than residents, the teachers or probably teachers of the teachers sitting here. So I would like to dive into this small thing where I've seen my own fellows or my own juniors who have been perplexed by this entire concept of how to balance between surgical training, theoretical exposure, and clinical exposures. And this is something that I've come across. This is just a story of struggle with no financial interests. Why this entire journey? Trust me, you are lucky if you are lucky enough to be able to ask this question whether you are supposed to balance it or not. Most of the times we are at a receiving end for these three paradigms where you don't get to choose how to balance. You take whatever is available to you. But probably as teachers to your own students, we could have a perspective that could change their entire journey of how ophthal is being pursued. What makes this story so important? Because it's my story, it's your story, it's our story, it's every single ophthal's story. My story insignificant yet insignificant. The reason why I say this is most of us have some or the other way dived into this journey. I did my DO from Nagari Eye Hospital, a high volume, a decently academically oriented, good surgical exposure oriented hospital. But of course, nowhere were the academics as compared to the other institutes of the national level. Then I did a short-term paid FECO fellowship, and I went to a trust hospital where I, it was massive. Like I had my own FECO exposure there, and then I walked up to Sri Shankaradeva Netralaya for my secondary DNB. So taking best of all the three worlds, I realized proper lacunae in all these three pits. That was academics, that's theoretical exposure, the surgical exposure, and this clinical in all three different worlds. Of course, settled by the resident or the student himself or herself. I also realized that the current batch of third years has come up from an era where they were expected to do a lot of COVID work. So the journey changes also. The drenched first year, which we remember, there were statements that we used to hear: my next turn comes too late, my senior doesn't allow me to sit on the slit lamp, only second years can do applanation tonometry, I don't like going to the wet lab. Trust me, there are setups, there are institutes where these sort of norms are going on. I'm not sure how well are the residents learning in this, or how good or how necessary it is for the superiors to intervene in this hierarchy, because I actually remember in my own institute there was a rule that first years cannot sit on the AT. So that gets a little tricky. Of course, most of us have experienced the same. I believe this very deeply, that wet labs are like dinosaurs. Most of the residents have heard of them, but nobody has actually seen its existence. It's an extremely underrated territory. Everybody actually talks about it. Like I've heard in our peers also talking a lot about these wet labs, but still at the end of the day, I myself am too lazy to go and be a part of the wet lab. The new enthusiastic second year, who has relatively less ward work but is busy enjoying, tries to explore all the three worlds, does a lot of complications in the OT, relatively is not able to handle his own complications, but has an unexceeding, a limitless urge to teach his first years. And finally, the responsible third year, who has a constant pressure of the number game, a constant will to perform, because there is judgment, there are HODs, there are tutors, there are professors hovering around him. Third year ko itna nahi aata. And a constant uncertainty of future plans. Amidst all these halabu, the balance between these three territories actually lands up getting disturbed. And that's why the entire topic, how should we balance these three? Paradoxically, there are some institutes where there's so much of cutting that the third years have to they have to request their professors कि अब मुझे OT नहीं जाना है, please मुझे पढ़ने दीजिए. There are institutes where this happens as well. So we concentrate on the theoretical side, how to scale up your academics and how to you scale up your theoretical side. I believe that there are only three pillars of this: read, ruminate, and reproduce. Read. In the recent times during residency, all of us are so clustered and we are so biased by the surgical rush that comes and by the clinical acumen or by the clinical validation that follows, that we'll end up realizing that textbooks are the infinite source of knowledge. One who reads finally makes it to the end. So if you have your students, and if they're not probably into reading so much, a little push, or maybe sit along with them, discuss, this would push the theoretical side ahead, which is extremely important. Of course, publishing and everything comes along with it. So yeah, read, ruminate, and reproduce. The clinical side, uh, there are places where there's too much of academics, or there's massive surgical exposure, but clinical side is not there. Like when I was in I come from Jamnagar, and I remember one of my colleagues who was doing his MS there, had his thesis topic for an OCT. So he used to go to a private with his 30 patient pool to do OCT, and there was no OCT in the government hospital. I'll wrap up in 2 slides. And so, how would you maximize it? You observe, you ask, you follow, you discuss these patients with your colleagues, you discuss it with your seniors, you discuss it with your peers, and you inquire, and that's how you magnify your clinical side. And the surgical side, of course, there's only one solution: you pray that you get cases in your residency. That's it. A lot of us have discussed already how much to maximize. There are a lot of resources. I won't go into detail. For personal note, surgical exposure has been optimum, which I'm grateful for. Complications have been plenty, which I'm guilty about. But learning has been infinite, which I feel blessed about. Take home messages. Don't take home any messages. Instead, take home some optimism that all these 3 learnings are conquerable. They're integrable. They are integral yet conquerable. Take home some beautiful bonds, because when you discuss it among different minds of different institutes, you come to know that the journeys are absolutely different. What happens in different institutes, the way of teaching, what a resident perceives, his entire journey is very different. Take home the beautiful stories, and take home a part of you that is lost in the rat race. Excellence is a process. So thank you so much, AIOC. Thank you so much, UC. Signing off, Dr. Bhavya Gopani. Thank you.
Thank you, Dr. Bhavya. Excellent tips. Next, I would like to call upon Dr. Ashi Singh. She is currently working at Guru Nanak Eye Center as a senior resident, and she completed her DNB from LV Prasad Eye Institute. She has completed her FICO as well. Ashi will be speaking about maximizing surgical opportunities during your residency, and she'll share her personal experiences as well.
Good afternoon, everyone. Thank you for this opportunity to present. So I'll be talking on how to maximize your surgical opportunities during residency. I had a fairly good exposure. I was lucky to be a part of a program which gave us a lot of hands-on and a lot of observations. So I did more than 1,000 surgeries during my residency, and then and this was across different fields. So I would say not every resident gets a very good institute, because it's all rank dependent. However, according to your rank, it is important that you make the right choices. Choose the right institute. It might not be closer to your place, but choose one with good exposure, choose one with good mentors, choose a good role model, choose to work hard, choose to work efficiently. You should make the right choice to never stop caring for your patients. The problem is, we probably think about mere ko case chahiye and I want to do more. If you start thinking about your patient outcomes, I promise you, you will not go wrong. And always make the choice to restore vision. So as a resident, I feel that you should make the most of your program. First, assess wherever you are, what opportunities does your place give you? Are you in a government setup? Are you in a private setup? Are you in a charitable institute? What sort of cases will you get? Will you get to assist more? Will you get to observe more? Or will you get to cut more? Accordingly, proceed ahead. Express your interest to the people around you, to your mentors. Get access to whatever facilities you have. Vet lab, आसपास में institutes है. Go wherever possible and learn it at every source possible. Assist, discuss, practice. And if not possible, outsource. Go learn somewhere else. Go assist other people if that is possible, or learn during different conferences. So 3 steps: prepare, practice, and perform. How do you prepare? Read, hit the books. Do your homework, be ready with the OT list, know what all cases are there, read up before, read up the surgeries, go read up the recent advances about it, know about the cases that are posted. And obviously, see everything on YouTube. Everything is available online, and you should also ask your mentors for their videos and see those. So these are different channels. YouTube has its own. There is Cataract Coach, and obviously right now in the previous presentation, we already heard about the other sources. Just go explore, find something that you like, something that interests you, and see how they perform, and then try and practice it. How do you practice it? Use a wet lab if you have one. A lot of our institutes do not have wet labs. I understand that. What else can you do? There are institutes that have simulators. How do you use the wet lab? There are different articles that tell you how you can practice different specialities in your wet lab, in what all ways. You should read up and then try and explore that in your own wet lab. And if you don't have a wet lab, do a kitchen wet lab or a home wet lab. I have used all vegetables and fruits possible to practice as many steps as I could. You do a potato rexes, do a tunnel on a banana, or practice swannial suturing on that. You don't even need a microscope. You can just bend a sewing needle and try practicing with that. Initially, that is something that will give you speed and that will give you some accuracy, and you can go replicate it in the OT later. Attend training sessions. Every conference these days has a training session, has a wet lab session. Spend that extra money, spend that extra time, go. You will earn some confidence and you'll definitely learn something. I have started my journey as a trainee and I've gone on to be a trainer now. In the operation theater, you need not always just be cutting. You can be a very good observer. And the other thing is assist. We often let the sisters assist. We should assist the mentors if possible. You will learn a lot more. Come prepared. Obviously, always come prepared. Read up the surgery before you see it. You will learn more from it. As a trainee surgeon, while you have a case, assess your patient on a slit lamp. Make sure you are aware about your microscope and the settings of it. Check your instruments that are available, check the lenses that are available to you, and think about your case before you do it. My trainer told me that you should have operated in your head at least 8 times before you actually perform the case, and twice should be while you are scrubbing. So, and while you're operating, try and record your video. You can actually assess it, you can go through it later, review where your mistakes are. Choose a good assistant and a good mentor and listen to their advice. Be calm, don't be overconfident, and call for help if you run into any problem. Believe me, repeated errors will cost you not only your confidence but patient vision and further cases. So, call for help at the right time. And as a post-op, what do you do after your case is over? See your surgical video if possible, analyze the mistakes that you have made, discuss that with a senior fellow or with a colleague, and don't be afraid of criticism. Think of it as feedback and this will help you in your growth. AIO has a beautiful tool out there called as Oscar. It is available for FACO, it is available for SICS. You can just go online, Google it and download it. Fill it up and make your mentor or your assistant fill it up for you as well. You can come to know how you are doing and keep a record of this as your cases go, at least for your initial cases. The way you read up about it, you will realize what your deficiencies are for every step of surgery. It is very meticulous. Also, to complete, have a surgical logbook. This is how I started my surgeries. This was the very, very first case that I did, and I have a record of almost of the 1,000 surgeries that I have done till now. So every learning that you've had, whatever difficulty you faced, you can also have a record of your post-op astigmatism through this. So keep a logbook. And at the end, you don't just get lucky. Luck can be created. And I've observed that the harder you work, the luckier you get. We as ophthalmologists are blessed to touch eyes and to have the power to restore vision. We should use this power, and it comes with a great responsibility. So train hard, train passionately, and believe in what you're doing. Thank you.
Thank you, Dr. Ashi, for such a useful information. Next, I would like to call Dr. Amit Pandey for his talk, Acing the Residency Exams Fearlessly. He is working as a anterior segment surgeon, cataract refractive and glaucoma at Center for Sight, Surat. He completed his glaucoma fellowship from Shankar Netralaya, and right now he's doing great work in MIGS and eye stent.
Yeah, good morning everyone. I'll be talking about acing the residency exams fearlessly. Fearlessly is important because डर के आगे जीत है. So this is my exam journey. I went to a medical college, I gave DNB, I did my fellowship, gave FICU as well. The approach to this, I'll be talking mostly about the theoretical exam because I think practicals, surgical, everything has been covered very well by the previous speakers. So the approach to the preparation could be what to read, where to read from, how to read, and when to read. And the execution during your preparatory leave, the week that matters just before the exam and during the exam. So I'll just briefly cover these topics. What to read from? There are basically four sources of reading: the conventional textbooks, the journal articles, internet-based interactive websites, and clinical application books, which are different from your textbooks. The conventional textbooks, Kansky is an excellent initial basic reading, but extremely inadequate for passing the PG exam. Yanov Duca textbook is good. Shields for glaucoma, especially other specialties, they are different books. AAO, has been clearly explained by the previous speakers. The ophthalmology series, it's precise, concise. LC Datta and other books that are regional based in your medical college or your center. Your seniors would be reading certain books, and that also you can follow. Journals: Survey of Ophthalmology, DOS Times, AIOS has their CME series, American Academy, they have these preferred practice patterns, which is free to download, and it provides excellent flowcharts of for disease management based on the current knowledge, and it has very good tables also that can summarize, compare major clinical trials in a particular field. Landmark studies you need to know. This is just for example for glaucoma. You have had landmark studies, and you can have short notes based on these studies also. And when you mention these landmark studies in your exam, it really impresses the examiner. Internet based learning has been covered wonderfully. eOphtha, iLearn, One Network, Ophthalmic Hyperguides, YouTube, iTube, ASCRS also has podcasts. Coming on to where to read from, I did this during my residency almost a decade back, more than a decade back, where I used to list down the topics and where I have read that from. And the number of times I read, I mark it every time you read. And now you can do a Excel sheet as well. This is, for example, for glaucoma, you have almost 45-50 topics to read only from one. So there are so many topics that you need to learn, and from so many sources. So the first read will not be registered. You won't even remember what the topic is. You just will get an idea that topic exists. You won't remember what is the content and where you have read it from. So because there are almost 500-600 topics that you need to learn, you will get confused where you read the topic, and then next time when you try to read, you try to read it from a different source, and you'll be wasting precious time and decreasing the recall value as well. So during the last few weeks, when time is of great essence, you don't waste your time searching where you read it from. If you have a list, you can directly go to that page and then read it from there. During the last few weeks of preparation, marking on the chart will also give you confidence that you have read this topic at least once, and then shift it to your long-term memory. How to read? Again, make notes, and make notes. Compiling from different sources into one note will save a lot of time. You will have good recall value of your own handwriting, much better than of printed material. Writing notes is also a good practice of writing the answers in the examination, and you can judge and adjust the size of the answer also in your notes. So you can compile the notes into one notebook, or you can stick it to your primary reference book also, like I used to do, and make my books very dirty. Also, during in the initial part of the notes, you can make this outline for the answers at the beginning and then expand each point enumerating, so that it will be very easy to revise also during their last revisions. Remember to prepare for answers in form of flowcharts or comparative tables. This will save a lot of time during your preparation, or also while writing the exam, and this would be a game changer. The examiner also would be very happy to see that you know all the points. Diagrams again improves your understanding of the topic. It becomes easier to remember in the visual memory, so faster recall, and it makes you should make easy to replicate diagrams. Don't need to be very artistic, and keep spare time during the last week before your exam to practice these diagrams as well. juggling between your residency and study plan is very difficult, but you need to go back and study whatever you have learned in the clinics. If you have seen a particular case, go back and read about that case. Again, your recall value would increase. Formulate a preparatory leave timetable and stick to it. Divide the available days into smaller periods and decide on deadlines to finish those topics. But you should know your limits, don't overburden yourself. Keep buffer periods in between these in the timetable to alleviate anxiety. You have enough time and you won't get panicky. DNB theory has 4 papers, and the time is so short that you won't have time to think about each and every question. The recall has to be instantaneous, and you have to revise accordingly. And always decide on the main source of reading and then an alternate referral source if time permits. Refer to exam papers from past exams only in the last 2 months. Try to write at least one mock exam 1 month before the real one, and be thorough with your basics. The last 10 years DNB or university questions should be thoroughly revised multiple times. Be calm during your preparation. You can't learn everything, of course, but you should know a little bit about everything. Be calm during your theory paper. Allot time each and every question. Do not overfill your pages. And everyone has their own different style and speed of learning. This was my style, which I've shared. Remember that you're not only preparing for your exam, it's this preparation that is going to determine how your practice is going to be in the future also. Thank you, and all the best to all the exam goers.
Thank you, Dr. Amit. This will be definitely helpful for the residents who will be facing the exams, and this will give them more confidence. Now, I would like to call upon the next speaker, Dr. Rajat Kapoor. He has completed his post-graduation from Shankara Eye Institute, Coimbatore. He completed his fellowship from LV Prasad Eye Institute, and currently he is working as a senior consultant at Pushpagiri Eye Institute, Hyderabad. So he will be talking on cracking the international exams.
Yeah, so previously we were discussing about procrastinating and how we start at the last moment to prepare the slides. I would like to put out a disclaimer. I started making this presentation 1 year back, but right before the previous conference I presented it in. So coming to the presentation as such, see, these are the common international exams which all of us want to appear or try to appear. So the most common one is International Council of Ophthalmology, which is ICO, and then there is the Royal College of Glasgow and Edinburgh. And then if somebody really wants to settle down in the United Kingdom, then they go for the Royal College of Ophthalmology, which is the FRCO. So clearing these exams is quite easy. You just have to read a few books, and the list I'm just sharing with you. I think once you have this list, you can all just attempt and sit in this exam, and you can clear. But wait a minute, the list just goes on and on and on. So I feel that then if you can't really do it, then you can stop there and I can finish my presentation. But there's a catch. You can do it. Tumse ho pai. And so I will just give you a brief about each of these particular exams. This is the ICO. And the ICO, so apart from the whole spectrum of the books which you saw before, I think probably this is sufficient if you want to clear the step A and B of the ICO, which includes the basic sciences and the optics. And this you can actually start giving it in the first year or second year of your residency. If you are doing a DNB or a master's, you can probably do it in the second year. For diploma candidates, probably first year is best when you are actually reading those subjects. And our basic textbooks of Kurana, anatomy, physiology, and a bit of optics from sources like Elkington is quite sufficient. The part 1 and 2 exams are MCQ based, and all this information is available online, but the part 1 consists of 120 questions which you have to cover in 3 hours, and the part B is 60 questions in 1.5 hours, and you can actually appear for both the steps at the same time, but you have to complete both steps separately. You can't mix the the marks and all that. And then part C is the clinical ophthalmology. This you can give in the final year of a residency or just after you finish, because that time you had almost covered your curriculum for your residency exams and your knowledge is fresh. So this will be a really good time to start giving the clinical ophthalmology exam. And the advanced exam is the one which you can give probably after your residency or when you're in a fellowship. But I would suggest to kind of give these exams back to back. So when your knowledge is fresh, once you go into a specialty fellowship, then you kind of focus on that one particular specialty, and then we lose touch with the other things. So this exam consists of extended matching type questions and context setting kind of descriptions, and there are multiple resources, but the common ones are a review manual in ophthalmology by Massachusetts, and then there is a provision, and all these things are available online or on Telegram. You have all these things. There's also recently a ICO subspecialty exams, which are in particular one specialty like cornea, glaucoma. But for that, you have to have a 1 year experience of working in that particular specialty. Of course, the limiting factor here is you have to give Lagan to the Westerners, and this is the fee structure. This was I don't know if it's updated, but they do keep increasing it every 1 or 2 years. And there are ICO fellowships which you may have completed ICO or may not, but you can still apply for these. These are 3 month kind of observerships where they award about 60 to 90 people in a year, and they give you a grant of about 6,000 US dollars. But they say that if you have completed ICO, then there's probably more chances of you getting it, and it is given to only YOS. There is no license to practice any. I mean, you can't operate, or you just, this is mostly like observership, and there is a terms and conditions where you have to return to your home country after you complete this. And these are some of the other fellowships which are offered by the ICO, and all this is available online. So the pros of ICO fellowships is probably you get to go abroad, you get to see a different style of working, you get probably exemptions. If the ultimate goal is to go for FRCS, then this gives you certain exemptions. You get a direct entry into the MRCS Edinburgh, and you probably lead to better working opportunities, but that is debatable. Cons is of course money, and especially during residency fellowship we are actually not earning anything, so it's like a burden definitely, and it is not a licensing exam, and plus there is no surgical work, so this is purely a observership. Coming to the next common ones, which is the Royal College of Glasgow and Edinburgh. So these are the details of the Royal Colleges. Eligibility for part 1 is that you should have completed at least 1 year into your training. For the giving the part 2, you need at least a 5 year training in ophthalmology. It can include your residency and your fellowship as well. And part 3 is only after you complete part 1 and 2 successfully. And these are some of the resources. There are many online websites like Chua, and some of the books specifically for the FRCS, which help you with the practical examinations. And again comes the fee structure, which is even higher. Instead of Dugna Lagan, it becomes Tigna Lagan, and part 1 is like almost 300 pounds, and when you end up going to the third part, you're almost paying them almost close to 1.5 to 2 lakhs. And if you don't clear, then probably second time you don't even have the heart to appear again. So this part 1 consists of MCQs, again basic science and optics. This can overlap. If you have given your ICO, then you can kind of skip these steps, and you can go directly to part 2B, which is a written paper, and this includes some amount of emergency medicine as well. And emergency medicine question is you have to clear separately. If you don't clear the emergency medicine question, then they will not allow you to complete this step. And then there is the oral examination, which includes these stations. It's more like a table viva. They will have 3 stations, and the clinical examination on the other day would be more like a the practical kind of aspect where you see the patients and discuss after that. So the oral examination has 3 stations of 20 minutes each, and they do have medicine and those kind of things. They'll show you ECGs and some clinical scenarios with like snake bites and burn injuries, which sounds scary, but they are limited to 8 to 10 scenarios. Probably they just rotate among them, but you have to read something apart from ophthalmology. And this is the Viva, which has 4 stations: anterior segment, posterior segment. They give a lot of importance to neuro-ophthalmology and squint, which is a separate station by itself, and oculoplasty as well. And each station you spend 12 minutes. There are 2 examiners. You end up seeing probably 2, 3 or 4 patients, and the more number of patients you see, probably your prognosis is better to clear the exam. And so Viva goes like, unka ek sawal mere do jawab, sawal ek jawab do, सवाल जवाब, and that's it. You are through. And advantages for FRCS is, it's a very well recognized post nominals for you, and it also gives you cross exemption with certain other exams. For Middle East people who want to settle, probably yes, you get a better remuneration if you have a FRCS with you, and probably better again job opportunities in India and overseas. Entry into UK is not really, that route is not there. So this is some information in 2019 they have given, but they keep changing this, where cross exemptions are there between ICO and FRCS groups. You can check the latest ones online now as well. So plan, pursue, commit, execute, and don't give up. You can clear this exam, but you have to plan for it. Thank you.
Thank you, Dr. Rajat. It was very informative for all those who are planning for giving these international exams. So, lastly, I would like few comments from our panelists. Like, what are your take on this international exams or cracking a residency exams? Any tips, Dr. Vaibhav?
Uh, First of all, try to clear them in first attempt to save money, as the international fellowship is quite expensive. And I think when you're doing your residency, when you're trying to crack the DNB exam or something, it's important to do those, make teams and do a mock test before you go in, because the timing is very important. Because I remember during the theory exam, I actually missed one question because of lack of time. I still passed, but still haunts me sometimes.
Yeah, I think group studying really helps for these as well. Just a note about the whole session, it was a very nice session. I think one thing we have to understand is everyone needs to keep a little patience during their training. Everyone's journey is different, everyone's learnings are different, and everyone's pace of learning is different. So I think the trap we fall into is comparing someone's cutting more, someone's cutting less, but it balances out in the end. So I think we need to look at the bigger picture in that sense.
Exactly. Thank you so much. Such a wonderful session. We were all going through our nostalgic trip, discussing about our PG days and how everything is evolving with the more new technologies and access to, internet, and so many brilliant sessions like YOSI and AIOS. So hats off to you guys and all the speakers. It was really good. And yes, please do not go for peer pressure. We all have our own journeys, exactly, and just decide what you want to do. Do not give an exam just because your friend is giving. Go for a fellowship that you want to do. Go for your passion. See the accessibility, what you want to do in future. So I know it's very easy to tell now, after so many years, but yes, it is always, and utilize your residency years. Those are the years that even right now we go back and we smile. So utilize them to the fullest. Work hard, study well, and clinics, there's no other alternative to clinics. Thank you so much.
And one point, overtaking from Rushad's point, is if you want to add peer pressure to your colleagues, I used to do something: keep your lights on the whole night and sleep with lights on. So next day when they come to the hostel area, they'll ask you, study the whole night. You said yes, why not? But you can sleep comfortably.
So no peer pressure.
I don't think I ever did that.
Thank you all panelists and all the speakers. I would like to call Dr. Digvijay Singh sir for the memento.
So request Dr. Ashi Singh to come and collect her memento from Dr. Digvijay. Just a moment. Thank you, Dr. Ashi. Next, I would like Dr. Digvijay to give a memento to Dr. Amit. And finally, to conclude the session, I would invite Dr. Bhavini to come on stage and collect the memento. Dr. Digvijay, one more. So thank you everyone for attending this session and making productive comments. We'll move on to the next session. Thank to the panelists also. Thank you.
So we'll move on to the next exciting session, that is the international session. And may I invite the panelists, Dr. Digvijay Singh, Dr. Sonal Kali is not here, Dr. Karan Bhatia, Dr. Avnish Upadhyay, and Dr. Nilesh Kumar to please join the panel. So next, I'll invite Dr. Po Chen Singh. He is an attending ophthalmologist from Taipei City Hospital, Taiwan, and he'll be talking about multicentric trials.
Hello, everyone. It's my first time in New Delhi. It's a beautiful city. It's too pity I don't have more time to visit around. It's my second time here to visit India. Last time I went to Hyderabad for APAO. It was like 10 years ago. I'm honored to be invited by Yosi to share this topic. How to initiate a multi-center study from Taiwan YO, combine Oshudex and anti-VEGF. Actually, I'm here to learn. It's very good programs and interesting activities. Congratulations to you all. I'm Dr. Po Chen Zhen from Taipei City Hospital, Taiwan. As you can see, there's 5 different hospitals in this study group. For young ophthalmologists in Taiwan, there are some limitations because we are from different training systems, hospitals. We usually don't get to know each other very well. Subconsciously, we even try to compete. We don't have a platform like Yoshi, like YO, until 2 years ago. And after training, if you get bored, you want to achieve some academic achievement or do some clinical research, there are some limitation too, because after training, if you are not in the medical center anymore and end up with a regional or local hospital clinic like I do, there is very limited access to start an original clinical research by yourself. There are more likely situations that you are the only one in your specialty field in your hospital. It's a much more smaller population based in Taiwan, not like India. So it's difficult. You're on your own now. Luckily, I met a group of friends from different hospital systems, and we get to know each other from several domestic or international meetings. At first, we just talk about gossip, jokes in our hospital, and complaints of our problems. Sometimes we discuss difficult cases that we made clinically. And later on, we decided that maybe we can do something else altogether. It's like a mini version of Taiwan YO. And besides being a platform of social networking, exchanging experience, career consulting, we can also achieve something more productive. Just like the picture I took yesterday, like the president, Dr. Kalia said yesterday, it's a power of teamwork. Because unlike our mentors and professors in the medical centers, who have very huge clinical data and patient bases, we have relatively limited clinical data from our patients. However, cooperating with each other and combining all our data, we can collect enough material for a multi-center study. This bottom-up approach was very time-consuming. We have started 4 to 5 research projects. Most of them is just still ongoing. One of our projects was published recently, and I'm here to share the result today. It's the therapeutic effect of simultaneous injection dexamethasone and aflibercept on diabetic macular edema. It was published on 2022, and it was our research group. We are from 5 different hospitals. As we all know, it's pretty much global trend for anti-VEGF to treat DME as the first-line treatment. However, if you look at the DME pathophysiology, VEGF just play a small part of it. It also includes a lot of inflammatory cytokines, inflammatory process. So that explains why if you treat with anti-VEGF, after 6 months, you have, even in the IDEA group, you can see like 1/3 of patients, they have persistent DME. And 60% in the IDEA Avastin group still have refractory DME. So in this refractory DME, if you switch to a steroid Ozurdex treatment, people can gain vision. So here's our thesis. Why bother to shift after the treatment results not good? How about we just combine the treatment initially? Is it maybe better? So we conduct this study. We divide the group into a control group is the monotherapy with Eylea, and the treatment group is combination group. We simultaneously inject Ozurdex and Eylea in the patient. So after 6 months, the treatment group is non-inferior in visual gain. And for retinal thickness reduction is also non-inferior to the control group. And we also concerned about the IOP in steroid group. It also shows not significant higher in the treatment group. We all know that steroid will induce cataract. So we do a subgroup analysis, and we find out that in the pseudophakic group, the combined therapy do better. The visual gain is much more significant improved. And it also showed that in pseudophakic group, the BCVA changes is better. And I think it's another good point is that it reduces our treatment burden greatly. So we don't bother to do the monthly injection for the loading dose of 4, 5, 6 loading doses. We just give them a combined shot, and it will last for 3 to 4 months. I think it's quite important for a busy clinic. So we are analyzing the second year data for now. Hopefully we can publish it soon. Here I just presented one approach of how we started a multi-center study from Taiwan. While I'm so happy to be here to see how things are done by YOSI. Really opens up my eyes. And I'm really glad to join this big YO family. Thank you for your attention. I hope you don't just have a good day, have a great day. Thank you.
Thank you, Bo. I think that was a lovely presentation, and we are very glad that you've joined us all the way. You've come here and you've shared your insights on this in Taiwan. Anybody has any questions that you guys want to ask or any comments? Okay. You can come join me here to the dais.
So next we'll have a recorded presentation. I think we'll just by Dr. Vidya from Indonesia. Can you play the recorded one?
Hello, I'm from YO Perdami, and for those of you who didn't know, Perdami stands for Persatuan Dokter Mata Indonesia or the Indonesian Association of Ophthalmologists. So YO Perdami is actually YO Indonesia. So we were established in the 44th AIO annual meeting back in September 2019. Our chair back then was Dr. Bayu Sasongko, pictured here in the white shirt. And unlike the BYOs or the YOSI, we're actually part of Indonesian Ophthalmology Association. But back then we were like we were not our own department or anything. We just know that we're part of the whole main organization. And the definition of YO in Indonesia is pretty different than the rest of the Asia Pacific, as ophthalmologists within the first 10 years of practice or below 40 years old. So as you know that a couple of months after we're established, then the pandemic hits. So from a point of view, I think the pandemic was a bit of a blessing in disguise for our YO communities. Why? So we actually start injecting members really early on the pandemic by making a WhatsApp group in April 2020. So back then, as you know, in ophthalmology, most of our work are elective. So the workload goes down like significantly, and a lot of us have a lot of free time to actually do things in the YO community. So back then, in the early on in the pandemic, a lot of us doesn't have much to do professionally. So a lot of us have a lot more energy to do things in the YO. So it's actually very active and bustling during those periods. Our first activity was actually being part of the newsletter for the APAO, and then it branches out into multiple division. So now we have 6 division. After doing the newsletter for the APAO, we then do our own newsletter. So then we have a newsletter division, and then we think that we need an online presence, so we make a division for social media and website. And then a lot of us wants to talk more about fellowship, so we make another division titled Fellowship and Education. Some of us who are good with music wants to record songs, so that we make the YO Art and Music. Some of us want to talk about culinary and photography. So this branches out as per demand and needs of our members. We didn't plan it out, but that's the spirit of YO Perdami. We want to facilitate our members. And as you probably can see here, most of our activities is non-scientific, because the scientific events are organized by our own society. So this is the channels that we have to reach out. We have what's our WhatsApp group for our members only, and then we have our Instagram, we have newsletter, which already have 4 edition by now, and we also have a podcast, mainly talk about things that are for patients' education in YouTube. So we did quite a lot of activities online, especially during the first 1-2 years of our establishment. We had YO Art. We had also one of the biggest event we've ever made was the YO Inspirational Series. Our first guest was Aika Ahmed, and it was a big hit in our community. And then we also have Tinder YO, where we talk about fellowship with YOs who had already undergone fellowship in and out of Indonesia. And then we also talk about entrepreneurship, and also we had video showcase competition, and we have the Perdami Fellowship survey, which we will do every 5 years. So moving forward, so the leadership in Perdami, it changes every 3 years, and in 2022, our new head then put young ophthalmologist as its own department within the main organization. So now we have our own department, which consists of me, Dr. Tigor, Dr. Windy, picture here, and also our new head, Dr. Alia, picture down there with me. And this actually means a lot for us, like having actual recognition that we are actually part of the organization. Then we can organize many more things, and I hope this will bring a lot of positive changes towards our society. But there are a lot of challenges ahead. As you know, now that the pandemic's almost becoming an endemic, there's not a lot of free time for our YOs to be as active as we were back in early on in the pandemic. So we're less active last year, but we're trying to like make changes while doing more offline events now. In the next year, we're also trying to do better induction of new member. We're trying to propose a change in the YO definition in Indonesia, trying to induct them into the YO community since residency. And mostly the excitement is about doing offline events. The next we will do is our first ever YO night in the next Perdami annual meeting in Yogyakarta in August. And also we have APAO next year, 2024 in Bali. So we will do like what the MSO did. We have YO social, YO night, and YO session scheduled. And I really hope that a lot of you from YOSI can actually participate in that. Because we need to collaborate, of course, with especially with another YO societies around Asia Pacific, and YOSI being one of the biggest. Of course, we're looking forward into more collaboration with you guys. Okay, that's all from me. I hope to see you all in Bali. Thank you.
Malaysia meet part, sideline meet with the APO.
So first of all, it's good to see Tinder involved in ophthalmology in Indonesia, and then Unite being the very important aspect of their initiatives as well. So Malaysian, we had a wonderful Yo sessions, and Dr. Ashraful was there, Dr. Kushal was also there. We had great sessions, great interaction, and now we are looking forward to 2024. We have two big events coming up. One is the Singapore meeting, the global ophthalmology one, and of course the meeting in Bali. So I hope most of us can join both the meetings and interact at a global level. So next, may I invite Dr. Kaushal, please join. Dr. Kaushal Pokhrel is a fellow of refractive surgery from Tilganga Institute of Ophthalmology. He is presently the president of Yo Nepal, and he was also the past joint secretary of the Nepal Ophthalmic Society. He'll be talking about the Yo activities that are happening in Nepal.
Especially Dr. Divakant and Dr. Karan, who made this possible. And I love you guys. You guys are so good. All the YOSI, so active. And you are the inspiration to not only YO Nepal, to the global YO. You are just flawless to what you do. So good. Namaste. I'm Kaushal. I'm the president of YO Nepal. And first, we had to understand and bring up the concept of YO in Nepal. So we had to convince everyone that it's just a platform where we will be connecting and encouraging and also providing opportunity to the young professionals. It will be mainly concerning about the academics, leadership development, and collective excellence. And it's a bond between the young professionals by interactions and entertainment. And it will also help in bridging the senior leadership with the future leaders. And of course, YO from one country, they can connect with YOs around the globe. So after realizing this, we conceptualized the YO in Nepal. It was the best day, 1st of January, and it was the best place, the lap of Mount Everest. So that is Kala Pathar, and that is me and my friends. We have a very supporting seniors and the founding members that includes Dr. Eli, she's the patron, Dr. Syam Vyas, he's the advisor. I'm the president, and the members include Dr. Rosisa, Dr. Rosisa Khanal, Dr. Anadi Khatri, Dr. Ravindra Singh Thakuri, Dr. Tetsu Singh Malla, Dr. Amit Kumar Yadav. So what have we done so far? Apart from getting the society, getting this YO started in Nepal, it was approved by the Nepal Ophthalmic Society, which is the sole ophthalmological society of Nepal. And they also provided us the official address and a small room and a cabinet for us. We organized interaction program with the recent pass out batches to discuss the issues with the posting, and the information was thus relayed to the Nepal Ophthalmic Society Executive Committee. We organized YO session with a theme of what after residency to help young professionals in choosing and deciding their career path as an ophthalmologist. And in the same conference, that is the ophthalmological conference in 2022, we started a joint Nepal Ophthalmic Society and Young Ophthalmology Best Resident Award. And to promote the health of the healers, that is, the doctors have to be healthy, which will enable them to cure the patients. So we organized this You Come First, that's the hike program. And during the event of Tihar Deepavali, that's the Festival of Lights, we organized cultural program called Deusi Vailo. It's a fundraiser program. And currently, we are working on establishing an independent society so that the things would expedite. We participate in Kuala Lumpur in 2023. So what will we be doing in the future? The most of our activity, the core of our activities will be core itself. That is connect, offer assistance and support, role of a leader and recreation, and excel together. So we will be helping in connecting the residents, fellows, young ophthalmologists in Nepal and beyond. We will be offering assistance and support regarding research and publications, opportunity notices involving the fellowships and jobs, and career counseling. We will be creating opportunities so that we can develop the role of a leader in every YO, and also participate in recreational activities and excelling together by sharing of learning tips, examination materials, and thesis assistance. I have a few photos with me. So this is the Everest, and this is Kala Pathar. Actually, we cannot go beyond this. It's really hard, and we need to have license for that. So this is the place where most of the photos of Everest is taken. So it's the lap of the Everest. If we go too close to that, we will be only seeing a part of the Everest, not the whole of it. So and January 1st, the best day, so we started this YO. And this is the Festival of Lights and then Deusi Vailo program, the fundraiser. This is the hike program. And we also had senior ophthalmologists coming for the hike. And of course, the fun at the Kuala Lumpur. It was a very memorable trip. And even this trip, I think I will be remembering this day for the rest of my life. It was awesome yesterday and awesome even today. So thank you so much, everyone. Thank you for having me here.
Dr. Kaushal, so we saw in your presentation that you are transitioning from being under your parent society to an independent society. So how is that journey like, and how the seniors are receiving it? Are they okay with you moving on to a separate society?
Yes. Actually, the problem is not with the society. They are very, very helpful, because the whole concept was by the support of the Nepal Ophthalmical Society. The only thing is that things that we want to do, it has to go through lots of steps. So if we have a different society, it will be easier. But we have very good support from the seniors, like very good. Yeah.
Thank you. Can we have the next recorded presentation, please?
Good afternoon, AIOS and YOSI. Thank you for having me. I'm Claire Peterson, a registrar at the Singapore National Eye Centre and the chair of our Young Ophthalmologist Society in Singapore. Today, I'll be giving an overview of cataract surgical training in SNEC and also share my personal experience. I have no conflict of interest. Cataract surgery is the most common eye surgery performed, and effective training and transfer of skills to the next generation of ophthalmologists is very important. This requires dedicated time and resources, including a focused curriculum, dedicated teaching and surgical time, good training equipment, good trainers, and motivated trainees. Our basic cataract surgical training in SNEC starts in our first year of residency and carries on through our third year and last year of junior residency before we move on to our registrar years. We previously learned extracapsular cataract extraction concurrently with phacoemulsification, as we felt manual surgery is a good way to hone suturing skills. However, more recently, we will be replacing this with small incision cataract surgery. We have lectures as they're important to set the foundation for anatomy, equipment names, handling, steps of surgery, and principles of surgery. These are accompanied by live demonstrations on pig's eyes or Kitara model eyes, and this allows trainers to slowly go through each step, demonstrate different techniques, instrument handling, and also answer questions along the way. We then have hands-on practice, often on pig's eyes, where we learn how to perform our first echis, phacos, and also how to suture under the watchful eyes of our trainer. As an aside, for oculoplastics, we practice our lid procedures on the whole pig's head for the butcher. After all this, we're given our own basic microsurgical kit, which we use to practice in our wet labs on pig's eyes. We also have 2 IC simulators for phacoemulsification practice, which allows us to familiarize ourselves with instruments, microscope, and the phaco foot pedal. And for us, we have to pass a few predetermined levels before starting phacoemulsification. During this period, we also have our OT orientation, where you learn the basics like where are scrubs, head caps, masks, where are the operating rooms, where are blocks, syringes, needles kept. We also see how patients move through the OT from the waiting room to anesthesia room, operating theater, then to recovery, what the paperwork is, what's the timeout process, and we also have a refresher of scrubbing and also cleaning and draping of eyes. After a couple of weeks, we have our wet lab surgical assessment where we complete full surgery on a pig's eye under the observation of a surgical trainer before we are deemed competent to start surgical training in the operating theater on people. As with most procedures in medicine, we observe a few cases, then assess in a few cases before finally performing the cases. Our training list for junior residents usually occurs about 1 to 2 times a week, and they have about 4 to 5 cases on each list. Most trainers take a back-to-front approach where they first teach the trainees how to do the later parts of the phaco, such as IA of SLM, IOL insertion, before progressing to do earlier parts such as CCC creation and phacoemulsification. Then as you get more senior, the trainers can guide you through newer techniques and more challenging cases, and you receive direct feedback at the end of the list. All our cases in SNEC are recorded on video, and we have a monthly cataract review rounds where a few trainees are able to present videos of surgeries and complications they faced and how they overcame them. Here you receive valuable feedback from other trainers, and it's also a good opportunity for other trainees to learn how complications are addressed. Most importantly, this serves as a good psychological aid for the trainees as everyone has complications and we're all here to learn from them. By the end of your third year of junior residency, you are then assessed to see if you're fit to progress to having your own independent list in your senior residency as a registrar. Your requirement is to complete a minimum of 86 cases, but in reality, my year, we had about more than 400 phacoemulsifications under our belt before we became independent. And that's not all. In medicine, learning never stops, and as registrars, we have an advanced cataract training list outside of an independent list where we can list polars, cases of zonulitis, and we also have subspecialty operating lists where we can assist and also perform more complex procedures. Well, what a journey. So now with 2020 hindsight, what are my biggest takeaways? Firstly, on imparting surgical skills, this is always best done in person on supervised training lists. Therefore, a good trainee-trainer relationship is key to having good, successful surgical training. So for the trainer, always try to give the trainee as much opportunity as safely possible. And every trainee is a bit different, so feedback and guidance needs to be tailored accordingly. Always start the safest phaco settings. And for left-handed trainees, when they're starting out, it may be useful for them to go with a left-handed trainer. Discuss what went well and what can be improved at the end of each case or list. Record and review your surgical videos together. And most importantly is to be honest but encouraging. For the trainee, it's important to be honest with yourself and know your limits, as there's no need to impress your trainer or any OT staff, as you are there to learn. And after all, you're also operating on someone's eye. Always listen to feedback and try to record all the notes down. And I always make it a point to learn at least one thing from my trainer every session, and I'll review it before my next list. When starting out, it's good to stick with one trainer so you can learn and correct any mistakes, but later on, learn from as many surgeons as possible. Before starting surgery, brush up on your knowledge, watch videos of cataract surgery online, know each step, know your equipment, know common complications, what to look out for, and how to manage them. Practice makes perfect. Do it on your wet lab or also simulators so you shorten your learning curve. Be also familiar with your own OT so you know the flow of your patients and paperwork so that when you start, you'll be less flustered. And be familiar with your equipment. Case selection is key. Always start with standard cases you've seen in clinic. Make sure the patient is not only eyed, that they're healthy, and their nucleus has adequate density. Also, remember that good surgery begins before surgery, so be early to your OT. Ensure you know how to give adequate anesthesia, such as a subtenons or peribulbar block. Make sure you're positioned comfortably, so your seat height and table height has to be adjusted. Tilt your microscope if you need, especially if you're shorter. Ensure that your hands and wrists and elbows have adequate support. Position your patient well, and know how to drape the eye well to keep all the eyelashes out of the way. And lastly, ensure that their pupil is always well dilated so you can give them pre-operative home dilation drops and also use intraoperative adjuncts. If possible, always try to record your own surgical videos. When starting out, you can also get your colleagues to record other things like your hand position or your seating position so you know how to adjust them accordingly. Be a perfectionist about every step, as everything has a knock-on effects. Also, try to follow up on your own post-operative patients and measure your surgical outcomes. Don't be afraid to discuss your cases with your peers and seniors, and always try to think of how you could have done it differently. Surgery, after all, is a lifelong journey. There's always room to learn and improve. And most importantly, stay positive. That's all from me. Thank you for listening, and feel free to contact me if you have further questions. And lastly, I would like to invite all of you to our Global Young Ophthalmologist Summit in Singapore in January 2024. Hope to see you there.
So I think that's a interesting presentation in cataract surgery. So how is the training for cataract surgery in Taiwan? Is it similar? Is it by a wet lab and then step-by-step approach, or how does it work there?
Yeah, and we use wet lab at first, and usually I train my resident step by step to as long as they can do. And so, yeah, it's very difficult for the trainer to because it's your own patient, so it's not easy to let them to go all the way. You have to stop them anytime.
How is it in Bangladesh? How do you?
Yeah, the thing is that the majority of our seniors, they train from India. So my mentors are from here. But in Bangladesh right now, we have 5 centers for the cataract fellowship, and that definitely starts with the wet lab and definitely the step-by-step surgical procedure with the supervision. And when one complete the all procedure with supervision, then they can start individually. So we have the fellowship, like majority of the fellowship are for 1 years, but in our center we have the cataract fellowship for 3 years. So I think that gives the residents and the fellows the good opportunity to do all the cases. When you do the fellowship for 3 years, so you can be confident by yourself that you can manage or handle every cataract cases. Thank you.
How many cases does a resident, get in typically at Tilganga where you've trained?
a resident by the end of 3 years, they get something around 250 surgeries, but in Nepal, only SICS training is done as a part of residency, and FACO training will be in the after the residency. We also focus on wet labs, and we are also getting a simulator for SICS training. Should be coming in around 2 to 3 months now. So I think that will be big help to have the simulator and then practice in the wet lab simultaneously before handling the patient.
Next, may I invite Dr. Ashraful Haq. He is the founding president of Bangladesh Young Ophthalmologist Society, and he is a consultant refractive and anterior segment surgeon at Bangladesh Eye Hospital.
Thank you very much. So, before I start my topic, the journey of Bangladesh Young Ophthalmology Society, I need to say one thing, that every journey is a personal journey, it's an organizational journey. Every journey needs an inspiration. So, for the YO Bangladesh and Bangladesh Young Ophthalmology Society, Yoshi is the inspiration for us. So, I would like to thank the organizer for having me here. So, in Bangladesh, the average age of becoming ophthalmologist is really 32 to 35 years. But when we become an eye doctor, the things in our mind that what will be the career, the courses, the jobs, or what will be the salary. So how maximum are married, they have the family life, how I can lead my family life. And when we become the ophthalmologist, the real challenge comes. So what will be the job? Do I continue with job, or I do the fellowship, or what will be my surgical skill, then how I start my practice, and definitely how I may communicate with the patient, with the seniors and other my friends. That's the most important part. And for that, we feel from our very beginning that we need a platform. We need a platform for the beginner ophthalmologists, the YOs, that to discuss their professional needs, to showcase their works, and definitely they need to flourish. But one thing is that the beginning, discuss the professional needs. Not all the ophthalmologists who become the initial beginner are that much proactive to communicate with the seniors, to communicate with the mentors, that what I will do, please advise me. They are very much comfortable, and many are very much comfortable to share with their friends or the little bit senior elder ophthalmologist, so that we feel that YO need a platform for the planning, for the activities, for the communication, for the learning and sharing. And we are planning for that. We will form a young ophthalmologist group in Bangladesh. And the red mark is, it's a very new concept. In Bangladesh, forming a young ophthalmologist group, a young ophthalmologist leader group, is a very new concept for our ophthalmologists. And so we have to think and work little bit more focusedly, that forming a group, and we have to forming a core team for with the young ophthalmologist. And the core team, we selected that should not be done, but we selected the toppers of all subspecialties among the young ophthalmologists who are good, who were good in their fellowship, who are now good in their practice, and who are now little bit coming up. The seniors are knowing them, and we communicated with the seniors that we want to form the young ophthalmologist group. And the most important part for us, we need to manage our seniors, because it's a question, why you need young ophthalmologist group? We are here for you. But the planning and activities goes on. That is at the 2019, we went to Kolkata. That is the West Bengal Ophthalmological Society conference, and there was a young ophthalmologist session. That gives our mind that if any conference has the young ophthalmologist session, why we cannot have at Bangladesh? And after coming back in Bangladesh in the 2020, first Ophthalmological Society of Bangladesh, we had a YO session, and even after that, immediately after that, we form a YO Facebook group, and we are planning to forming a young ophthalmologist group. But the main eye opener came on, it was 2020 March. I must thank Dr. Divakant Misra, who is here. I must say he is the global YO leader, and he included me and Dr. Maziba, Asia Pacific YO Forum. That was the eye-opener for us, that we saw and learned that different country has the society. We learned to know about Yoshi, we follow them, and after that we are planning that, okay, along with the other countries organization, we can form Bangladesh Young Ophthalmologist Society. And finally, we got approval from our seniors and teachers. And I must mention one name, Professor Abha Hussain. She is the chief patron, but she is every time with us for every works of Bangladesh Young Ophthalmologist Society. And that in September 17, 2020, the dreams come true. We formed Bangladesh Young Ophthalmologist Society. So we formed the Bangladesh Young Ophthalmologist Society with the three key goals. One is the bringing the all young ophthalmologists in Bangladesh under one umbrella and giving the young ophthalmologists a platform to showcase their works and collaborate with the national and supranational YO societies to learn and share knowledge and skills. But we always say, when you get independency, but to keep the independence is very difficult. So the real challenge started. So we had to do lots of work in our last 3 years. We had even 55 events in last 3 years. And what we did, our journey so far, we are the RGSC registered organization. This is, we had our government need to approve every voluntary organization. So we have that approval from Bangladesh government, and right now till now we have 137 members, young ophthalmologist members. For your information, that we have only 1200 ophthalmologists in Bangladesh, all over the Bangladesh. Among them 137 are the YO members, and that the COVID times was there, and we started the webinars. Why we started the webinars? To learn and share, but the webinars gave the very good opportunity for the other young ophthalmologist members, because we encourage the local YO speakers. This platform give the Bangladeshi YOs to talk, having the speaker of the webinars that they couldn't get the previous times. And we did the collaboration with the national and international societies, subspecial, and we started the subspecialty based ophthalmology webinars for YO. And we all know that we had a very good webinar, and thanks Dr. Divakan Mishra, Dr. Digvijay sir, and Dr. Karan for the Yoshi Bios debate. That was a very good debate. And we had some international society conference, and we had the subspecialty based webinar in all subspecialties. And immediately after that, we started the YO talk. That gives us the relationship bonding with the seniors and the juniors. The seniors were coming there and the juniors were talking, and we represented in the international YOs meetings, supranational meetings, and we have the most important focus was coming to the American Academy of Ophthalmology. The YO Info had the feature about the Bangladesh Young Ophthalmologist Society. And I must also again thanks Dr. Divakan Mishra for inviting Bangladesh Young Ophthalmologist Society in all AIOS YOSI sessions. That give us a very good exposure. And we started the initiative having some project of us, that is the YO capture. That is the most popular YO capture, because every young ophthalmologist, they took the photos and sent us. We published these things online and the printed version in our newsletters. We went for the YO showcase. That's we showcase every YO achievement and the YO buzz. And definitely we have another program, that is the BIOS Clinical Top Tips from the YOs, and we had a very good photo contest competition. We had it every year, and we have with the name of our one senior ophthalmologist who passed away. But we had the collaboration with the Bangladesh Society of Cataract and Refractive Surgeons officially. So we have the collaboration with our national subspecialty societies, and our latest works was our newsletter. We have it with the online version and the printed version. And we have done it 5 newsletter till now, and we are working on BIOS journal. Hopefully it will be published this year. And we have done the meeting regularly, and this we keep in the practice that the organizational structure, we do the meeting, and our every activities will be decided by a meeting, and we celebrate our maximum events. So the celebration becomes with the senior doctor and the junior doctors, so that the YOs and the senior leader of the ophthalmologist, they get to bond each other. Some seniors have the question, what are you doing? So by this program, they can understand that what Bangladesh young ophthalmologists are doing. So this is the very good, I would say, the event celebration for Bangladesh Young Ophthalmologist Society, and definitely we encourage our young ophthalmologists to attend international meetings. That will give them the good exposure, and also to share and learn knowledge and communicate with the others. So Bangladesh Young Ophthalmologist Society for Bangladesh, it was a new concept. But the COVID, at that time the COVID happening, in the COVID, I must say that there is every opportunity. I just take few seconds. There is always opportunity in every situation, and opportunities will open the platform for the better bonding. And for better bonding, we get the opportunity to form Bangladesh Young Ophthalmologist Society, and our journey continues to share, to talk, to learn, to grow, and definitely one time we will have to teach our young ophthalmologists. And I must say, from not for this time, from the 2020, when we learn about young ophthalmologists, Yoshi and all the Indian friends, Dr. Digvijay Singh, Dr. Divakant Mishra, Dr. Karan Bhatia, and many others Yoshi friends are always helping us in every moment. And my gratitude to you for this helping. Thank you very much.
See that BIOS has achieved a lot. You've achieved a lot in the last 2 or 3 years, and I think you'll do great. And the best is yet to come, but you're on your way there. So it's amazing, very well done.
Thank you, sir. And we are following Yoshi and other bio societies, and definitely we all will grow and flourish ophthalmology and take ophthalmology at the superior level.
Can I ask? And how do you get approval to get independent from your original, like local ophthalmology society? Because in Taiwan, they are afraid that we are going to take away some of the resources, some of the sponsors.
Yeah, it's a very good question. It's a very good question. How we get approval from it being independent from our parent society. So when I saw the first picture, when we formed the society. So what we did, we have our advisor, the president and secretary general of our parent society, and we took Professor Abha Hussain. She is our chief patron. She is now the president of Asia Pacific Academy of Ophthalmology, and we had our many seniors as the advisors. So one thing come at our positive side, that our parent society did not has any rules that every subspecialty based society will have under their supervision. So that we are before forming the Young Ophthalmologist Society, we are involved in the Bangladesh Glaucoma Society, Bangladesh Cataract and Refractive Society, Bangladesh Cornea Society. All the society has the separate registration, and for that reason, the parent society in their meeting, they had the resolution: if the Young Ophthalmologist Society wants, they can have or they might get the independent registration from the government. We took the opportunity. That's it. Thank you.
Thank you. Just a second. For people who have not collected their delegate or faculty certificates, they're available with Ninesh now. Or any confusion, I'm going to use closing the registration counter for now. Okay.
Can we have the next recorded presentation?
Hello everyone, I'm Sudashini Chandrasekharan. I'm the founder and the immediate past president of the Malaysian Young Ophthalmologists Group. Today I would like to share with you all a little bit on what we've been doing since our formation in 2020. So before I begin, I would like to send our greetings from Malaysia, young ophthalmologists here. So this slide is just to show us all the attractions in Malaysia. So we have very nice, beautiful buildings, beaches, there's heritage sites, as well as lots of food. So if you get a chance to visit us, do come over, okay? Okay, so this meeting, the first Global YO Summit Singapore 2020, was the beginning for us as a chapter in Malaysia. So I attended this meeting and I met a lot of the young ophthalmologist leaders from around the world. And this really inspired me to create our own young ophthalmologist chapter in Malaysia. So when I got back to Malaysia, I spoke to our parent society, which is the Malaysian Society of Ophthalmology, about forming our own young ophthalmologist group. And they were very encouraging about it. And that's how we were born. So we were formed on 16 March 2020 officially. But the lockdown was 2 days later on 18th March 2020. That's how perfect our timing was. So after that, it was 2 years of pandemic, but it did not stop us from continuing what we started. We wanted to start, they say begin, the rest is easy. So once we have our own group, we thought that, eventually it will become more and more active. So we started off with our objectives, which was to form a professional networking between the Malaysian YOs as well as YOs around the world. We wanted to enable academic exchanges and collaborative research opportunities among the young ophthalmologists. We wanted to enable updates regarding information pertaining to YOs. So we wanted to update our YOs about fellowship opportunities, travel grants, academic conferences, international YO meetings, etc. And we also wanted to act as a platform from which YOs are able to communicate their ideas and concerns without hesitancy. When everyone is of the same mindset, we may be able to communicate better. We also wanted to encourage active participation and contribution of the Malaysian YOs to the ophthalmology fraternity. So you must understand something. In Malaysia, we are a very small group. We only have about 800 over ophthalmologists in Malaysia. And in our YO society, the YO group, we only have about 150 members. So we did not want to be a separate body. So we still work under the umbrella of our parent society. So this is who we are. On the left side, you can see the original founding committee. And just during the APAO 2023, which was held in February in Malaysia, we handed over to the next team of very young and vibrant and enthusiastic group of young ophthalmologists. So as I said before, we are not a separate body. So most of our work associated with our parent society, which is the Malaysian Society of Ophthalmology. So as young ophthalmologists, we help to run their newsletter, which is a quarterly newsletter. We try to publish things which are relevant to the ophthalmology fraternity, as well as young ophthalmology specifically. As you can see, some of the titles here that of the articles that we have published before. We also run a very successful webinar series. We have two. One is the MSO Grand Ward Round webinar, and the other one is the MYOSIC webinar, which is Malaysian Young Ophthalmology Special Interest Group webinar. We've been doing this for the past 2 years, and we have a good response for these webinars. We also managed to get in some sponsorships, educational sponsorships from our industrial partners in order to run this series. We have other activities during every World Sight Day or the World Glaucoma Week or our annual scientific meetings. We have our own YO sessions and YO activities. Not just our committee, there are many young ophthalmologists in Malaysia who contribute to these activities, which is fun at the same time educational as well. We also have a collaborative research work that we have done among young ophthalmologists in Malaysia, as well as young ophthalmologists in the region. Then comes the big meetings. Like last year, we had 2 big meetings in Malaysia, which is the Asia Pacific Glaucoma Conference, during which we had our own young ophthalmology sessions. So we had a symposium followed by a nice, exciting young ophthalmologist night, which were both very successful. And then the APAO, which was the big meeting after a long time in Malaysia, APAO 2023. We had many segments here which involved the young ophthalmologists, such as the Young Ophthalmology Social Night, which was about influencing and inspiring people. There was a YO Symposium, there was a YO Night, and there was also a YO Lounge, which is a dedicated space for the young ophthalmologists who attended the conference. Not forgetting to have fun, we also meet up just to have a meal or a drinks together and catch up with each other, form our friendship. And this is basically what we do. So we have some future plans. We want to have more collaborations. Something that we are lacking at the moment is that collaboration with the other young ophthalmology societies in the region. As you can see, we are a very young society, and we developed during the pandemic. So now that the pandemic is over, there's more opportunities for collaborations. We also would like to get more fellowship opportunities for our young ophthalmologists in our country. And we would also like to invite others to come and carry out their fellowship trainings around our region. We would like to form strong network among the young ophthalmologists in this region. And we would like to guide our juniors, which we're already doing by the webinars and all that, but we have further plans to do this even better. So hope to see you all sometime soon in the next meeting. Thank you very much.
So any comments from the panelists?
You guys could share your experience in the Malaysia APIO very quickly.
Yeah, thank you. It was a very good WIO session, followed by the first, we had the Rising Star session and then the WIO social, and that was a very good gathering. And we always say that the communication between the WIOs is a very good thing, and this is the WIO meetings and the supranational society meetings are the great platform for the communication and also for the learning and sharing.
I think most of you know me already, so I enjoyed the WIO night the most. It was grand, and I got to make friends, so many friends, and seeing online friends in person. That was the best part of it, and I loved it.
Good. These are always good opportunities, and I hope all of you are able to join for the global WIO next year, and we'll all we'll meet there, and I'm sure we'd like to see you there as well with us.
I met a lot of you guys and made new friends and very good programs and very interesting activities. Yeah, so I learned a lot from here. Thank you. Very good forum. Congratulations.
We'll move on to the next session. Thank you so much, everybody.
So till we are arranging for the next session, so we had a fish pond session for which most of you have filled forms. So this was actually an idea inception by Dr. Sonal Kalia, our YOSI president. So she told me when the concept of WIO night came that Nupur, this YOSI forum, let us have something that each YOSI, each WIO who attends a conference should make at least 3 new friends and go. So a little bit of brainstorming on my part. And so we came out with this form. We had these different colored stickers, which obviously we played the WIO night last night. So we have 9 submissions, and we're happy to announce that all 9 of you will get a prize. So quickly, the first is Harti Heda. So Harti Heda interacted with Dr. Prasanna. So she says that she finds him very friendly and innovative. Dr. Karthikeyan is very hardworking and dedicated. And Dr. Zain, she would like to connect with him with ophthalmology and beyond ophthalmology. So Harti, so please come and collect your prize. Digvijay sir, if you can just quickly give the prize to Harti. So our next fish pond winner is Dr. Arshi Singh. Arshi. So Arshi interacted with Dr. Shilpa Ghosh, and she says that she won the WIO Slide Award today, and she has a beautiful eyes and is very humble. Then she interacted with Dr. Yashi, and she says she's extremely passionate about work and enjoys retina. And she interacted with Dr. Ayushi Agarwal, and she would like to stay connected with her, meet up at every meeting, and through the YOSI medium and WhatsApp. So our next winner is Dr. Mohan. Are you there? Okay, so Dr. Mohan is not there, so I'll skip that. Then we have Dr. Sahil Bhandari. Dr. Sahil, are you there? Okay, he's left, so I'll skip that. Then we have Dr. Anu. So Anu interacted with me, Nupur, and she says that I have a very nice smile and a dynamic personality. Thank you, Anu. Then she interacted with Dr. Piyush, and she says that she likes everything about him. She interacted with Dr. Ankita, and she would like to stay connected with her through phone. So Anu. Then our next submission was by Dr. Ankita Khanna. Ankita, are you there? Yeah, so Ankita interacted with Dr. Piyush Bansal. She found her very friendly, and then she interacted with Dr. Shilpa, and she liked her smile, and she interacted with me, and she would like to stay connected with me through YOSI sessions, and she says that this was a great way to interact. This was a great idea to make interactions this way, and kudos to whoever developed this great form. Thank you. And then Dr. Shilpa is there. Dr. Shilpa, no. Dr. Shilpa Ghosh and Dr. Shilpa Narvane. Okay, not there. Dr. Yashi Gupta is there. They're your residents. Yeah, please. So whoever is there, you can just take it. So Yashi interacted with Dr. Shilpa Ghosh. She liked her confidence. She interacted with Dr. Ayushi. She liked her that she's a go-getter. She interacted with Dr. Arshi, and she would like to stay connected with her through a video call. Dr. Shilpa Ghosh interacted with Dr. Arshi, and she says that Arshi is a very hardworking and a very good surgeon. She interacted with Dr. Yashi, and she likes her boldness and honesty. She interacted with Dr. Pranesh Balasubramaniam, and she would like to stay connected with the YOSI channel. Arshi will take it. Yeah. Dr. Yashi, sure.
Of Dr. Aman, Dr. Smita, Dr. Anu, Dr. Arshi, Team Khalnayak, Aditya, Dr. Zain, Dr. Bhavini, Dr. Nupur, and Team Bahubali, Dr. Prasanna, Dr. Amit, Dr. Karthikeyan, Dr. Rolika. So we have gathered here again for another exciting session. This is going to be one of its kind session, and first time it is happening in YOSI. It is going to be an ophthalmic war. We have grade 7 judges. So in the judges we have Dr. Digvijay sir, Dr. Divakan sir, Dr. Avnish sir, Dr. Nilesh, Dr. Ashraful, Dr. Pokoin, and Dr. Kaushal. I would request all the judges to please take the center seat in front. And teams, please keep yourself placed. So we have 4 events in this. First is surgical video. I would request your attention, please. We have surgical videos. First is surgical video for 4 minutes. So please stick to time. Interesting medical case that will be of 3 minutes. Then there is rapid fire quiz, and then there is Bollywood quiz. So each team has to come up on stage. So every team will get a chance to complete this event in total, and all the if first there will be chit selection. So the team you can pick your chit slots, and turn by turn you will be called upon stage, and you will complete all the 4 events. I'll hand over mic to Doctor.
Yeah, before starting the session, we wanted to announce the winners for the York session. The second runner-up is Dr. Monisha Apte. The first runner-up is Dr. Aditi, and the winner for the entire session is Dr. Dipanshu. So congratulations to all, and the certificates and the prizes would be distributed during the AIOS Pavilion. So thank you.
So looks like everybody is settled in the hall. Yes, no, maybe. Yes.
Are the teams charged up?
Yes.
We need something better, On count of 1, 2, 3. Yeah. So I would request you to play the video, please. We have made a small video compilation of this session, introducing every team and moderators and the judges. So can we have the video, please?
That's surprise for everybody.
Volume. Please play it again. Please play it again. Pause. Yeah, pause. Go back. Since this has been a great year for us in the terms of Indian music, so we have gone totally desi with our video. Can we have the video again, please?
Start from the beginning, please.
పొలం గట్టు దుమ్ములోన పోట్ల గిట్ట దూకినట్టు పొలేరమ్మ జాతరలో పోతరాజు ఊగినట్టు కిర్రు చెప్పులేసుకొని కర్ర సాము చేసినట్టు మర్రి సొట్టు నీడలోన కుర్ర గుంపు కూడినట్టు ఎర్ర జొన్న రొట్టెలోన మిరప తొక్కు కలిగినట్టు నా పాట చూడు నా పాట చూడు నా పాట చూడు నాటు 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 తీర నాటు 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 కూర मेरा अपना कर्म है मेरे अपने गवाहे हैं वो मेरा अपना कर्म है मेरे अपने गवाहे हैं मेरी अपनी चलत है मेरे अपने सहारे हैं गली गली तेरी लाज चलनी जियो रे बाहुबली
कैसी करुणा है
गली गली तेरी लाज चलनी जियो रे बाहुबली प्राणों से बढ़ के प्यारा तू
हम
मैं बाजीगर सबसे अलग सबसे असली डिफरेंट कैलिबर बाजीगर सबसे अलग सबसे असली डिफरेंट कैलिबर हमसे मस्ती सीधा पप्पी तेरे आंसू पर हम गेम रखते मुट्ठी में हाँ जादूगर आए बाजीगर बाजीगर समर में बजा दूंगी उठा लूंगी बांध मम्मा कमर पे आज समा बना है रुकना मम्मा मना है आज हमा नहीं आज धमा 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 ओ धमक 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 म्यूजिक पे तिरके झूमेंगे गाएंगे हम सारे मिलके आज बजे जश्न वाली जोर 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 पूंगी
Thank you.
So I'm sure you all are charged up. We really enjoyed planning this session. So the team was Dr. Karan, myself, Dr. Dipanshu, and Dr. Kaushik. And I hope you all also enjoy this. Yes, I'll announce. So we will. I hope you all also enjoy equally. So because of some reason, Kaushik is not participating in the session, but we have with us Dr. Ayushi. So she will play a very important role. So let me quickly explain you all how the session is going to be. So we have 4 teams and we have divided the question and answer and everything in 4 teams, A, B, C, D. So to be fair, we'll give equal chance to each one of you. So a team captain should come forward and pick one chit from these 4 for you to decide what will be your fate, whether it will be A, B, C or D. Okay. So we'll have 4 rounds. First will be surgical case, which will be for 4 minutes. Then will be the interesting medical case, which will be for 3 minutes. Then we will move on to rapid fire quiz. You'll be given 1 minute of time to answer the questions. The maximum number of questions will be 10. If you can't answer the question, just tell pass so that you save the time. And yes, there is negative marking to this. So for each correct answer, you get plus 10. And for each incorrect answer, you get minus 5. Okay. You'll have 4 choices. No, only one person from the team can answer. You can whatever, I mean, that you will be sitting here on the stage, but only the person who is holding the mic, and you have to choose that person. That is going to be the final call. Okay. I will give you a chance to ask the doubts. So just let me complete. Then the last will be Bollywood quiz. So we'll have 5 questions in that, and for each correct answer you'll get plus 10, and here also for each incorrect answer you'll get minus 5. And you will get 10 seconds to answer the Bollywood quiz. Please listen the instruction and then discuss. Prasanna looks like very busy making the strategies. Okay. And on top of all this is for the judges. We have given you the score sheet. We do have marks for team representation. That includes whatever getup you are sitting here with. Okay. So, anything I have missed? Okay. So, Dr. Ayushi will take care. Yes. So, yeah, I have told them. So, Dr. Ayushi will keep an eye on the time. Dr. Karan is going to give you scores for the quiz. And I'll be asking you the ophthalmic quiz, and Dipanshu will ask you the Bollywood quiz. So, any question from the... No, you can't have anything related to surgery in the medical case. The instruction was very clear. You have to present.
Disqualified.
Yes,
Disqualified. Abhi say.
Let the case be purely medical management of any interesting ophthalmology case. Any other question anyone has?
For the Bollywood quiz per question.
10 seconds. Per question, 10 seconds.
Since we're looking so smart, can you give us plus 100 to start with?
So okay, that I'll leave on to the judges.
So the
Okay,
person will
so
be sitting
I
there. Person will be sitting there. The others can prompt the answer, na?
You all will be sitting there.
All.
But there will be one person
who will have to answer. Yeah.
So are you 5 or 4? No. Then she has to take the audience seat, please. Otherwise, you'll get minus 200.
Karan is
Okay,
our manager.
so any other questions from the judges? From the participants?
Please don't concentrate on negative marking.
Okay, so judges will give marks for the surgical case and the medical case. You don't have to ask any questions. You just have to give the scores. For the scores, other Bollywood and the ophthalmic quiz, Karan will take care. Now you decide whatever anybody wants to bribe any of the judges, you are free to do that. So I assume that there are no more questions and we start. So can the team captain come forward and pick one from this? Please come fast. The person looks like Aman has no option now. He has to pick the chit. Aman, just pick that chit which is left for you. So,
What questions will be asked to you?
Discuss 10 seconds on question, or as you answer it keeps going.
for rapid fire?
Rapid
Yeah.
fire.
So Prasanna wants to know more about the rapid fire quiz. We will have 10 questions maximum. You will get 1 minute to answer. As soon as you answer, I'll move on to the next question. You can read the question yourself and answer. Though I have not completed talking about it, I'll go to the next question. If you don't want to answer any question, you can just tell pass so that you don't waste the time. Is it clear? Any more questions? Okay. So, team Bahubali is team A. Please, for the judges. Team Bahubali will be team A. Will come first. Huh? No. We'll start with A. We'll start with A. So team Bahubali is A. Team Dabang is team B.
Second to go is team Dabang.
C is Khalnayak, so they will be the third one. And Bazigar will be the last team to come forward.
All set, yes.
Okay, so please, this is team Bahubali. This is team Bahubali. And judges, you can score for the time when it comes to the surgical case and the medical case. Okay? 4 minutes and 3 minutes.
You can reduce the marks if they exceed the time.
Which one?
We'll start. Respected judges, can we start?
Namaste, I'm Dr. Amit Pandey and I'll be talking about smile lenticule assisted modified technique of emetic glaucoma valve implantation. Glaucoma drainage implantation is the surgery of choice in refractory glaucomas, especially when trabeculectomy has failed. But tube exposure is a major obstacle in drainage implant surgery. To prevent tube exposure, a layer of patch graft is usually used to cover the drainage tube. Many different graft materials have been used in the past. But donor corneal tissue seems to be the best because of its tight structure and good aesthetics. Presenting a case of a 72-year-old male with uncontrolled glaucoma and a previous history of failed trabeculectomy. He underwent emetic glaucoma valve implantation. A different patient underwent a smile surgery and 2 corneal lenticules were obtained from him. After implantation of the tube in the anterior chamber and suturing it to the sclera, the first lenticule is taken and folded like a taco. It is then placed over the long axis of the tube, making sure to cover the area of insertion of the tube into the sclera. The second lenticule is then taken and unfolded. The scleral bed is dried. Fibrin glue is applied. And the second lenticule is placed over the double-layered first lenticule to create a triple-layered configuration. The conjunctiva is then closed over it. An animation depicting the same steps These are the post-operative results on day 1, week 3, and 6 months follow-up. The advantage of smile-derived corneal stromal patch grafts are: it is cost-effective, cosmetic appearance seems to be ideal, the tube is partially visible through the transparent graft, so blockage or ligatures can be observed, no preparation is required in the eye bank, the ease of manipulation of the tissue, and as it is a laser cut tissue, no irregular, sharp or ragged edges are present, so there are lesser chances of conjunctival retraction and Dellin formation. This tissue is also devoid of any epithelium or uveal tissue remnants. It is acquired in a sterile OT environment, hence there are lesser chances of contamination. To conclude, corneal stromal lenticules derived from smile surgery may be an ideal patch graft over glaucoma drainage devices. With more number of smile surgeries being done, the graft availability issue can also be resolved. This is a novel technique and a larger prospective study is required before the surgery can be performed on a large scale. Thank you for your kind attention.
Thank you.
Very nice.
So who's your team leader, Prasanna? So maybe you can cheer up, say good things about your team to score some impression on the judges. You see, you have your ways of driving them. So
Yeah, I'll just wait for my slide. No, we'll try to underplay the. We'll all 4 of us will underplay the event. Can I have my slides? Yeah, thank you for the opportunity. I'm going to talk on a medical case, an interesting case, diagnosing glaucomatous damage in a patient with neurological pallor. If it's glaucomatous pallor or neurological pallor, that itself will cause a lot of headache. What if both are together, and how do we going to pick it up? Because it's something which is very fallen in our blind spot, and we have used a novel Brooks membrane opening minimum rim width tool, and I'm just going to take you through this for the next 2 minutes as to how we went about it. So this is an animation showing how the OCT interpretation recently changed, where you can see that the Brooks membrane minimum rim width. Previously we had the horizontal rim width between the horizontal plane. Now we have the minimal rim width, which is nothing but the distance, the smallest distance between the interlimiting membrane and the Brooks membrane opening. So we have used it to our advantage. You can see that previously if there is an eye movement, you miss the plane. But with this, even if there is eye movement, you end up getting the same plane of choice, and even 1 to 2 micrometer difference will be able to pick it. So what happens is, first the macula is plotted center, then the disc is plotted, then the fovea BMO axis is plotted, then the RNFL and the ganglion cell layer are centered on it. So this is the case, this is the technology that we have used, and this is a 73-year-old gentleman, also occipital lobe infarct, 30 years back, right homonymous hemianopia, macula sparring. He says for the last 1 year, he has defective vision in the seeing field. And the routine checkup says visual acuity is normal, color vision is normal. We do a DVT and 21 in only one reading in 10 o'clock and 12 o'clock in right eye and left eye. There is temporal pallor, CD ratio 0.7 and 0.8. This is the fundus photo of this particular gentleman. Visual fields 24-2 reveals there is a slight spillover of the visual field defect in the seeing area as well. This is a 10-2, and the BMO MRW, as I pointed out in the animations, it's constricted, my dear friends, in both eyes, and the cupping also looks more cavernous. So we do a progression analysis. The patient comes on December 2019, then for 3 months we see the patient, we analyze it whether it's going in for a progression. Since the same piece of tissue is examined in every visit, you can see that there is a progression in RNFL and the ganglion cell layer, inner plexiform layer in this patient in the right eye as well as in the left eye. You can see the early defect pricked in this patient, and we started the patient on dorzolamide, and the patient is doing well in 2 years of follow-up. The rationale for diagnosis is history taking, mild diminution in the seeing area, occipital lobe infarcts, does not cause glaucomatous cupping. There is a diurnal variation of IOP, enough to at least diagnose NTG. There is a breaching of the basic sciences. The ISNT rule is breached. in the fundus, the OCT progression was documented with great precision, and there is an increased inception of superior arcuate scotoma in the seeing eye. So this is the patient now, March 2023 follow-up. If I compare this with this and this with this, the progression analysis is more or less the same. There is no progression in the last 3 years, and the patient is doing good. So this is the first technology we applied, and we have diagnosed this. Thank you once again for this opportunity, and these are my references. Thank you. Next, the quiz will be taken by Karthik Mahalingam, our Katappa. Yes.
So basically, he'll be stabbing you from behind, huh?
And Rolika will be taking the Bollywood quiz.
Dev Sena looks to be little scared. Very scared, she said.
Yes, thank you.
So whatever answer Dr. Karthikeyan give will be taken care. Okay? Can you please play Team A PPT? So Kaushik was supposed to conduct this quiz, and since he is not available, I am conducting on his behalf, and he was kind enough to share wonderful questions with us. So are you ready? Is the timer ready? Karan is ready? Okay. So here we start. This is the finding in a 26-year-old female. Vision is 6/6 in both eyes. Which of the following medication is most likely to cause this?
Acetazolamide.
Please?
Acetazolamide.
Okay, the answer is minocycline. The fundus photo of a 25-year-old female is given, similar in both the eyes. What is the most likely advice? Avoid high-velocity sports, intravitreal ranibizumab, systemic evaluation to rule out nematode infection, laser.
Pass.
So avoid high-velocity sports. Diagnosis of this: subconjunctival worm, cyst, thread under the conjunctiva, conjunctival lymphangiectasia. Quick.
Conjunctival lymphangiectasia.
Okay, you're correct. What is the name of this glaucoma drainage device made in India? Ahmed Valve, Adi?
Adi.
Okay, next. The deposit of this material is in which layer? Bowman's membrane, epithelium, Descemet's membrane, endothelium.
Descemet's membrane.
Okay. Diagnose the lid lesion: cavernous hemangioma, capillary
Capillary
hemangioma?
Yeah.
Okay, you're correct. The color of the Facebook page is blue because, to contrast with Google, to reduce computer vision syndrome, Facebook CEO has...
up.
You can still take this question. You can...
C.
Okay, you're correct. Okay, so how many questions they have answered
So
correctly?
they've answered 5 correct and 1 wrong, 1 pass. So your team score in the quiz is 45.
So we have questions or else my team. So skip कर ले.
So we'll be moving on with our Bollywood quiz. This will have 5 questions. Every question you will have 10 seconds to answer. Okay, shall we start? Have you seen this movie?
Yes.
One of the actors in the video has an oculoplasty condition in real life. What is it?
No options.
Pass?
No options are going
No
to be
options.
there. No. Your time's up.
He has Marin-Amat syndrome.
Really?
Next question. Identify the actor.
Abhishek Bachchan.
Yes, you're right.
Okay.
Which was the first sound movie?
Pass it.
You have options for that.
Raja.
Which one?
Raja Harishchandra.
Has to answer.
Yeah, I'm saying. Time's up. Alamara.
Time up, sorry.
I said Alamara.
No. Time up, sorry. The procedure has been done on this actor. Actor had written a book on the type. The picture of that is on the top right, and you can take some clues from the below pictures. What actor is famous for?
Pass. Okay. Okay. Got it.
But it's Twinkle.
Okay, okay, got it.
So it was Twinkle Khanna. She has written, she is Mrs. Funny Bones. She has undergone a squint surgery in 1996.
Okay.
Identify any correlation between the Bollywood scene and the refractive surgery.
Don't. This is aphakia. Yeah, he's wearing the bilateral aphakia.
Refractive surgery.
Refractive surgery.
Time's up now.
He's yeah. This is not for high myopia. This is IOL implantation. These are the aphakic
Myopic
glasses.
glasses. Myopic glasses.
No, no. No, he is wearing.
Myopic. है ना? Patient is myopic with high power, and patient can. This was the question.
Quiz master is fine. It's okay.
So this was the last question. Yeah.
Okay, so they get 5 points in this round. Okay, let me remind you all, this Bollywood quiz is not a rapid fire. So you can take your time to think, but you have 10 seconds. Okay, and try to correlate.
Can we have...
The time starts after finishing the question.
Yeah. So any comments? Team B is Dabang. Can you move on to the stage, please? In the meantime, any comments from the team captain, Team Bahubali? Any comments?
We thoroughly enjoyed the event, and I think it was a great initiative. We thoroughly enjoyed it, and I think the next teams wish you all the luck. Thank you. We'd like to take a selfie.
Photographer. Yeah.
So, Team Dabang, can you please take your seats quickly?
Actually, we are running quite late.
Yeah,
So we have to speed it up a bit.
So please, the person. Okay, so we are ready. Who is presenting the surgical case?
I'm presenting. Can someone play the... Can you please play the video, Team Dabang? So be prepared to be wowed by the enchanting Rajjo. So who all has seen an oculus polydiosis? Have any one of you seen? It is very rare. And has anyone seen a bulbar oculus polydiosis?
Associated with staphyloma.
Can you increase the volume, please?
Management, a rare case. Rhinosporidiosis is a chronic granulomatous infection of the mucous membrane caused by Rhinosporidium sebae. When the spores enter a breached mucous membrane of the nose and nasopharynx, clinically, the subepithelial yellow-white dots or spherules are classical. A 23-year-old male presented to us with a mass in right eye, painless, gradually progressing to its present size, not associated with diminution of vision, no history of trauma, surgery, and animal control. There was, however, a history of frequent pond water bathing with no other similar mass and no history of ENT bleeding. In the right eye,
See the size.
Oval swelling situated 3 mm superotemporal from limbus, approximately of 13 into 17 mm. The bulbar conjunctiva was fleshy with multiple yellow dots. Ultrasound biomicroscopy, we could see a large cystic mass with scleral heavy.
But Rajjo ko dar nahi lagta. I'll just show you the surgery.
The mass was excised with 2 mm of normal looking conjunctiva. The surgical field was kept dry to avoid settling. A blunt dissection was made, taking care that the staphyloma did not rupture. The conjunctival mass was removed in total and sent for histopathological examination. Then the underlying staphyloma was repaired with minimal cautery to avoid perforation, yet shrink the lesion. Scleral patch graft was used to provide tectonic strength over the reduced papilloma. This was secured with fibrin loop and sutures. The remnant conjunctiva was pulled and, along with the tenant pedicle, covered the scleral patch graft. The challenges faced was in toto excision from the base without perforating. Postoperatively, the chances of conjunctival flap retraction, scleral patch related complications, and recurrence. On histopathology, we could see spores in different stages of maturation. Postoperatively, the patient was given topical steroid course, lubricant, and antibiotic. After G6PD deficiency being ruled out, the patient was started on oral dapsone 100 mg post-op photograph. We could see a graft well conjunctivalized with no conjunctival retraction, no scleral graft melt, and most importantly, no recurrence even at 3 years. Bulbar ocular sporidiosis with large staphyloma is rare. A very high index of clinical suspicion is required. Histopathology is definitive. Scleral patch graft provides tectonic strength. We document the largest scleral patch graft used.
And we have published an IGO last year.
ENT evaluation is a must, and early diagnosis is the key to avoid perforation.
रज्जो को ना कॉम्प्लिकेटेड केसेस से डर लगता है ना ऑफ्थेल्मिक वॉर्स से।
Wow, wow, Rajo, wow. Just to be sure, did I hear the largest ever documented world record? भाई अच्छा ही बताओ, स्विमिंग का वर्ल्ड रिकॉर्ड किसके नाम है?
रज्जो।
माइकल फेल्प्स के। सेकंड कौन आया था?
रज्जो।
किसी को नहीं पता। किसी को नहीं पता। We have a world record holder who presented the case. The competition is dead, dude. I mean, it's a no-brainer.
PubMed says no.
All right, so next we have Robin Hood Pandey. हम भी पांडे हैं, हम चुलबुल हैं.
Can I have the case, please? Team B. So I'm going to present this case where Chulbul Pandey will become a wimping kid by the end of it. This is what my long nightmare looked like. So this was a LASIK patient I did who was a budding actor, came with a normal refractive error, no kind of other pathology. Systemically, post-operatively, we did a femto LASIK for this patient. He was uncorrected visual acuity 6.6 on the first post-op day, looked pretty okay. Then he calls up at about 3 p.m. complaining of pain. So I asked him to come back for a checkup. And to my horror, I saw this in one eye, in the right eye. And by this time, my heart was already up in my brain. So my questions with this was this infective etiology or was it an immune infiltrate? It was progressing rapidly. I was worried about Pseudomonas. At this point, the other eye looked like there was some cellularity starting to develop. In my panic, I was like, this may be infective. I think the first thing to do is to stop the steroids. I put the patient on Ali topical vancomycin and amikacin and continued lubricants. And the next day picture was this. Now the second eye is also involved. And by this time, I am totally in full panic. As you can know with a LASIK patient, this is extremely troubling. So there's an increased density of the infiltrate in the right eye, and the left eye is now involved even worse than the right eye. The slit images shows an area of DLK in both eyes along with the cellularity. So panic had set in completely. I continued with the topical fortified drops, continued lubricants, but I did get a scraping done from outside the flap area. This showed gram-positive bacilli, which again is completely inconclusive. It wasn't pointing towards any particular kind of etiology. So at this point, I stepped up the antibiotics, went to colistin as the next drug to use, and made a phone call to some of my mentors. They looked at the clinical photos and immediately felt that this looked more immune mediated because it was following the contour of the flap. So with trepidation, they encouraged me to start topical and systemic steroids, and I did the same with held breath. And the good thing for me was it started to respond. As you can see, it started to clear up. This is the day 5 image for both eyes. And finally, at about day 15, it looked like this. There was minimal scarring along the flap edge, but there was no DLK, and the patient's uncorrected visual acuity improved back to 6/6. So the possible etiology for this is a peripheral infiltrative keratitis. Is post-op NSAIDs can cause this. Bandage contact lenses trap antigens in the tear film. This inhibits the cyclooxygenase pathway and leads to a collection of leukotrienes, which can cause this kind of peripheral infiltrate developing. Our case was different because the patient wasn't on contact lenses and was already on steroids, so this made it a little tricky to diagnose. Thank you.
Another 1 in a million case. Another 1 in a million case.
Points also 1 in million.
Looks like Rohan wants to be the judge instead of the participant. So next time I'll keep that in mind. And can we have presentation for team B? Who is taking the quiz? Rapid fire quiz. So your time will get wasted in the song, Rohan. Are you ready?
Yes.
Rutuja, are you ready?
Yes.
Rutuja will hold the mic. Are you ready, Ayushi and Karan? Okay, so here we start. The visual fields of a 46-year-old male are given. He has taken medications for complex partial seizures. Which of the following drugs might be implicated? Clonazepam, gabapentin, vigabatrin, valproic acid.
Pass.
What is the name of this surgery? Trabeculectomy, trabeculotomy, iridonclysis, Elliott's finding.
Pass.
This patient has this appearance of the cornea bilaterally. In which city of India was this surgery likely performed?
Indore.
Correct. What is the most likely predisposing factor? Diabetes, hypertension, weightlifting, HIV.
Weightlifting.
Correct. A 10-year-old complains of recent onset night blindness. The slit lamp image is given. The fundus appearance is normal in both the eyes. What is the most appropriate management? Genetic testing, VEP, capsules of vitamin A, observation.
Vitamin A.
Which musical instrument was he proficient in playing? Guitar, harmonium, saxophone?
Saxophone.
Okay. What is the diagnosis?
Your time is up.
We'll take this question.
Microphthalmia with orbital cyst.
Okay, you're correct. So we'll wait to hear from Karan, but
So they've answered 5 correct. So 50 points. Great job.
So shall we start the Bollywood quiz? Who will be answering?
I'll be answering.
Great. So this Bahubali actor is blind in one eye, and he has had a surgery in the left eye. What surgery has been done in his left eye?
Corneal tear repair.
Close. I'm sorry, it will be a negative answer. No. Corneal tear repair.
Next.
Identify this actress. Take your time. You have 10 seconds.
8, 7, 6, 5.
Your time's up.
Pass.
Do you identify this festival?
Tomatino.
Yeah. So in this movie, where did the 3 friends meet?
Where did they meet first or where did they meet go? Please specify.
First.
Mumbai.
No.
Of course, they met in Mumbai first, then they went.
Your time is up.
I
Time's
asked
up.
specifically. This is very ambiguous.
Time up. Spain. They met in Spain. They met in Spain. You can Google it. So this is a procedure, and there is a TV series. So one of the contestant in the recent Big Boss sessions underwent this surgery.
What's the question?
Which contestant was he or she?
Your time is up.
So it's Gavi Chahal. So I'll play a video, an audio. Question is not that. Which movie is this? You don't know the song? So which movie is this? This is just a out of the question.
प्यार किया तो डरना चाहिए.
Yeah. So in this, Salman Khan, when he goes to meet Arbaz Khan, he troubles him a lot. So there is this scene in the movie. Which refractive step would you correlate with this? Step of a refractive surgery.
PRK. Epithelial.
Surface ablation PRK. Great. So I think we have finished 5 questions. Thank you.
So team Dabang has 2 wrong answers, 1 pass and 1 right. 2 pass, 1 wrong and 1 right. So they scored no points, 0 points. Yeah, so it's 50 plus 0 so far, 50 points.
So next we have
Meantime,
team
can we have the
Khalai.
second team of the third team?
Team Khalai, can you please sit?
यही है.
You have to sit there.
ऑडियो का कौन सा है?
Any comments? So how are you finding it so far?
It's very enjoyable and it's really good. And specifically, the cases they're presenting, that's really good. And also the total system and the Bollywood quiz, I like it.
Tell him not to increase the sound.
Can we have the music?
Incision very carefully. I make the incision, and what do I say? I see something that I cannot believe. I go on and stain, and with staining I can see now what I confirm an explosion of materials coming out stained with refinement. So we have the Khalaiks, we are not bothered by this because my last case I just took a deep breath, I confirmed that this is materials, and I just followed some basic steps. The first thing is to inject this person OBD. After injecting OBD, I see that there is a large 150-degree subluxation in this patient. So what do? I just go about my business. I do a recess, but I see with the forceps I cannot do. So an important pearl here is make a straight system and make the incision. And then once that is done, with the help of the recess process, I initiate and successfully go ahead and complete the capsular recess. Then I go ahead and do my hydrodissection. After doing hydrodissection, before rotating the lens, it's extremely important to make sure the bag is stable. So before I attempt to rotate, I put in iris hooks to give some stability to the bag. That is my first method to try to stabilize the bag. Then I
like go ahead with the bimanual rotation, but the nucleus fails to rotate. So mind you, this is grade 2. So for additional support now I insert into the CPR. So CPR along with the iris together are a very strong support for the capsular bag. And now once this is done, I'm able to successfully rotate the nucleus. The fourth pearl is Chico should always be done with these formative parameters. So the only method which minimizes the formative parameters is divide and conquer 4 quadrants. We are not doing any kind of chopping, we are just using sculpting or trenching. And with the sculpting, the goes on quite uneventfully. So once I come out, there is so much of positive vitreous pressure that the bag has got pulled forward. So the next thing is to do a thorough anterior vitrectomy. So I'm doing the vitrectomy specifically and then I go ahead with my cortex removal. Once the cortex removal is done, I go to inject the IOL, but realize the pressure is so much between the IOL and not going inside. So I just do the vitrectomy once again near the wound. And now after doing the vitrectomy, the toric IOL which I planned initially goes into the bag. The bag is constantly getting pushed forward with the struggle to actually put the lens inside what is gone in. If I remove the iris hook and inside, I am not satisfied. You can see how the whole thing is tilted and it is still coming out. So the last step that is to be done in this case successfully is to remove the vitreous from past cleanup to reduce the vitreous pressure and load and to prevent vitreous from coming to that part of the body. And now once I go ahead and do the past cleanup, you can see how stable the whole back complex is, and the final thing is to align the toric IOL into place. And once the toric IOL is in place, that's the end of the surgery. Go ahead with the vitrectomy and so that's the Kulnayak way of managing complications which we encountered in.
Wow, excellent, excellent. You saw him become Nayak, then Nayak, and then Nayak again. Amazing. Now, let's take you to another level of Nayak and Khalnayak. So, this is a. Let's go so, this is the case. We've all been in the OPD as a pediatric ophthalmologist, also a doctor, a detective sometimes, judge and jury. Imagine if it's a child. So let's introduce a 6-year-old girl child with 2 other parents walking to my OPD. The child was walking to the the thing is, we check the location of the child check. It's going to be a law case. Why you are there? So if this child is there, let's find out. Both the Khalnayak and the Nayak at the same time. I want to know more. The parents said child is complaining of blood, vision, watering or last 2 weeks. That's similar. The parents suggest if you send the patient started after tiny conditions started. Parents complaining multiple injuries. I think what the relevant history that I was dug more into, mother says that she is unresponsive to pain or distress and there's a history of cheek biting, sensitivity, multiple fractures, being elsewhere, non-consensual marriage, baby, normal delivery, sexual community, also problems with exaggerated specific points that I would point out getting some of the pain in the mind, it's not distraction in the past. Normal position of everything also family history on taking care of the child was conscious of this missing examination, multiple ulcers, hypertrophic, Large campaigns follow the right judge also had time to listen to the parents, they would have never got it. Thank you.
Some time to diagnose.
Think about the parents' pain.
So Aditya thought that since I am Khalnayak, I have that liberty of taking some extra time, but I'm sure judges won't allow that. And I was wondering, Zain, very wonderful, wonderful case. But how could you see vitreous with your black glasses? I was just wondering that. हमें तो वैसे ही नहीं दिखता है, उसको ब्लैक ग्लासेस से भी दिख रहा है. My first comment was that that was a wonderful case. Team C. Team C. Team C को लगा दो. So who is going to take the quiz?
I'll be.
You're ready? All set?
Yes.
Ayush is ready. Karan, you're ready? So I understand we all are hungry, but let's try to finish it fast. So here we go. A 45-year-old male patient was using some FDA-approved eye drop for seeing near vision clearer. Now he is diagnosed with rhegmatogenous RD. Which of the following topical drops may be implicated? Pilocarpine 1%, 1.25%, 2%, 1.5%.
C. Pilocarpine 2%.
Wrong. This is the fundus image of an adult male who came for a routine eye checkup, which is the most important investigation to order: blood glucose, saturation of oxygen, lipid profile, HIV.
Lipid profile.
Correct. Which mutation is most likely to be seen in this patient? Fundus finding is similar in both eyes. USH1B, BBS1, ABCA4.
Pass. ABCA4.
Okay. What is the diagnosis? Leukocoria, IMSC, membranous cataract, opacified IOL.
D. Opacified IOL.
Correct. Which is the cause of, what is the cause of blindness for this singer?
C. ROP.
Correct. Diagnose the CT image: maxillary sinus polyp, intraocular foreign body invading maxillary sinus, orbital floor fracture, orbital
C. Orbital floor fracture.
Your time is up. Okay, fine. Correct. So Karan will tell us the score.
So that the answer given by the person who's been designated will only be considered. So you got lucky over there with the wrong answer, that because she did answer that. Yeah. So they've answered 4 correct and 1 wrong. So their total is 35.
So are you ready for the Bollywood quiz? Who will be answering?
I'll be answering.
Okay, great. So this is your first question. This contestant recently participated in Indian Idol and he underwent
Keratoconus.
Great. Identify the actor.
Hrithik Roshan.
Great. So this is not identification of the actor. I'll tell you the actor. Can you tell in which year Aishwarya Rai was crowned?
1994.
Great. Correct answer. So there is a situation mentioned here one of the actors in this movie had this situation, had this condition, or had this issue?
Bells. No, wait. No, wait. Time's up. Bells. Not Bells.
You were right in
Bells Farsi.
diagnosing
Bells
the
Farsi.
correct, but the actor is Amir Khan.
No, so you had.
I asked the actor, which actor in this movie?
You said the condition.
Did I ask?
We
I
didn't
asked.
No. You asked the condition.
I asked which actor. I asked which actor in this movie.
We asked, yeah. ठीक है, but no negative.
I asked which actor in this movie had this condition. Oh, all done.
3 correct. So far they scored the best in the Bollywood round. So 30 points. And actually they are leading because of the Bollywood round in the terms of the quiz.
So we don't have these scores from
35
judges.
plus 30, it's 65.
But then they are leading, right?
Right now.
Yeah. So thank you. Next I invite Team Bazigar. Can we be little fast?
Fast. Actually, we are running quite late.
The problem is we are hungry.
Yeah.
Dr. Anu, don't fight with the judges, otherwise they'll give you minus marks.
ये गोरे गोरे गाल, ये तीखी तीखी नजरें, ये हिरनी जैसी चाल, ये काली काली.
Okay, now let's get back to ophthalmology.
दिल वालों का मैं दिलबर, बाजीगर मैं बाजीगर, दिल वालों का मैं दिलबर. ओ दिल लेके दिल दिया है सौदा प्यार का किया.
Can I have the video, please? So time starts. So this was a case of a trap done in an IRIDIA patient with LSCD, one-eyed female, other eye no PL. This eye was hand movements. Cupping could not be visualized. High tensions, optic nerve head cupping, tensions almost 30 on maximum medical therapy. Started as a routine case. She did have nystagmus, we'll be seeing later. Once the block effect fades away, routine incision, triangular flap, MMC done. Started dissecting, modified Moofield's technique. The side edges were falling short of the limbus. Very confident I could create a flap, but what did I see? There was a gush of fluid. Extended the side edges till the limbus and there's a black tissue. ये काली काली आंखें क्या आ रही हैं? Try to create another flap just above it. Try to do further dissection instead of opening up another new site. Am I going to have a cyclodialysis cleft? This is premature entry. Would the patient be having hypotony on day 1? Flat, AC, everything going on in my mind. But I feel composed. Try to suture this first. A lot of fluid coming in here. We can see the gush without even entering. So premature entry. Try to secure this. Similar to a no-touch technique. Did not want to create any new thinning areas here. Try to pass in 2 to 3 mattress sutures to close it before I go in with the punch and create a further defect. Trying to secure as much as I can. Looks easy but was very tough both with the hands and in the mind. Trying to do as much as I can. Looks a bit well opposed now. Try to proceed further. I think I'm happy with this. Try to enter. I'm usually a Kelly's punch person, but I did not want to put in a punch here. Try to do it with the MVR and try to cut a small sclerostomy with the Vanas. Again, notice some fluid from the other edge. Trying to put in another suture here. And iridia, no PI. There was no iris stump for that matter. Ensuring that the sclerostomy is complete. Finally feeling a bit happy but very worried about the post-op day 1. Closing the suture flap. Usually I do one fixed and two releasables, but I was worried about the hypotony, so did not pass any releasables here. And there was a lot of leaks, so had to put in 5 sutures, could not bury them, left it like that, put in an amniotic membrane, and conjunctival closure was done. Looks good on table. AC depth cannot be assessed on table because of the opacity and a lot of vascularization of the cornea. One-eyed female, very, very stressful. Looks good for now. But we are the Bazigars after all. Post-op day 1, nice bleb and thankfully a nice anterior chamber. I can see the anterior lens capsule and the endothelium. So good job done, Bazigars.
एकदम रापचिक मैनेजमेंट है, क्या बात है.
करने का ना
ओनली बाजीगर्स.
So this Bazigar is going to present a medical mystery. So we had a 25-year-old male who comes to us with left eye loss of vision since 1 year and right eye decrease of vision for distance and near since 6 months. His history was gradual, painless to progressive loss of vision in the left eye and decrease of vision in the right eye. He had consulted elsewhere and was diagnosed as glaucoma and was started on medications. He had a family history of glaucoma as well. On examination, his best corrected visual acuity was 20/100 PR accurate in the right eye, PL/PR inaccurate in the left eye, with a 30-degree sensory exotropia and pupillary atrophy in both the eyes. There was a RAPD in the left eye. Intraocular pressure was 14 and 24 respectively. Lens was clear. On gonioscopy, there were occludable angles in both the eyes. On fundus examination, there was a medium-sized disc with 0.9 CDR with DDLS 8 in the right eye and DDLS 8 to 9 with rim pallor in the left eye. On field examination, he had advanced damage with macular split in the right eye. The diagnosis was advanced PSCG with sensory exotropia in the left eye. He underwent a YAC-PI and his topical medications were continued. He came to us post-PI, gonioscopy showed closed angles. Investigations were done to rule out plateau iris. However, there was a left eye IOP spike despite the patent PI. So he was planned for a sequential trabeculectomy in both the eyes. Okay, all said and done, seems like a closed book case now. So both eyes underwent a trab, both the eyes were doing well, both blebs doing well, intraocular pressures less than 10. However, he comes back to us with sudden loss of vision in the only seeing eye in this 25-year-old male. He suddenly hand movements at post-op 1 week, absolutely shallow AC, bleb still doing well, lens bulge, and intraocular pressure very low. Seedles test negative. We could not even measure the intraocular pressure or a GAT. The fundus has no choroidal detachment and the left eye is still doing well. So we have a shallow AC, low IOP, and a moderate bleb. Could it be overfiltering? Could it be a bleb leak? What could it be? We still have something going on in our heads. Ultrasound shows everything is normal. UBM says there's no ciliary body rotation. So we go back. Is it overfiltering? No. Bleb is fine. There's no leak. There's no CD. There's no bleed. So what could it be? Review the literature. We came across an entity called hypertonous malignant glaucoma. So now what are the management? It can be medical, laser, or surgical. So what did we do? We tried the medical management for this patient. He was started on topical steroids which were tapered now. He was started on intensive cycloplegics, did not improve. We did a AC reformation with the viscoelastic. Again, did not improve. Repeated that with a more viscous Helon GV this time. Again, did not improve. Had reviewed the literature, so knew something known as a vitreous tap. So we did a Chandler's procedure for this patient and thankfully he started regaining vision. However, while all of this was going on, we were trying to manage this. The left eye suddenly goes into shallowing of the AC. Again, the similar picture, but intraocular pressure increased. All right.
That's all right. We are done with the case. Have you ever heard of a hypotony?
So this is hypertonous malignant and hypertonous malignant both. Again, did the same management.
Time up. We are not discussing further. Have you ever heard of a hypotenuse maculopathy?
Yeah.
It's not a surgical case. It was managed medically.
No. Dr. Anu, hold on. Let her talk, please. That's her case. Let her talk.
It was mostly managed with just atropine. We did a small vitreous tap, yes, because the medical management ultimately did not fail. That's exactly what we're pointing to. So this patient had a hypotonous malignant glaucoma and a hypertonous malignant glaucoma. Both eyes had malignant glaucoma of different varieties. So start thinking out of the box, guys, and never stop reading, because this patient we could not have diagnosed. Only seeing eye of a 25-year-old male student. And we saved it ultimately. Thank you.
Amazing, Arvind. Amazing. Shallow AC, who would think
Can
of
we have
malignant?
presentation for team C?
Great, awesome.
Diagnosis.
What a diagnosis.
Who is going to take the quiz? So you have the mic in your hand.
I'm giving.
Okay.
Okay. So Ayushi, you're ready. Karan, you're ready. So let's start. What is the most likely associated ocular finding? The fundus features are identical in each eye. Brushfield spots, Berlin's nodule, KF ring, Lish nodules.
Pass.
How did he become blind? Glaucoma, ARMD, sympathetic ophthalmia, congenital cataract.
C. Sympathetic ophthalmia.
Correct. What is this iridotomy called?
B. Andos iridectomy.
Can you be a little loud, please? This is used to manage miotic pupil, subluxated cataract, capsulorhexis, run out, dropped cataracts.
B. Subluxated cataracts.
Correct. What is the most likely cause? Laser iridoplasty, smallpox, laser peripheral iridotomy, Axenfeld Rieger syndrome.
D. Axenfeld Rieger.
Smallpox. That was wrong. What is the inheritance pattern of this disease? Autosomal dominant.
C. X-linked.
Can you repeat?
X-linked.
Wrong.
Time is up. Time
This
is up.
child is brought.
Time is up.
Okay, fine.
Can we have the Bollywood quiz now?
Yep.
So far, they have 3 correct, 1 pass, and 2 wrong. So they have scored 20 points.
Are you guys ready for the Bollywood quiz? Who is going to answer? Great. So here's your first question. Take clues from. What kind of corneal lesion would correlate with these images? What kind of corneal lesion would correlate with these images?
Time is over.
Satellite, feathery lesions, satellite lesions, pigmentation. All right. So identify the actress.
Priyanka Chopra.
Great. So have you guys seen this movie, Super 30? Hrithik Roshan has played an actual educator. So who is that Indian educator?
Anand Kumar. That is D.
That's the right answer. So correlate these images. One of the Indian actors has this condition. Which Indian actress it is? So there are some
Time is
features
up.
of the disease.
Time is up.
We don't know. Sonam Kapoor has type 1 diabetes actually. So identify the correlation between Bollywood scene and the refractive surgery. Look at this face, beautiful face. Which refractive surgery would you correlate it with?
Smile.
Relax, smile. Great. Thank you. That were all your questions. Thank you. Thank you.
So, so far, till we judges, can we have the marks for everybody? We'll do the totaling, and for the quiz, I'm announcing regarding the quiz. So, Team Bazigar had scored 20 points in rapid fire quiz. So, and Bollywood quiz, they've scored 30, so they're at 50 points. Team Bahubali is also at 50 points total. Team Dabang is also at 50 points. However, Team Khalnayak is leading currently with 65 points. So now it's up to the judges.
So we till the time the
Kaushik has the answer. Kaushik has the answer.
now the scores have gone. So you can sing. You can sing. I allow you.
Avanish, can you
So I
announce
would
the
like
yaw-
to once
Take
again
picture.
acknowledge
Yeah,
Dr.
can we have a
Kaushik.
picture? Yeah, please. Everybody on stage. Results.
Before you start fighting. So I would like to
Everybody on
acknowledge
stage.
my team here, Dr. Kaushik for making the quiz, Dr. Dipanshu, Dr. Karan, Dr. Ayushi.
And Dr. Aarti. And Dr. Aarti, please.
चलो चलो हम चले
सबको ही बुला लो
Can I get a big round of applause for all the participants? An amazing session. Again, great work by Aarti, Kaushik, Ayushi, and definitely Dipanshu as well. Dipanshu had worked very hard on the videos. So, big Bollywood questions as well. So, I have the results. So, it's very close. It's quite close, okay? So, any guesses who the winner is? So we should definitely thank the judges. They have done a wonderful job, a tough job, है ना? So fourth is Team Dabang. Total being fourth by 212 points. Total points are 212. Team third is Team Bazigar with 213 points. Team second is Team Bahubali with 215 points. And the winner is Team Khalnayak with 230 points. So a big congratulations to everybody and the participants. Trophy हम लोग यो pavilion में देंगे. So can we have a picture here? Picture ले लो. At the same time, I would thank everybody. आप बोल दो सर आपने कुछ नहीं बोला. Vote of thanks करो सबको. देवकांत तो देगा vote of thanks. So thank you everybody, thank you all young ophthalmologists for making this conference extremely good. Thank you for our international guests as well. Thank you CIPLA, thank you AIOS for making it possible. Big thanks to the audiovisual team and everybody who's involved. Lunch is served, we'll see you there. Thank you everybody. See you all at Yo Pavilion.